So with that, all these people who are present here and all those people who are online, so again, my sincere welcome to all of them for today's scientific session. So we'll start with the paper presentation. The first paper is by Dr. Ankit Gulia. She is from DMC Ludhiana. The risk factors, clinical angiographic profile of women with acute coronary syndrome. Dr. Ankit Gulia.
Good morning, sir. Respected seniors, my colleagues, myself, Dr. Ankit Gulia. I am DM Cardio Resident, final year in Dayanand Medical College, Ludhiana. So this was my thesis topic, to study risk factors, clinical and angiographic profile of women with acute coronary syndrome. So we know that ACS is in women is often underdiagnosed due to atypical symptoms and treatment disparities. Menopause adds unique risk like hormonal changes and pregnancy-related complication. Studying these differences is crucial for early diagnosis and better outcomes. The aims and objectives of the study was to study risk factors and clinical profile of women with ACS, to study the angiographic profile of women with ACS. Materials and methods. This prospective case control study was conducted at the DMC Ludhiana from June 2023 to May 2024, including 125 consecutive female ACS patients with 125 age-matched male controls, detailed history, menstrual and obstetric factors, clinical examination, ECG, biomarkers, echocardiography, and coronary angiography were recorded using standard protocol. The result of this study, it includes all the parameters like risk factor, age, any other comorbidity, presentation time to the hospital, whether the patient presented within the 12 hours or after 12 hours or late presentation, and how many patients undergone coronary angiography, they were also included, and those who undergone procedure, this data was also taken. In the most common presentation in the male was NSTEMI, and in female, it was observed in around 21% of the cases, but STEMI was the most common presentation, and among STEMI, the anterior wall MI was the most common. Out of the 125 patients, if we see that loading dose was given in the 100% of the male patients, but it was given in 95% of the female. So this indicates that underestimations of the symptoms or lack of the knowledge of the atypical symptoms with which women present. So loading dose was given in only 95% patients and 5% patients were skipped. On echo showed that there were more LV dysfunction, more valvular complications as compared to the male, indicating that women present with serious complications in ACS. Among the 100 patients, the angiography were more done in the male and less was in the females, indicating that lack of knowledge, lack of financial issues in females. Complications were more common, complications like arrhythmia, cardiogenic shock, VT, VF, This was more common in female and it was less in male. IABP use of mechanical circulatory devices was more common in female. Around 12.8% female received IABP and around 4% of the male received IABP. So this diagram shows, the yellow one shows, this study also included this cohort divided into 3 parts, that there was a general data was taken from 250 patients that was separately analyzed. Then this data was analyzed between male and females for the risk factors and the angiographic profile. Then between the female, there was a substrata that includes premenopausal and the postmenopausal females to see that how the menopausal status affects or the coronary artery disease and its outcome. So the menarche history, post-menopausal history was also taken and it was compared between the females. So between the premenopausal and the postmenopausal female, the postmenopausal female, they have more acute decompensated presentation with ACS, was more with acute decompensated heart failure. Complication was more commonly seen with postmenopausal female, but the thrombolysis was more common in the premenopausal females. Contraceptive use was more common in premenopausal female, and peripartum cardiomyopathy was more common in premenopausal female. Stillbirth. So stillbirth was more common in postmenopausal female. The mean age was of postmenopausal female was around 65 age. So it indicates that there was previously lack of the medical facility. Preterm delivery was more common in the postmenopausal female. Gestational hypertension and gestational diabetes were more common in premenopausal female, indicating the risk factor that these were exclusively or most commonly were seen in the premenopausal female. Normal vaginal delivery was more common in the postmenopausal female, indicating that lack of the medical services, but LSCS was more common in young female, premenopausal female. If we, about the BMI, the premenopausal female were more obese as compared to the postmenopausal female, indicating as a risk factor. The women with ACS showed more RWMA, more MR, mitral regurgitation and complication, while men more often had NSTEMI. Premenopausal women carried higher metabolic risk like overweight, gestational diabetes, gestational hypertension, and greater contraceptive use. Postmenopausal women had more preterm deliveries, stillbirth, and higher rates of acute decompensated heart failure. These findings highlight worse myocardial dysfunction and in-hospital complication in women. Obstetric and reproductive history add to long-term cardiovascular risk in pre- and postmenopausal female. Conclusion: women with acute coronary syndrome face greater myocardial dysfunction and complications with risk shaped by reproductive and menopausal status. Incorporating obstetric history into risk assessment can improve prevention and outcomes. The limitation of the study was it was a single center design with a relatively small sample size, which may limit generalizability. Thank you, sir.
This paper presentation is between pre-menopausal and post-menopausal women, you see, rather than comparing with the men at large, you see.
Sir, this was the data which showed difference between the, this was the significant difference were there, but the study was also included 125 matched male control. Yeah. They were age matched. So there were some differences, but they were not significant, like that the chest pain was more common in the male, around 90%, but in female it was around 70%. There were some atypical symptoms like ghabrat, shortness of breath, shoulder pain. They were more common in the female, sir.
Probably maybe that is the basic reason, because they did not have any symptoms and they presented with more severe complications because being diagnosed at a late stage than an early stage, you see.
Yes, sir, right, sir. Sir, this data was also taken, the time of presentation after symptom onset. It was observed that this study divided that less than 12 hours, 12 to 24 hours, 24 to 48 hours, and more than 48 hours. It was observed that around 40% of the male, those who present with chest pain, they presented with less than 12 hours to the hospital. But female, the data only showed around 25% of the female presented in less than 12 hours. So late presentation was more common in the female.
Because of the symptoms, no? That's
because
why.
of the symptoms, and the one data was more that we are DM residents in the emergency and in a tertiary care hospitals.
Or maybe the inferior sex is ignored, you see, rather than the male sex, you see.
No, sir. But it was observed that in 5% of the patients, those who have symptoms, they were not given the loading dose, sir.
You see, again, this question of loading dose.
Yes.
I mean, all these patients are at your hospital, no? At DMC.
Yes, in my hospital.
So why 95% of the ladies and 100% of men, you see, why the 5% were left?
Sir, because these patients were taken of the only acute coronary syndrome. Some female presented with unstable angina and some with NSTEMI. So, and they have atypical symptoms, like some female presented with inferior wall MI, they have symptoms of ghabrat, sweating, and they have 1 to 2 episodes of loose stool. So they were underrated. That
means the message from your paper is that even people presenting with atypical, particularly females,
yes, sir,
they should also be subjected to the loading dose of thrombolytic agents.
Antiplatelets, sir.
Antiplatelets.
Yes, sir.
Sorry.
And one of the female patient was skipped of loading dose, sir, of these thrombolytic agents, sir.
Okay. Thank
Yes,
you.
sir. Thank you, sir. So nice of you, sir. And we are glad to hear that you organized this MAPICON and we got opportunity to present our paper here, sir. Thank you very much, sir.
Thank you. Thank you. I think next is Dr. Gurleen Kaur. She is again from DMC Ludhiana. The energy crisis within clinical clues to metabolic myopathy. Dr. Gurleen Kaur.
Good morning, everyone. I'm Dr. Gurleen from DMC Ludhiana, JR General Medicine. Introduction. Metabolic myopathies are a heterogeneous group of disorder characterized by defects of enzymatic pathways involved in myocyte metabolism. MM manifests with exercise intolerance, muscle cramps, myalgias, rhabdomyolysis, or myoglobinuria and are sometimes asymptomatic also. Classically, metabolic myopathies encompass glycogen storage disorders, fatty acid defects, and mitochondrial disorders. Glycogen storage disorders present within minutes of high intensity exercise like weightlifting or sprinting, whereas fatty acid oxidation disorders and mitochondrial myopathies present after prolonged low intensity exercise. So here we report a case of young boy with intermittent history of proximal weakness for 4 years before MM was diagnosed. He presented to us in the Department of Neurology. Patient presentation. A 14-year-old boy presented with complaint of bilateral lower limb weakness with pain in thighs for 15 days following exercise. He also noticed that there was partial improvement in his symptoms with continued exercise. Next day when he woke up, he experienced difficulty in standing from sitting position and climbing stairs. There is no history of upper limb and cranial nerve involvement, no sensory or bladder dysfunction. He recalled similar episode of pain in thighs along with bilateral lower limb pain 4 years ago while playing cricket. During that time, there was spontaneous improvement with no residual deficit and he continued to play. There is no family history with normal nutritional history. Clinical examination, journal physical examination was normal with no skeletal abnormality. Chest CVS examination was normal. In CNS examination, higher mental functions and all cranial nerves were normal. Motor system examination showed no atrophy or hypertrophy of muscles. Normal tone, proximal muscle weakness in bilateral lower limb graded 2/5 on MRC scale. Distal muscle power was preserved. Deep tendon reflexes and sensory examination were normal. Investigations. The routine investigations like CBC, RFT, LFT, TSH, calcium, phosphorus, magnesium, they all were normal. Vitamin D3 levels, CPK levels, uric acid levels and cholesterol levels were too normal. Urine examination revealed no myoglobinuria. The NCV-EMG study was done suggestive of myopathic pattern with no spontaneous activity. In view of these two intermittent episodes of muscle weakness, possibility of metabolic myopathy was considered. Hence, forearm exercise test was performed for 1 minute. Pre-exercise and post-exercise lactate and ammonia levels were sent. Pre-exercise lactate and ammonia levels were 1.12 millimole per liter and 23 micromole per liter respectively. Post-exercise, there was no significant rise in lactate and ammonia levels. They were 1.34 millimole per liter and 14 micromole per liter respectively. His blood samples were sent for genetic testing for PYGM gene mutation, which revealed mutation on chromosome 11q13, exon 1, heterozygous nonsense type of variant. So basically in this forearm exercise test, baseline sampling was done for lactate and ammonia levels. The patient was asked to hold bowl for 9 seconds and then release for 1 second and repeat the same cycle for 1 minute. Post-exercise lactate and ammonia levels were set. Normally these levels should rise by threefold, but there was no rise by threefold suggestive of metabolic myopathy. So management and outcome, patient was managed with supportive treatment and his condition improved gradually. He was told to take high carb diet and he was told about second wind phenomena and he was told to just do moderate graded aerobic exercise. On follow-up after 6 months, his muscle power improved to 5/5 on MRC scale. Discussion. The above clinical history with investigations are suggestive of myocardial disease, glycogen storage type 5, rare inherited metabolic disorder with an autosomal recessive inheritance pattern. This case highlights the importance of history in delineating the diagnosis of metabolic myopathy even with normal CPK levels. The bedside forearm exercise test clearly showed glycogen storage disorder. Later, the diagnosis was confirmed with genetic testing. In myocardial, there is deficiency of muscle glycogen phosphorylase, the enzyme, which is responsible for breaking down glycogen into glucose, which is the energy source for muscles, resulting in accumulation of glycogen in muscle tissues. This forms the basis for forearm exercise test. In our patient, another diagnostic characteristic finding noted was second wind phenomena, which is characterized by improved symptoms after prolonged exercise, typically observed in GST. Though there is no specific treatment, but dietary interventions, including high carbohydrate intake before exercise, moderate intensity graded aerobic exercise therapy can help in managing the symptoms. So the learnings, metabolic myopathy should be considered in the differential diagnosis in young person with episodic weakness. A careful history and a detailed clinical approach will help in narrowing down the differentials among the multiple biochemical pathways involved. Though rare, these disorders can be accurately and efficiently diagnosed if the key clinical features are kept in mind. Thank you.
Thank you, Dr. Gurleen. I think you haven't mentioned about the family history, you see. I thought, you see.
I mentioned, sir, there was no family history.
But you can still get sporadic cases of myopathy without any family history.
Yes, sir.
Of glycogen storage disease?
Yes, so the parents maybe
Carrier.
they didn't show other symptoms basically. They can be the carriers, sir.
So you reach the diagnosis, or your department reached the diagnosis because most of the investigations were normal.
Yes, sir.
That's why probably they made you to think about the glycogen storage disease.
Yes, sir. They ruled out other causes and dystrophism.
Because familial periodic paralysis probably is more common, you see, than what we see, like glycogen storage or other myopathies.
Yes, sir.
Thank you. Nice presentation. Thank you.
Thank you, sir.
Next is Dr. Harleesh Gupta, again from DMC Ludhiana, to compare the safety, tolerability and efficacy of Denosumab and aldosterone CKD3 5D patient with osteoporosis. Dr. Harleesh Gupta. Sorry. Okay. So sorry, Dr. Harleesh is not there. So next is Dr. Parul. Again, she is also from DMC Ludhiana. So she is going to present her paper on Cologastric fistula area presentation of coronary cancer. Dr. Parul, please.
morning, everyone. Myself, Dr. Parul from DMC. My poster for today is Cologastric fistula, a rare presentation of colonic carcinoma. Cologastric fistula is an abnormal communication between the stomach and the colon. Etiologies include malignancies, colon cancer in the west, gastric cancer in the east, Crohn's disease, complicated diverticulitis, and penetrating gastric ulcers. It is exceedingly rare and with a reported incidence of less than 0.5% and often poses a diagnostic challenge due to its non-specific presentation. I report a rare case of cologastric fistula secondary to mucinous colonic adenocarcinoma and highlight diagnostic and therapeutic considerations. So I have a 66-year-old male with postprandial diarrhea and passage of undigested food for 6 weeks. Associated symptoms were reduced appetite and 10 kg weight loss. Clinical findings included patient was pale, emaciated with a BMI of 19 kg per meter square. Lab results were suggestive of microcytic hypochromic anemia and hypoproteinemia. Colonoscopy was suggestive of a ulceroproliferative growth at splenic flexure. The scope unexpectedly passed into upper GI tract, as we can see in the figures B to D. We can see the presence of gastric rugae, pylorus, duodenum, and bile. Cologastric fistula was further confirmed by contrast-enhanced CT enterography. Patient underwent a radical left hemicolectomy along with gastric wedge resection, diaphragm repair, and loop ileostomy. Histopathological examination confirmed the presence of mucinous adenocarcinoma of colon with all resected margins free of tumor. The disease was staged as PT4 NOM0, stage 2 according to AJCC UICC criteria. Post-operatively, the patient showed marked clinical improvement with complete resolution of diarrhea and a weight gain of 3 kg over 2 months. In view of the staging and favorable recovery, adjuvant chemotherapy was not administered. Discussion: cologastric fistula due to primary colonic malignancy is a rare entity. Its diagnosis is often delayed due to non-specific symptoms and rarity. Colonoscopy and imaging are key to diagnosis, and CCT enterography is confirmatory. Radical en-bloc surgical dissection remains the mainstay of treatment, especially in the absence of distant metastasis. Conclusion: colonic adenocarcinoma presenting as cologastric fistula is rare but important to recognize. Early diagnosis and radical surgical intervention are crucial to reducing morbidity and improving survival outcomes. A high index of suspicion is essential in patients with unusual gastrointestinal symptoms and underlying malignancy. This case highlights the importance of considering cologastric fistula in the differential diagnosis of colon cancer. Thank you.
Thank you. Again, I don't think there's many questions on this sort of this cologastric fistula. Probably it is the diagnosis of colonoscopy, you see.
Yes,
I mean,
yes, sir.
it's not a clinical diagnosis.
No.
The other thing is, you see, people having, it depends upon where is the cancer in the colon, you see. If it is close proximity to the stomach, probably there are high chances that probably the patient will end up with a fistula.
Yes.
Suppose it is at the end of the descending colon, you see, there are unlikely chances of having a gastric fistula.
Oh, sure,
So it's basically colonoscopic diagnosis and then surgical management, as you told, you see.
Yes.
So why you mentioned diverticulitis? I don't think diverticulitis will cause a gastric fistula.
Less likely. Diverticulitis will be lower down.
They are too far away from
Yes.
the stomach, no?
Yes, sir.
So probably that doesn't come under the differential diagnosis of gastric fistula. Anyway, thank you very much. Next, Dr. Sakor DMC Ludhiana, rare case of primary sclerosing cholangitis with IgG4 positive and hypereosinophilic syndrome.
Good morning everyone. Today I am going to present a rare case of primary sclerosing cholangitis with IgG4 positive and hypereosinophil syndrome. Introduction. Primary sclerosing cholangitis or PSC is a chronic cholestatic syndrome that is characterized by diffuse inflammation and fibrosis involving the entire biliary tree, resulting in chronic cholestasis. The obliteration of both the intra and extrahepatic biliary tree leading to biliary cirrhosis, portal hypertension and liver failure. PSC is generally believed to be an autoimmune disease detected in 30 to 40-year-old male patients which attack the immune cells of biliary ducts leading to scarring and ultimately blockage of the biliary system. Case report. A 36-year-old male known case of IgG4 plus related PSC presented with anorexia, jaundice, abdominal pain and elevated LFTs. Upon presentation to the clinic, his AST was 41, ALT was 64 and ALP was 334 with elevated serum bilirubin of total to 7.6 and direct 7.1. ESR was raised to 120, serum IgG4 plus levels were raised to 28.5. Autoimmune workup as well as serologies for hepatitis A, B and C were negative. Ultrasound abdomen showed irregularly dilated intrahepatic biliary radicals with organized sludge throughout extent of common bile duct. Magnetic resonance cholangiopancreatography revealed intrahepatic bile duct dilatation and common bile duct calculi with loss of lobulations of pancreas showing hyperintense signal. ERCP was done which showed CBD stricture and CBD double pigtail stent was placed. CBD brushings showed no risk of malignancy. Bone marrow was done which showed hypercellular marrow with prominence of eosinophils. Management. Patient was started on mycophenolate mofetil and oral steroids for IgG4 related sclerosing cholangitis. In view of obstructive jaundice and cholangitis, broad spectrum IV antibiotics and CBD stenting was done. Discussion of the case. IgG4 associated cholangitis akin to primary sclerosing cholangitis is steroid responsive and more prevalent in males. The presentation is often includes obstructive jaundice with elevated IgG4 levels aiding diagnosis. Differential diagnosis is crucial, distinguishing it from conditions like cholangiocarcinoma. Diagnosis requires a multidisciplinary approach incorporating serological, histological and imaging techniques. Treatment involves high-dose corticosteroids or immunosuppressants, both effective in inducing remission. Despite common relapses, proper management reduces the risk of liver failure and malignancies, rendering IgG4 associated cholangitis typically benign. Conclusion of the case. IgG4 related cholangitis presents diagnostic challenges but early recognition and treatment initiation, including corticosteroids or immunosuppressants, are crucial for symptom control and disease management. With proper care, prognosis is favorable.
Thank you. What made you to do the bone marrow, you say? Why you suspected to do bone marrow on this patient?
So bone marrow and brushings were taken to rule out any malignancy because of the
malignancy.
Yes, sir. Because of the
blood,
similar
blood, you mean
symptoms.
the blood malignancy, blood cancer. You mean?
Yes, sir.
Okay. So how rare is this one? The case you have presented?
So very rare. I have seen only one case in my 3-year.
You are too young to see only one case.
Yes,
you
sir.
say.
Yes, sir. Maybe in coming
one,
years.
one for you is a big number.
Yes, extremely rare, sir.
Okay, thank you.
Thank you, sir.
And the last paper to be presented is by Dr. She is from GLC Amritsar. Surgical section of Mucinous Ovarian carcinoma presenting as post-menopausal bleeding. Dr. Diksha.
Good morning, everyone. My topic is surgical resection. I am Dr. Diksha Singla from GMC Amritsar. My poster topic is surgical resection of mucinous ovarian carcinoma presenting as post-menopausal bleeding per vaginum. Mucinous ovarian carcinoma is a rare malignant ovarian cancer. Occurrence of less than 3% of ovarian cancer occurs in women under the age of 40 years. Mucinous ovarian carcinoma is a subtype of epithelial ovarian cancer, sporadic in origin, mucin producing. It could be primary or metastatic CA. 80% are metastatic, with most common primary GI cancers. Diagnosis is challenging, relying on histopathological examination and immunohistochemistry. Treatment for early disease staging, it depends upon the staging procedure, and for advanced disease, cytoreductive surgery is performed, followed by adjuvant chemotherapy. Case report: 68-year-old menopausal female presented in gynae OPD with on-off of vaginal bleeding for 2 months. On gynecological examination, cervix was normal. On pervaginal examination, cervix high up and uterus not palpable. MRI pelvis performed, it showed well-defined cystic lesion with internal septations in left adnexa, not separate from left ovary. Omental thickening with nodularity seen. Case was referred to the surgical oncology department. CECT abdomen of the patient done. CECT abdomen indicated pelvic abdominal complex cystic mass showing enhancing septae and nodularity in omentum. Tumor marker study done. CA 125 came out to be 202 and CEA came out to be 1074. On this basis, a diagnosis of stage 3 mucinous ovarian carcinoma was made. In surgical oncology department, she underwent exploratory laparotomy under GA, and on opening the peritoneum, large amounts of mucinous jelly-like material was seen, as you can see in the image. This is the image on this surgery table. Total abdominal hysterectomy plus bilateral salpingoophorectomy plus omentectomy plus appendicectomy was done. Histopathological examination of the specimen sent revealed well-differentiated mucinous ovarian carcinoma as shown in the image with peritoneal and omental implants. Patient post-operatively was planned for adjuvant chemotherapy. Discussion, history taking, radiological examination and IHC revealed it to be a case of ovarian cancer, which later on post-op histopathological examination suggested it to be mucinous ovarian carcinoma. IHC plays an essential role in diagnosis. CEA most valuable in detecting mucinous ovarian carcinoma preoperatively. CA 125, CK7, CA 199 are other tumor markers. It can be primary or metastatic. Primary can be confluent or infiltrative type. Primary mucinous ovarian carcinoma, certain molecular alterations are present like KRAS mutation, TP53 mutation, and HER2 amplification. Most frequent primary site for metastatic carcinoma is GI malignancies. Clinical staging is achieved by CT or MRI abdomen and pelvis with contrast. Lymph node involvement is rare in this. Surgery is the mainstay of treatment, that is total hysterectomy, bilateral salpingoophorectomy, omentectomy, peritoneal biopsy plus appendicectomy, followed by adjuvant chemotherapy. Conclusion. As per the clinical case scenario reported and documented, this is a rare case of primary mucinous ovarian carcinoma of infiltrative type. Advanced stage is associated with poor prognosis due to poor outcomes with platinum-based chemotherapy. Surgery is the mainstay of treatment. Amount of residual disease after surgery is the most critical factor in prognosis. Thank you.
Thank you. I think the standard teaching is that particularly elderly female post-menopausal bleeding, I think the first thing that comes to your mind is always to rule out malignancy. And in your case also, say the malignancy was there from all the markers and the CT and all that, but I think the mucinous diagnosis was only from the histopathology rather than the clinical diagnosis of your case.
So from gross examination we can also it is jelly like OTTable.
You still following the patient, or the patient is not on your follow-up?
So no.
You don't know. Surgery done, chemotherapy done, but you don't know what is the outcome.
Sir, itna follow-up ke liye.
Okay. Dr. Seema, please.
What was the presentation of your patient?
Patient presented with bleeding per vagina.
No distension of abdomen?
जिसमें abdominal distension.
The primary
Ma'am,
complaint.
but there is a pattern in older females. They ignore, like, ma'am, in our surgical oncology departments, patients come with tumors of like 20 kgs, 25 kgs. But they don't tell their family and they ignore it.
Because it was so slow growing tumor.
Yes, ma'am.
Right. What is Meeks syndrome?
Meeks syndrome, ma'am, there is 3 symptoms are present.
Yeah,
like,
yes.
Yes, ma'am, fibrosis and pulmonary involvement.
Your patient have CEA raised. What are the other condition in which CEA will get raised?
Ma'am, in GI malignancies it can be
GI,
raised.
especially colorectal carcinoma.
Colorectal carcinoma.
Adjuvant chemotherapy followed by adjuvant chemotherapy. So what is?
Cisplatin-based chemotherapy.
Okay, it is adjuvant. That means something combination.
No, yes, after surgery.
Okay. Followed by, maybe it is chemo with immuno, maybe chemo with radio.
Yes, ma'am.
She doesn't know the follow-up.
Okay, no, doesn't know.
Thank you. Sir, surgical oncology में patient है.
Achha, you are from surgery department? Okay.
Surgery oncology.
Yes. हाँ जी, सर वो 1 month posting.
इसीलिए follow-up नहीं होगा.
So the substance was mucinous and jelly-like,
Yes, ma'am.
and it gets solidified when you open it,
Then, no, it doesn't solve.
not solidified. Okay. क्या weight कितना था इस tumor का?
10 to 15, 12 kgs.
Big
No,
tumor.
patients come with 20-25 kgs, but this was 10 to 12.
Okay.
आपकी जो 1 month पोस्टिंग थी इसके दौरान पेशेंट आया था
नहीं,
आपने सिस्ट किया था सर्जरी
हाँ जी,
अपने ओटी में साथ
yes,
में
yes.
So try to keep the follow-up also. Thank you.
Thank you all the poster presenters. Now we are going to start our regular scientific session, and with the efficiency of our speakers as well as the organizing committee, we are dot on time. And I must apprise you that first day was watched by 500 doctors on YouTube and 150 online or our virtual platform. So it is a great honor for us that 650 doctors watched the first day's proceeding, and we have shared the second day's YouTube link as well as Zoom link also. So whosoever is getting, please share with your friends and colleagues so that more and more people come to know about MAPICON. So I am greatly honored to start the second days of scientific program. So I invite Dr. Noria to please moderate the first session.
Thank you, Dr. Vittal. At the onset, once again, I welcome you to all for the second day of the scientific session of MAPICON 12th edition. To start with, the first lecture is by Dr. Arun Bansal. He is going to talk about behind the smile. So what is there? That is unseen struggle of the student mind. So very, very sort of a topic, you see, concerning all the students, you see, probably the psychiatric illness, the depression and anxiety and all these factors day by day are on the increase. And Dr. Arun is going to tell us all about his topic. Dr. Arun, please. Thank you.
Good morning, everyone. First of all, I want to thank you, Dr. Vittal sir, for giving me opportunity for talking on this very important topic. As you know, behind the smile, unseen struggles of student mind. Behind every cheerful student lies a story that often goes unheard. Academic pressure, family expectation, peer comparison, these factors weigh heavily on a student's mind. Today we will shine a light on these hidden struggles that make a real difference in helping students lead healthier and happy life. This is the agenda of my today's presentation. Suicide is a silent epidemic. Suicide is now a leading cause of death. India is the leading cause of death among young Indians between 15 to 29 aged. This presentation explores the death, uncovers the root cause, and calls for urgent action to build safer and more supportive system for our youth. It's look to beyond grades and recognize the emotional toll our system impose. Especially in India, we look beyond only grades. We look on grades, not beyond grades. Suicide. This is the data released by NCRB in 2022, which records the total number of approximately 1,71,000 suicide, marking 4.2 increase from 2021 and significant jump from 2018, which is 1 lakh people reached an all-time high of 12.4 in 2022. Suicide rates are rising at a rate of 4.2 annually, which is a double national average for overall suicide. The national average is 2% overall suicide, but students' suicides are rising at a rate of 4% annually. Over the last decade, the number of suicides has nearly doubled, which were approximately 6,600, and now in 2022, which is 13,000 approximately. These are just a data. Key comparison between student suicides and farmers. A tragic crossover. In 2022, student suicide has crossed the farmer suicide, which were 13,000 in 2022, and farmer suicide were 11,000 approximately. The underlying factors among student suicide is academic pressure, exam anxiety, lack of mental health are the key drivers. And among farmers, as you know, financial distress, climate-related crop devastation, latest is floods. Now come to the common root causes of student suicides. Main is the academic pressure and toxic competitiveness. Unyielding academic pressure places a severe burden on students' mental health. High-stake exams often define a student's worth based on a performance on a single day, like NEET exam, IITs. Fear of failure in one exam has tragically led many students to take their own lives. As one expert put it, we prepare them for exams, not for life. The narrow definition of success. Parents and society have a lofty aspiration for students' academic performance, frequently equating it with future employment opportunities and social standings. For students, the competitiveness in India's educational system is a very stressful and difficulty component. Societal and interpersonal factors affecting students' mental health. Academic stress, toxic environments, relationship issues, financial instability, and social isolation are common stressors. Young women faces added challenges like gender-based violence, societal restrictions, and discriminations. Rural areas often lack safe spaces and support systems, worsening mental health struggles. Unfiltered exposure to social media, special reels can lead to mental imbalance and impulsive behavior. Ragging, still the hidden threat is in higher education. Behind campus walls, ragging and bullying still persist, often masked by institutional silence and reputation management. These practices violate student dignity and undermine their right to a safe learning environment. The state has a duty to ensure access and safety at entry level. Still, the caste discrimination on campus is a plague at India's top-level institution, leaving marginalized students feeling isolated and unspotted. Lack of safe spaces and cultural sensitivity worsens the mental toll on marginalized students. Strict anti-discrimination policies, faculty training, and inclusive support system are essential to dismantle systemic bias and ensure every student feels seen, safe, and valued. Some are institutional gaps and failures in student mental health. The current educational system is often labeled score-centric and empathy deficient. Mental health support in institution is frequently inadequate and missing altogether. Stigma around mental health. Supreme Court has acknowledged the inadequate and ineffectiveness of existing legal and institutional framework. There is an urgent need for systemic reform to prioritize students' well-being alongside academic mental well-being. This is a cutting from famous newspaper. The important in this is warning signs of suicide. Isolation from family and friends, self-harm, drastic change in mood and behavior, changes in sleep and eating habit, drug and alcohol use, engaging in risking behavior, showing less interest in activity they previously enjoyed. These are recent tragedies. Just in September 2025, BITS Plani in South Goa campus, a 5th student suicide in 10th month shook the campus, spotlighting deep-rooted issues in institutional support. In IIT Delhi, Supreme Court's task force was born from plea by families of 2 students who died by suicide, proof that even elite institutions are not immune. In Kota, Rajasthan, India's coaching capital remains a pressure cooker. In 2024 alone, 17 students died by suicide. One tragic case in March 2025 involved an 18-year-old JEE parent who ended his life just before his exam. The recent suicide of 14-year-old Ashir Nanda, a class 9th student of Kerala, has sent shockwaves through parents and students. It also raises urgent questions about administrative policies, student mental health, and the responsibility of educational institution. Some are other suicide news. The latest one is in May 28th, last one, of class 12 girl student hanged herself and died since he could not get high mark her plus 2 examination near Tamil Nadu. Well, there are many examples. Well, every 40 seconds suicide happens. This is the responsibility of government and the government and institutions response. There is a bold movement by Supreme Court. In March 2025, Supreme Court of India declared a rising student suicide a suicide epidemic and launched a national task force to confront the crisis head-on. Led by Justice S. Ravindra Bhatt, the task force brings together top minds, psychiatrists, professors, legal experts, and officials to investigate root causes, evaluate current policies, and recommend urgent reforms. Latest action, a new website with anonymous survey has already drawn over 1 lakh responses from students, parents, educators. Nodal officers appointed across all states and UTs. Ground level visits underway to assess real conditions. Interim findings drop in end of September, with the final report expected by the year end. Till date, the interim report has not came. Supreme Court's landmark guideline for student safety, mental health, and suicide prevention. Supreme Court issued 15 national-wide guidelines to address student suicide, mental health, and safety in educational institutions. This follows a case involving the death of 17-year-old NEET aspirant in Andhra Pradesh. A CBI investigation was ordered and interim measures will apply until formal laws are enacted. Key guidelines are uniform mental health policy, qualified mental health support, institution with 100 plus students must appoint trained counselors or psychologists. Smaller institution should create referral linkage, optimal student counselor ratio, no batch segregation or academic shaming. This is very important. Avoid dividing students by performance or shaming them. Academic target should be realistic and personalized. Referral systems and helplines, physical safety measures, install tamper-proof ceiling fans, restrict access to rooftops, balconies, and other high-risk areas. Special focus on coaching hubs, mandatory staff training, harassment and assault reporting, ensure accessible confidential reporting system, applicability across institutions, support to national task force, annual reporting, career counseling for students and guardians. Now next, what is call for action? India's suicide crisis demands more than sympathy. It needs system change. Underreported and misunderstood. Suicide data may be vastly underestimated due to stigma even after decriminalization. Support the signs early. Train parents, teachers, and peers to recognize distress. Creative programs like Tamil Nadu Stops, school-based interventions using theatres of the oppressed for prevention of suicide are paving the way. Redefine success, move beyond the exam scores, build role models and safety nets for students under pressure. Empower institution, college must offer integrated mental health care and teach emotional resilience. Strength support, boost awareness of service like Telemanus helpline, which has fielded over 1.8 billion calls but remain underutilized. Many more helplines are there like Roshni and many more, but still underutilized. As a psychiatrist, I believe preventing the increasing rate of student suicide is a significant and complex challenge that requires the coordinated efforts of schools, parents, communities, and mental health professionals. By raising awareness, addressing stigma, and ensure the availability of comprehensive support system, we can work together to create a safer, more supportive and nurturing environment where students feel empowered to seek help and thrive. Thank you.
Thank you, Dr. Arun. A very hot and burning topic which needs the attention of all of us. And to my mind, you see, the experience says that the student of first year and the student of fifth year, you see, starting from first year onwards, the incidence or the rate or the prevalence of suicide, as the year goes by, it starts increasing. And by the time they are in final year or they are in their internship or house job, probably the rate is much more higher than when they start their career at the medical college. Maybe the reason is again peer pressure, financial stress, or the stress of the academics.
Yes, sir. Yes, sir.
I think these are the important factors. What I feel strongly, that all the institutes, whether it's a medical or non-medical, once a week, sort of a session of counseling.
Yes, sir.
By the experts, so that even if you don't need it, there should be counseling to each and everybody, so that at early stage we can counsel the people who are vulnerable for suicide.
Recognizing of early signs.
Yeah, early signs. And number two is all the friends of the person, whom they think he is aloof, he is alone, and these are the early signs, They should always try to talk to him and have to spend more time with them, so that it is always a time, the suicide is only a time. Once the time is over, probably all the things are over. So that's my feeling is.
Yes,
Dr. Arun, suicide is the second most common cause in young students, right? And AIMS and IITs, they have very high incidence of the suicide. I am faculty from AIMS Bhopal. So at my personal level, what precaution I have to take for my student?
Every suicide is preventable.
Yes, because few days before there was a suicide prevention day, so we organized a good CME.
10th September.
Yeah.
World
So
Suicide
yes, suicide prevention day. So it itself means suicide is preventable, and with one successful suicide, there is behind 28 attempts before that.
Everybody knows the early signs. We should teach, every teachers, parents should know the early signs of, recognize early signs of mood, change in the mood, behavior. If person is cheerful and he changes his habits and we seen the changes in mood and change in habits. Then
Dr. Arun, actually in AIMS Bhopal,
patient shows the signs of, talks about death which is, we should not ignore that things.
एक्चुअली वर्कलोड इतना ज़्यादा रहता है कि एक स्टूडेंट वो हमेशा ही प्रॉब्लम में रहते हैं.
परसों की बात ये है, आई वाज जस्ट गोइंग थ्रू द सोशल मीडिया. परसों लखनऊ में एक 13 साल के बच्चे ने सुसाइड किया है. उसने ऑनलाइन गेम में फादर के सारे पैसे उड़ा दिए. तो उसने डर के मारे हैंग कर लिया फाइनेंशियल, तो मतलब डर के मारे सुसाइड कर लिया. उसने घर में बात नहीं की. तो इवन तो आई डोंट, तो कल जस्टरडे मेरे किसी ने पेशेंट ने सुसाइड किया मेरे चिल्ड्रन. हाँ, मतलब 13 साल के बच्चे. अब जिस सुसाइड की जो एज है, मतलब आई वाज टॉकिंग 15 to 29 में बात कर रहा था. तो सुसाइड की जो मतलब वो एज और कम हो रही है, नॉट 15 to 29 और 13 के उसके आ गई है अभी.
पहले था कि 17 to 27.
हाँ, 15 to 29 बात कर रहा, 13 ईयर्स पे आ गई है और बिलो आ रही. बच्चे जल्दी मैच्योर हो रहे हैं सोशल मीडिया के कारण, उस पर पढ़ रही है. बट 12 ईयर 13 ईयर, वो एक केरला में बात बता रहा था मैं, स्कूल का बच्चा सुसाइड कर रहा है. मतलब और नीचे आ रही है, बच्चे जल्दी मैच्योर हो रहे हैं. मतलब सोशल मीडिया वो रील से देख रही है, जो ऑनलाइन गेमिंग है, जो टास्क दे रहे हैं ब्लू व्हेल गेम, आपने ऐसा करना है, जंप करना है, मतलब जो ऑनलाइन गेमिंग है वो सारा यही चीज़ें हो रही हैं.
In my institute we have a very good wellness center and वहाँ पर counselor and psychiatrist are available 6 to 10 in the evening. So उसके बाद जब से ये wellness center open हुआ है, एम्स में suicide rate बहुत कम हुआ है. तो I think that is a good initiative and we should engage all the student in sports activity. बिल्कुल, क्योंकि sports activity से failure acceptance आता है. तो जब फेल्यूर का एक्सेप्टेंस रहेगा तो सुसाइड अल्टीमेटली थोड़ा सा कम होगा.
एंगेज अभी जैसे मैंने कहा, टेम्पर मोस्ट कॉमन मेथड इज हैंगिंग. तो उसमें एक नए मतलब एक स्टडी हुई है उसमें आईआईटीज़ में, तो फैंस डिफरेंट टाइप के फैंस लगाने का हुआ है. टेम्पर प्रूफ सीलिंग फैंस. फैन में स्प्रिंग्स हैं, आप फैन में लटके तो फैन नीचे आ जाता है.
मतलब
तो
फैन से पॉसिबल
नहीं होगा. तो जब फैन में एक अलार्म सिस्टम आ गया, जैसे वो हैंग करेंगे हॉस्टल में फैन, तो अलार्म वार्डन के रूम में अलार्म देगा. मतलब जैसे सर भी वो फैन स्प्रिंग टाइप सिस्टम है. चलो
हॉस्टल्स में यूज कर सकते हैं.
सुप्रीम कोर्ट ये देगा, मतलब इसमें सुप्रीम कोर्ट ने एक अच्छा बनाया उसमें टास्क फोर्स में. ये चीज़ें आगे आ रही हैं. चलो कुछ ना कुछ मतलब जितना हम प्रिवेंट कर सकें सर. जो रेट है 12.4 है, उसको जस्ट कम डाउन ले आए जैसे भी. चलो वी कैन डू मच बेटर.
डॉक्टर अरुण, नाइस प्रेजेंटेशन. एक्चुअली मैं ये कहूँगा कि जस्ट नॉट सुसाइड तो चलो बहुत एक्सट्रीम हो गया, अदरवाइज भी जो मेंटल इलनेस है ना, स्ट्रेस है, वो स्टूडेंट में ज़्यादा इंक्रीज हो रहा है. सुसाइड तो चलो तो बिल्कुल लाइफ ही एंड होगी ना, और तो अल्टीमेट है. और इसका रीज़न सोशल मीडिया तो है ही है. वन ही सोशल मीडिया. जो स्टूडेंट मिक्सअप तो होते ही नहीं है ना, उनके फ्रेंड सर्कल, उनका फेसबुक पे फ्रेंड्स हैं, उनके इंस्टाग्राम पे फ्रेंड्स हैं, फिजिकली उनके फ्रेंड्स ही नहीं है ना, बातचीत वो करते नहीं है.
रियल लाइफ में वर्चुअल है.
बिल्कुल. तो ये है. कॉलेजेस में वैसे मैम पूछ रहे थे कि व्हाट शुड बी डन. आई थिंक एक तो मैंने मेंटर मेंटी जैसे सिस्टम है ना, दिस इज़ आई थिंक वेरी गुड सिस्टम. अभी एनएमसी ने 1:3 रेशो के साथ शुरू किया है. सो हाँ, वो मेंटर मेंटी भी देखो, क्योंकि टीचर्स के पास भी इतना टाइम नहीं होता. बट नाउ जैसे एनएमसी ने प्रपोज किया है मॉडल 1:3 वाला, तो 1 टीचर 3 स्टूडेंट, बट इट विल बी लॉन्गिट्यूडनल प्रोग्राम. नॉट जस्ट लिमिटेड टू द फर्स्ट ईयर, सेकंड ईयर 3 और आ जाएंगे, फिर 3 और आ जाएंगे, 3 और जाएंगे, इसमें बड़ी प्रोग्राम हो जाएगा. इट्स ए बड़ी प्रोग्राम आल्सो. सो सीनियर will peer mentoring the junior and then it's longitudinal program. तो आई थिंक आई होप कि इससे थोड़ा एडवांटेज मिलेगा. बाकी स्टूडेंट को एक्स्ट्रा करिकुलर एक्टिविटीज़ में इन्वॉल्व करना चाहिए, स्पोर्ट्स वगैरह में उनकी एनर्जी वहाँ पे यूज़ होए. ठीक है
सर, आप स्पोर्ट्स एक्टिविटी करोगे ना, वहाँ भी आधे लोग मोबाइल पे बैठे होते हैं.
उसमें मैडम आई थिंक इफ द टीचर्स आर लाइक यू बोथ, half of the stress of students will go otherwise without any mental program or anything. So we need to educate the teachers as well as parents how to de-stress. क्योंकि आप जितना मर्जी काउंसलर कर लो, वो जाके ये नहीं बोलेगा कि मेरे बॉस मेरे को तंग करता है, ये करता है, because he has fear that might be communicated to my boss. So it is the behavior of your teacher, of your parents, which is going to instill confidence in them कि यार अगर मेरे से गलती हो भी जाएगी तो my parents will support and make me understand not to do it again. So I think that is the most important part. So we must include the stakeholders to de-stress the students as well as children. So very nice talk, really great topic, Dr. Arun, and you have justifiably, you can say, put forward your point that we should tackle the student stress, and it is going to become, it has already become a public health issue. Yes, mental issues in the children, or you can say students. Thank you very much.
Public health issue to ho hi gaya once you start comparing with farmer suicide.
Yes, sir.
Okay, thank you. Next speaker is Dr. Jagrup Singh. He is a medical officer, medical specialist, Civil Hospital, Bathinda. His topic is fibromyalgia. Friends, fibromyalgia is not an uncommon condition, but I feel most of the physicians probably, or even the general physicians, it's a very neglected sort of a entity, and I hope Dr. Jagrup will justify his topic on fibromyalgia. Dr. Jagrup, please.
Thank you, sir. Thank you, sir. Thank you. Good morning to all of us. And I am highly thankful to MAPICON organizing committee for providing me this opportunity to bring this scientific topic of fibromyalgia. Fibromyalgia is quite a common occurrence in the OPD, but it is least tested and least diagnosed entity, and usually such type of patient land up in the definition of vague complaints, and they are treated with vague medications, and a targeted approach is definitely needed to diagnose the fibromyalgia. By definition, fibromyalgia is characterized by the chronic widespread musculoskeletal pain and tenderness, which is present all over the body, and fatigue is the second most common feature of the fibromyalgia. There are other overlapping functional symptoms like unrefreshing sleep, cognitive dysfunction, anxiety and depression. As far as epidemiology is concerned, it is present in up to 2% in the general population, but the community-based survey has estimated a prevalence of around 5%. Predominantly affects the females with the ratio of female to male is 9:1, and it is associated with considerable distress at personal level and economic and social burden at societal level. There are certain risk factors that has been attributed for the development of the fibromyalgia. As per the study conducted in relation to the fibromyalgia, there are psychological conditions such as somatization, mental disorder, presence of psychological stress, major depression, generalized anxiety, panic disorder, familial major mood disorder. In addition to the psychological aspect of the fibromyalgia, there are certain genetic association, infections, physical trauma and stress. Pathogenesis of the fibromyalgia is poorly understood. In all the studies, they indicate that the pain perception of the fibromyalgia is maladaptive. And the most common maladaptation is increased sensitivity or hyperresponsiveness to the pain, often manifested as allodynia or hyperalgesia. Peripheral sensitization is reduction in the threshold and increases responsiveness of the peripheral ends of the nociceptors. There is central sensitization that leads to increased neural excitability in the CNS that causes the increased sensory stimulation of the pain. There is also a role of hypothalamic pituitary adrenal axis dysfunction. Clinical features, as we are looking at the picture, the symptom of fibromyalgia is there is widespread pain. Pain all over the body is the common clinical symptom that patient presents with. Fatigue is the second most common. Sleep disturbance is also a hallmark of the diagnosis. Depression is very common. The hypersensitivity, that is allodynia and hyperesthesia to the pain, and there is cognitive loss in the form of memory loss and difficulty in concentration. Clinical feature by discussing all in one by one. Pain is, as I have discussed, that persistent and widespread pain. Patient commonly reports as pain all over the body, typically above and below the waist and both sides of the body, and involve the axial skeleton as well. Pain is poorly localized, difficult to ignore, and severe in intensity, and it is associated with reduced functional capacity. Allodynia and dysesthesia complain of body swelling, but there is no objective swelling on the examination. Early morning stiffness is present, but it is not mandatory for the diagnosis. Fatigue is the second most common symptom of the fibromyalgia, present in 80 to 90% of the patient. Patients generally have poor tolerance to the physical activity, including the exercise. Patient complain of completely washed out. Sleep is the most important, one of the most important aspect of the fibromyalgia. Diverse sleep abnormalities and sleep disorders are common in fibromyalgia. It may happen in delayed sleep, repeated awakening in the night, and poor sleep pattern. The sleep is non-restorative, and disturbance of the sleep is associated with further worsening of the pain symptom. It is directly related. More poor is the sleep, more are the symptom of the fibromyalgia. The characteristic polysomnography finding are alpha intrusion in the slow delta sleep. So sometimes it's also called as alpha delta sleep. Increased sleep latency and poor sleep efficiency may also be seen in the subset of the patient. There are certain associated condition or overlapping syndromes. Fibromyalgia overlap with the somatization disorders. As we can see in the diagram, there is poor self-reported state of health, fatigue, disturbed sleep, anxiety and depression, poor emotional function, failure to cope, weakness, morning stiffness, paresthesia, subjective joint swelling, headache, IBS, dysmenorrhea, and poor self-reported physical function. For diagnosis, we have evolved the ACR, American College of Rheumatology 1990 criteria. We have 3 criteria for that. One is ACR 1990. There is chronic widespread pain involving all the 4 quadrants of the body as well as the axial skeleton. In the diagram, we can see there are 18 tender points. Out of these 18 tender points, the presence of 11 tender point on the examination is must for the diagnosis. To diagnose these tender points, a pressure of equivalent to 4 kg per meter square is put. That is sufficient, that is equivalent to the pressure that it can produce the blanching of the fingertips. Original 1990 criteria remain valid and reliable in the experienced hand, but still have drawbacks. As in the primary care physician are willing or untrained to look for tender point, hence in the coming criteria, the examination part of the tender point has been eliminated in 2010 and 2016 criteria. As per the ACR 2010 criteria, the widespread pain for at least 3 months should be there. The other causes of chronic pain should has been excluded. Tender point examination has been replaced by the symptom checklist. By the 2 scale, that is widespread pain index and symptom severity scale has been introduced. This has an advantage because the tender point criteria is removed, survey-based criteria, and it also can be used to monitor the disease activity. So from the more experienced one, it has been shifted to the general physician. So this is the scale, widespread pain index score. This has a 19 point, 1 in the neck, 2 in bilateral jaw, bilateral sides of the jaw, shoulder girdle, upper arm, lower arm, 1 in the chest, upper back and lower back, 2 in the hip, 1 abdomen, upper leg and lower leg. This is a survey that is conducted on the patient. And on the other side, we have a symptom severity score that is in the grading of severity of the symptom of fatigue, awakening, unrefreshed, cognitive symptom. 0 is no problem, 1 is slight or mild problem, 2 is moderate, considerable problem, 3 is severe, pervasive or continuous life-disturbing problem. For the diagnosis of fibromyalgia, WPI is equivalent to more than equivalent to 7 plus symptom severity score of more than equivalent to 5, that is total of 12, or WPI more than equal to 3 plus symptom severity score more than equal to 9, again 12 should be fulfilled. In ACR 2016 modification, there is no longer exclusion of any diseases required. This emphasized the requirement of persistent and widespread pain for at least 23 months. In the previous ACR 2000 criteria, it was for 3 months, but in this, we have a pain persistence for at least 23 months. Widespread pain, that is pain present in at least 4 of 5 quadrants. Diagnosis of fibromyalgia can be made in parallel with any other diagnosis. 2016 criteria has not superseded or invalidated the 2010 criteria. Thus, both criteria should complete each other. So these criteria are based on the realization that fibromyalgia forms a continuous spectrum from the normal to this very severe and polysymptomatic distress scale. This gives an index of fibromyalgia severity, that is fibromyalgianess. Once we are tackling the patient of chronic pain, we should keep in mind the following differential diagnosis, and it should be ruled out during the course of treatment. Inflammatory cause can be polymyalgia rheumatica, or it can be inflammatory arthritis, that is rheumatoid arthritis or spondyloarthropathy, connective tissue disease like SLE, Sjogren syndrome, infectious component like hepatitis C, HIV, Lyme disease, Epstein-Barr virus infection. Non-inflammatory causes include degenerative joint, spine, disc disease, myofascial pain syndrome, bursitis, tendinitis, repetitive strain injuries. Endocrine dysfunction include hypo and hyperthyroidism, hyperparathyroidism. Neurologic disease like include multiple sclerosis, neuropathic pain syndromes. Psychiatric disease include major depressive disorder. Certain drugs can also produce the symptom of chronic pain, that is statin and aromatase inhibitors. Certain workup before labeling the patient of fibromyalgia, we should exclude the other causes with the help of these investigation. And as per the history, we should go for the routine examination of CBC. To rule out the inflammatory component, we should need acute phase reactant, that is ESR CRP. As per the history indicates ANA, RA factor or anti-CCP, serum calcium, serum phosphate, alkaline phosphate, thyroid function test to rule out the endocrine causes. Depending upon the clinical presentation, CPK can be done. X-ray and MRE to rule out any of the sacroiliac to rule out ankylosing spondylitis or any other degenerative disease. HIV, hepatitis C and bacterial disease like Lyme disease. Polysomnography to correlate with the sleep pattern. And these days ultrasound is also emerging us to rule out inflammatory arthritis. Now, after we have made a diagnosis of fibromyalgia by excluding all the other inflammatory, endocrine and other psychiatric component, the treatment should be based upon 3 component: non-pharmacological, pharmacological and other modalities. It is a multidisciplinary approach. For non-pharmacological, patient education is required. Patient should be educated what sort of expectation he or she should have from the treatment, what sort of this chronic pain is going to affect his daily routine activity in the coming life, and to what extent this can be addressed. Exercise and physiotherapy, these play a role exercise initially in the patient of fibromyalgia can worsen the pain, but we have to reassure the patient that exercise does not badly damage the joints or other parts of the body, and it should be encouraged so as to rehabilitate the patient in his or her routine daily activities. Cognitive behavior therapy to address the, as we have seen in the etiology, that major component of the fibromyalgia is the depressive symptom, and hence the quality of life on the basis of depression is also poor. This should also be addressed to counter the depression, anxiety, and other sort of the psychological illness. Pharmacological approach is very much centered, and it should be tailored as per the side effect and other profile of the patient. Anticonvulsant has a role. Pregabalin is one of the drugs that can be used. 75 milligrams starting from 1 OD to 1 BD, 75 1 BD, and it can be increased to 150 BD or even 250 BD. Then it should be kept in mind the side effect of the pregabalin. Tricyclic antidepressant amitriptyline has been proven role. It can be started from 25 milligram OD to 50 milligram OD. Again, the major side effect is the dry mouth and other symptom. SNRE in the form of duloxetine has a very proven role. It can be started from 30 milligram and can be taken up to 60 milligram per day. Milnacipran is 25 milligram BD can be used, and it can be increased to 50 milligram BD. 5S3 antagonist tropisterone can be used. Analgesic usually in SAD don't have any role in fibromyalgia. Sometimes they can definitely counter the pain, but for long term it is not advocated because of the side effect profile, and also it is not much beneficial in case of fibromyalgia. Tramadol can be used in certain cases, but again it has a abuse potential. Others, the role of mindful technique. Mindful technique is just to relax the psychological aspect. There is mindful reading, mindful exercise, mindful eating, and certain treatments to just relax and elevate the anxiety and the psychological component. Yoga again working on the same mechanism, and in certain cases acupuncture has been shown to play a role to improve the quality of life. So the take-home message is any patient not fitting into any of the condition causing chronic pain should be evaluated for fibromyalgia rather than labeling a patient as having back complaints. Any such back complaint should not be put on back treatment like multivitamins, antipsychotic, antidepressants. Targeted approach is needed for such set of complaints. Thank you.
Thank you, Dr. Jakub. Very nice presentation. Again, I think fibromyalgia probably is more or less a lifelong sort of a entity disease, you see. It's not that you have treated somebody and for the rest of your life the patient is all right. But and the young females, again, 2016 guidelines say, I think I still feel it's a diagnosis of exclusion rather than you make diagnosis on a clinical ground, you see.
Yes.
Once
yes.
you have ruled out most of those things, you see,
yes.
only then you label. The other thing is 11 tender points out of 18. And this is on a sort of a joke side, you see. I had a patient who had 18 tender points, and ultimately he had a fractured finger rather than having a tender point, you see. That was not a tender point. Actually, the finger was having a fracture. So I think one has to be very careful when you count about the tender points also. Make sure that they are really tender points, not the other way around.
That's why the tender point has been eliminated in the subsequent criteria.
Yeah,
because they have an increased sensitivity.
You have written 11 out of 10.
Yes,
I think
yes, this was the first criteria that was used for diagnosis of the fibromyalgia.
Doesn't justify.
Excellent talk. I think the physicians need to be aware of this condition to diagnose this condition. नहीं तो बंदा कहता यार उही हो गया थकावट है किसी नाल लड़ पिया सी तां करके थकावट चली जाती है. So definitely great talk. I must congratulate you to put forward all the points, relevant points for awareness of the conditions, how to diagnose and treat that condition. Thank you very much. Thank you.
Thank you.
Any other question or addition? Thank you.
I think the next topic is biologicals in asthma. And we had a talk yesterday, again from the same sort of institute, Dr. Agarwal, and he talked about chronic obstructive airway disease with an overlap with asthma. Today we are only talking about asthma. She's not there? Acha, acha, acha. Chalo. So she's not there. So next is, कहते हैं ना, the charity must begin from home. So next speaker is my own son, Dr. Sahil Nauria. He is DM Gastro. He is going to talk about an overview of MASLD. Previously, it was known as NASH or NAFLD, that non-alcoholic fatty cirrhosis, liver cirrhosis. So his talk is, because recently the terminology has been changed from NFL to MSALD. So Dr. Sahil, please.
Good morning, everyone. At the outset, I would like to congratulate Dr. Vitul sir and the entire organizing committee of MAPICON for this conference. So the topic for me today is metabolic dysfunction associated steatotic liver disease. In short, MASLD, a term which has recently replaced the old term that was NAFLD. To begin with, first, what's in the name? Why this change of name was needed? If you look at the old term NAFLD, when it was first coined way back in 1980 by Ludwig, it was mainly used in patients who were obese and on biopsy they had steatohepatitis. So it is basically a diagnosis of exclusion, not any criteria was defined. But over the years, as we have learned more about the pathogenesis and the etiology of this disease, it is now more clear that it is more commonly associated with a term which we all called as a metabolic syndrome. So NAFLD term per se was not doing justice to the true etiology of the disease. The other reason was the stigma. There was a certain amount of stigma, if you see, which is associated with the term fatty and alcohol. Many a times a patient visits to us in the OPD with an ultrasound report and saying, Doc sahab, liver fatty ho gaya mera. So these two were the main reasons behind the change of term. Eventually in 2023, a multi-Delphi consensus was made, and what they did was they used an umbrella term which was a steatotic liver disease, and which encompassed the entire spectrum of steatotic liver disease, namely MASLD, which we will discuss today. Then MetALD. This was an interesting kit which encompassed metabolic dysfunction and alcoholic liver disease, because the studies have shown that in patients who have got MASLD, the consumption of alcohol potentiates the progression to MASH. And then there was alcoholic liver disease and other causes of steatotic liver diseases. Coming on to the criteria, once you diagnose a patient with a steatotic liver disease on the imaging or biopsy, then you have to see whether there is any risk factor patient fits into any cardiometabolic risk factors or metabolic syndrome. And if patient is having 1 out of 5 metabolic syndrome criteria that were BMI more than 25 and 23 in Asian population, fasting serum glucose of more than 100, or patient is on any diabetic drugs, patient is having BP of more than or equal to 130/85, or patient is on an antihypertensive drug, or patient is dyslipidemic or is taking any lipid lowering agents. If yes, then you have to rule out any other cause of steatosis, and if patient is not having any other cause of steatosis, then you label the patient is having MASLD. The next problem was, once this coin was termed, the thing that came in mind was, over the past 40 years, there have been number of studies that were done on NAFLD. Can those studies be used in MASLD patients also? So for this, there was an analysis of Indian Consortium on MASLD, also known as ICOM-D, which was previously ICON-D. What they did was they studied 7,000 NAFLD patients, the clinical profile of NAFLD patients, and they found that almost there was an overlap of 98% in the clinical profile, the FIB4 criteria, the LSM, which was fibrosis, overlapping with MASLD patients. And the similar results were also found in other parts of the world, in which the percentage of the patients with NAFLD had the MSLD criteria almost 99%. Thus, concluding that the epidemiology, the clinical profile, the biomarkers which were previously used in NAFLD studies can be extrapolated to MSLD patients also. Prevalence: with the growing obesity epidemic in India, the prevalence is increasing. It is approaching approximately 30%. Pathogenesis: it is a complex interplay of the various fibrogenic cascade which is happening in the liver. There is increased accumulation of carbohydrates and fats, which leads to de novo lipogenesis, thereby increasing triglycerides. It leads to endoplasmic reticulum stress, lipotoxicity. Then there is insulin resistance, which leads to increased accumulation of free fatty acids, subsequently leading to increased triglycerides, ER stress, and lipotoxicity. Then there is activation of Kupffer cells, which leads to inflammation. Inflammatory cascade is activated, all potentiating to leading to MSLD and MASH. Coming on to the diagnosis, the first is the imaging modalities, abdominal ultrasound. It is with the first and foremost test which each and every one of us use because it is widely available, it is inexpensive. However, it is operator dependent and it is accurate only if more than 30% steatosis is present. With the advent of transient elastography, it was a game changer because it can not only diagnose steatosis, even milder steatosis also, it can also tell you about the fibrosis by providing liver stiffness measurement. Then there are other imaging modalities like CT and MRI. However, their use is restricted because of the cost and they are predominantly used in clinical research settings only. Then there are commonly used non-invasive tests. I will not dwell into much detail because of the shortage of time. It is altogether a different topic. However, just a short note that there are simple OPD-based tests now available and you can easily calculate on your mobiles. And these are FIB4 index, NAFLD fibrosis score, APRI index or AST upon platelet ratio index. And if these are positive, then you can subject the patient to the further testing. Liver biopsy, it is an imperfect gold standard because it is one of the most accurate tests which can tell you clearly about the degree of steatosis, steatohepatitis and fibrosis. Imperfect because it is invasive, it is painful, it has got its own degree of morbidity and mortality, and it is impractical for population screening. So its main use is limited to if you want to rule out any other diagnosis. This is a risk stratification flowchart which I think every one of us physicians, endocrinologists and gastroenterologists should use in our daily OPD. If you diagnose a patient with MASLD, then you should subject to one of the non-invasive tests which we have just discussed. If FIB4 is more than 1.3 or more than 2, then patient is probably having a high risk for MASLD or MASH, and then he should be subjected to second line non-invasive test like transient elastography. And if transient elastography values are more than 8, then yes, the patient is having significant fibrosis and he should be referred to a gastroenterologist and a hepatologist. And if patient is having FIB4 value of less than 1.3, then the patient should be subjected to a repeat non-invasive test in 1 to 3 years. Management, usually the first line of management is the lifestyle interventions. This is the cornerstone of the management for patients with MASLD. And then there is pharmacotherapy, and there are two types of pharmacotherapies. These are liver-directed therapies for MASLD, and there are therapies for managing diabetes and underlying cardiometabolic risk factors. Regarding lifestyle management, both ASLD and EASL have laid down clear guidelines for this. Regarding the weight loss, a reduction of more than equal to 5% of the total body weight leads to reduction in the liver fat in obese patients. A reduction of more than 7 to 10% leads to improvement in liver inflammation, and reduction of more than equal to 10% leads to improvement in fibrosis. In patients with lean NASH, a reduction of 3 to 5% of total body weight leads to reduction in liver fat. Regarding dietary interventions, there are clear-cut guidelines to follow the Mediterranean diet or a plant-based diet, which includes consumption of more of fruits, vegetables, lentils, olive oil, and more of unprocessed poultry food. Limitation should limit the consumption of ultra-processed and saturated fats. Regarding exercise, 75 minutes per week of vigorous exercise or 150 minutes per week of moderate exercise leads to reduction in liver fat, and then obviously you have to avoid alcohol and smoking. Coming on to the pharmacotherapy, the current pharmacotherapy aims at reducing hepatic steatosis, improves insulin resistance, there are anti-inflammatory agents, and there are antifibrotic agents. The pharmacotherapy we will discuss today, we are only limiting it to the drugs that are currently available in India and is being currently used for the patients in MSLD. The first drug which has been used for long is vitamin E in a dose of 800 international units per day. It is an antioxidant and it reduces the oxidative stress. It has been recommended in non-diabetic MASH patients with F2 and F3 fibrosis. However, it has got its own certain limitations, as it was found that it increases the risk of prostate cancer in men, and there was a higher cardiovascular risk and increased risk of hemorrhagic strokes. So use it with caution. Then there is resmetirom, which is a THR beta agonist. These THR beta agonists are the receptors which are predominantly expressed in the liver, and they reduce the de novo lipogenesis in the liver, and they increase the hepatic cholesterol clearance. A MAESTRO-NASH trial was performed for this resmetirom, and they showed that it reduces both inflammation without worsening of fibrosis, with minor GI side effects like diarrhea and nausea. Then is the GLP-1 agonist. They act by improving insulin hepatic sensitivity. They decreases inflammation, reduces hepatic lipid accumulation, and they were generally well tolerated with side effects like cholelithiasis, cholecystitis, and minor heart rate elevation. Semaglutide has been a game changer. It is emerging as a leading pharmacological candidate for the patients who have got both MSLD and MASH, with ongoing trials demonstrating its potential to improve liver fat, inflammation, and hepatic fibrosis. So this was a systematic review and meta-analysis which was done for semaglutide. Dose was 0.4 mg per day, and they showed that the treatment with 24 weeks of semaglutide could significantly improve liver enzymes, reduce liver stiffness, and improve metabolic parameters in patients with NAFLD NASH. Then there are dual and triple incretin agonists. There is tirzepatide, survodutide, and retatrutide. Of this, only tirzepatide is available in India right now. Survodutide and retatrutide are not yet available. A short word on tirzepatide: it is a dual agonist acting on GLP-1 and GIP receptor agonist. In this phase 2 multi-center trial, using a dose of tirzepatide 5, 10 or 15 mg once weekly, comparing it with placebo for 52 weeks, they showed that tirzepatide significantly improved the MASH without any hepatic fibrosis worsening in 44% in 5 mg, 56% in 10 mg, and 62% in 15 mg of the patients. Then we have got PPAR that are paroxysmal proliferated activated receptors in patients with MASH. There are basically 3 isoforms which are expressed in liver. These are PPAR gamma, which are the main target of actions of pioglitazones. Then there is PPAR alpha, which are the main targets for fibrates. And then there are PPAR beta and delta, on which elafibranor acts. Out of these, saroglitazar, pioglitazones are available in India, so which we will discuss. Pioglitazone, it has been extensively studied with combination with vitamin E in patients with biopsy-proven NASH, and it has shown that there was a significant improvement in liver histology, with MASH resolution achieving in 47% of treated patients compared to 21%. However, its use was limited because of its side effects. A 30 mg dose per day dose led to weight gain and worsening of heart failure. Studies are undergoing with the lower doses while mitigating its side effects. Saroglitazar, it is a novel dual PPAR alpha and gamma agonist, and recently it has got a DCGI approval for treatment of MASH. Well, it acts by decreasing hepatic steatosis and insulin resistance. It decreases hepatic inflammation by acting on the Kupffer cells, and it decreases hepatic fibrosis by preventing hepatic stellate cell activation, and reduces collagen deposition by reducing pro-fibroblastic factors. Well, this was a evidence 2 phase 3 trial of saroglitazar, which was performed by Dr. Sareen, and it shows that the saroglitazar in doses of 4 mg at week 52, it met the primary endpoint of resolution of NASH without worsening of fibrosis. There was improvement in liver parameters from baseline to week 52, and there was improvement in lipid parameters from baseline to week 52. Then there is SGLT2 inhibitors. The main study is being done on dapagliflozin. This was a DEAN trial which at 48 weeks showed a significant improvement in MASH without worsening fibrosis in 53% of the patients. Omega-3 fatty acids, it is an anti-inflammatory and lipid-lowering properties make them a promising option for MSLD and MASH management. A meta-analysis involving 9 studies reported a significant reduction in liver fat and AST levels. Well, in current future, there are multiple drugs which are in development for MASH in US, European Union and Japan. And few years we will have more drugs in our armamentarium which will have both anti-metabolic, anti-inflammatory and anti-fibrotic properties. This is a flowchart which can help us in managing the patients who have got MASLD. So if a patient has got a non-diabetic MSLD with no significant fibrosis, only lifestyle intervention is enough. But if the patient is having a significant fibrosis with an LSM of almost 15, then the patient should, along with lifestyle measures, can receive semaglutide, tirzepatide, resmetirom, saroglitazar or vitamin E. If the patient has got diabetic MSLD without significant fibrosis, then along with lifestyle measures, we can use semaglutide, tirzepatide, SGLT2 inhibitors and pioglitazones. If a patient has got a significant fibrosis, then along with lifestyle measures, you can use, along with the other drugs, pioglitazones and saroglitazar also. A word about bariatric surgery. In a meta-analysis by Lee et al., they have confirmed that after bariatric surgery, there was improvement in liver histology, including steatosis, ballooning degeneration, inflammation, and fibrosis. It can be considered in individuals with a BMI of more than equal to 27.5. However, a word of caution that even after bariatric surgery, there can be worsening of NAFLD. To conclude, MSLD should be considered in patients who are high-risk groups such as type 2 diabetes, who are pre-diabetic, who have got metabolic syndrome, and should be followed by an appropriate workup. A holistic personalized care involving all primary care physicians, endocrinologist, nutritionist, and gastroenterologist is needed. Thank you for your patient listening, please.
Thank you, Dr. Sahil. I think MASLD is coming up in a very big way as a root cause of all the issues associated with obesity, like diabetes, cardiovascular disease. It is causing lot of problems, and now we are, fortunate to have lot of drugs which are acting on the liver in association with decreasing the obesity. So I think it is a basic aim should be to diagnose, as you have already told, the diagnostic criteria. Every physician should look for MASLD in obese people, in diabetic people, in people having heart disease, and treating MASLD will reduce the other mortality and morbidity factors related to other diseases.
Treating it will definitely have a favorable outcome in cardiovascular disease and even progression to renal diseases also.
Yes. So I think I request you to give a brief take-home message as far as treating the condition in grade 1, grade 2, grade 3, grade 4.
So, sir, I think this slide will clearly show that if patient who has got a non-diabetic MASLD and has not got no significant fibrosis, then yes, lifestyle interventions have been the cornerstone for the management. And if yes, the patient has got a significant fibrosis, then any of the available drugs can be used because they are currently available in India. If diabetic MASLD is there, then yes, you have to manage the underlying diabetes. Along with that, you can use the drugs which have got the hepatic benefits along with the lifestyle measurements also, sir.
Thank you.
Thank you, sir.
Any other question, please? Thank you. Thank you, beta. could see Dr. Vikas. Sorry. Oh, again? Dr. Poonam, I mentioned that yesterday we had Dr. B.K. Agarwal from the same institute. He talked about chronic obstructive airway disease with an overlap in asthma. Today she is only going to talk about asthma and its sort of management and what are its biologicals. Dr. Poonam, please.
Good morning, respected seniors and all present here. I, Dr. Poonam Punya. Today I am presenting the topic biologicals in asthma. Firstly, defining asthma. Asthma is a heterogeneous lung disease characterized by the chronic airway inflammation with the respiratory symptoms such as wheeze, shortness of breath, chest tightness and cough, which vary over time and intensity and with the variable expiratory airflow limitation. It is very common disease, prevalence being 1 to 29% in various countries, and in India it is 2 to 4%. Some other related definitions like terms uncontrolled asthma. Uncontrolled asthma is persistent poor asthma control indicated by the frequent symptoms like twice in a week daytime symptom or night awakening due to this, or frequent reliever use like more than twice a week which limits the activity, or frequent exacerbations like more than equal to 2 in the past year requiring the OCS or more than equal to 1 requiring hospitalization. Then the difficult to treat asthma. It is the uncontrolled asthma that requires GINA step 4 and 5 treatment to maintain the control, and asthma being uncontrolled with these high level of the treatment still. Then severe asthma. It is the uncontrolled being maximal high dose inhaled ICS-LABA therapy and having an contributing factor such as incorrect inhaler use and comorbidities. And asthma worsens when we decrease the treatment from the high dose. There are some asthma phenotypes according to which we do the treatment of these phenotypes. These are the demographic, clinical and pathophysiological characteristics. First being allergic. As the name suggests, allergics in this phenotype, we have association with the allergic diseases such as eczema, allergic rhinitis, food or drug allergy, and it responds well with the ICS treatment. Second is non-allergic. It has no association with the allergy and it has a lesser response with the ICS treatment. Third is cough variant or cough predominant. The only symptom being the cough in these cases, and some develop wheezing or bronchodilator responsiveness, and ICS is the treatment. Fourth one is adult onset or late onset asthma. It's mainly seen in the young females and in the adult life. And the corticosteroid is the only treatment and high dose ICS. Asthma with persistent airflow limitation. This is a long-standing asthma in which the patient having the airflow limitation that persists or incompletely reversible, and some of them develop the airway remodeling. Last one is the asthma with obesity. It is associated in the obese patients. Now there are two types of inflammatory phenotypes, type 2 high and non-type 2 inflammation. Type 2 inflammation is associated with certain cytokines like interleukin 4, 5 and 13, elevated eosinophil levels and increase the FeNO, and associated with the atopy and elevated IgE levels. Non-type 2 is having the mainly increased neutrophil levels. And in severe asthma, type 2 inflammation may be relatively refractory to the high dose ICS and responds well to the OCS, but higher dose of OCS. How we assess the severe asthma phenotype in which we need the biologicals is the any of the following, with having the patient already taking high dose ICS or daily OCS with blood eosinophil count more than equal to 150 per microliter, FeNO more than equal to 20 parts per billion, sputum eosinophils more than equal to 2%, and asthma is clinically allergen driven. This is the flow. We have two tracks for the asthma management or treatment according to the GINA 2025. The more popular being the track 1, and we mainly treat our patients according to the track 1. In this case, step 1 and 2 is the anti-inflammatory reliever therapy is the used, mainly the low dose ICS formoterol. In step 3, we use the maintenance and reliever therapy with low dose maintenance ICS formoterol. In step 4, we use MART with the medium dose of the maintenance ICS formoterol. In step 5, we use add-on LAMA therapy and assess the phenotypes accordingly and consider the high dose of ICS formoterol with the biologicals. And the reliever is same in all these steps, is as needed low dose ICS formoterol. In track 2, we have step 1 reliever only therapy where the SABA with ICS in each dose, step 2 low dose maintenance ICS, and in step 3, 4, 5 the same as the track 1. But here the change is reliever therapy. Reliever is as needed ICS SABA. I have discussed earlier that the biologicals are mainly being given in the type 2 targeted therapies. This is the inflammatory cascade in the asthma pathophysiology. Firstly, any of the allergen, pollutant or smoke which irritates the bronchial epithelium, which sensitize the dendritic cells, further which causes the, through the naive T cells, T2 cell stimulation. Th2 cells have two responses, one to the B cells which releases the eosinophils, IgE sensitizes the mast cell activation at basophils, which releases interleukin 4 and 13. And through the T2 cytokines, we have interleukin 5, 4 and 13, which causes the eosinophil maturation and smooth muscle contraction. Goblet cell releases the mucus hypersecretion. And the other response is through the TSLP and interleukin 33 and 25 through the NK cells, which causes the cell-mediated cytotoxicity. Here the response of these various biological agents act on these receptors of the, like omalizumab acts on the B cell receptors to decrease the IgE levels, and dupilumab acts on the interleukin 4 receptors. Mepolizumab and reslizumab act on the interleukin 5 receptors, and benralizumab act on the interleukin 5 alpha chain of these receptors, and tezepelumab acts on the TSLP. These are the 6 biologicals present. First, omalizumab, dupilumab, mepolizumab, reslizumab, benralizumab, and tezepelumab. IgE is an essential in inflammatory cascade of the allergic asthma produced by the B cells and responds to allergen activation of the cell-mediated immune response. Here the omalizumab acts on the IgE. It is the first FDA-approved biological for the treatment of severe asthma. It is humanized anti-IgE monoclonal antibody, and it binds to the Fc receptor of unbound IgE. This is shown in the next slide in the diagrammatic form. Omalizumab binds to the circulating IgE and decreases the cell-bound IgE, and secondly, it decreases the expression of high affinity receptors, which leads to decreased tissue infiltration and mediator release. Further leads to decrease in the allergic inflammation and asthma symptoms and exacerbations. Indicated in the patients of more than equal to 6 years, and in the moderate to severe asthma patients, total IgE between 30 to 1300 international unit for the 6 to 11 years, and 30 to 700 international unit per ml for the 12-year or older patients. And positive skin allergy testing for the perennial air allergens. This can be skipped, the preparation. The dose is based on the body weight and pre-treatment of the IgE levels. Recommended dose 0.016 milligram per kg of the body weight per international unit of the IgE, and it is given subcutaneously every 2 to 4 weeks. given for the 3 to 6 months, and then we will see the response to of the patient, and accordingly we can continue for the indefinite period. There are various studies like persistent innovative study. It shows that there is significantly reduced rate of the asthma exacerbation. Export study shows that if even on the withdrawn of the omalizumab, there are decreased exacerbation for at least 1 year. There are some side effects like injection site reaction, nasopharyngitis, headache, upper respiratory infection, sinusitis, and it has a black box warning for the anaphylaxis. And it shows that there is an increase in the risk of malignancy like epithelial or solid organ cancers, but according to the Excel study, there is no increase in the risk of malignancy. Second interleukin is interleukin 5. Consider the key cytokine responsible for the recruitment, maturation, activation, and degranulation of the eosinophils. This is the mechanism when any allergen acts on the bronchial epithelium, activates the dendritic cells, and through TSLP, ILC2 cells, and mast cells are sensitized, which all the three releases the interleukin 5, and further it causes the eosinophil activation. Mepolizumab, it is a humanized monoclonal antibody, first approved IL-5 against the IL-5 in November 2015, and acts on the alpha chain of the interleukin 5 receptor. Used for the uncontrolled eosinophilic asthma with increased sputum more than 3% or AEC more than 150 cells per microliter. There is a DREAM study for the mepolizumab. It shows that there is a reduced rate of clinically significant exacerbations after its use. Mensa study shows that there is a rate of exacerbation of patient receiving IV mepolizumab reduced by 47 to 53% of the subcutaneous administration. And the serious study shows that there is a reduction in the glucocorticoid use after this. Dosing and administration approved for the patient more than 12 years and with severe asthma with eosinophilic type, available in 100 mg lyophilized powder for reconstitution and used in the sterile water. 100 mg is given via the subcutaneous route every 4 weeks and given for at least 4 months for the treatment, and then can be given for the indefinite period according to the response. Adverse reactions like headache, injection site reaction, back pain, fatigue. The zoster vaccination should be given at least 4 weeks before its administration, even if we give the mepolizumab in the more than 50 years of the age of the patients. It also approved in the patients of eosinophilic granulomatosis with polyangiitis with higher dose of 300 mg every 4 weeks. And also in the COPD with eosinophilic phenotype. And there is a study Matrix or Mitrio for the COPD with eosinophilic type phenotype variant, and in the cases where the AEC level is more than 150. And it reduces the exacerbation. Third is reslizumab. It is a humanized, it is also humanized IL-5 antibody for the uncontrolled eosinophilic asthma, and it reduces the exacerbation and reduce AEC levels and improve the lung function. It is available on the brand name Syncure and FDA approved in the March 2016. It is given for the patients of age more than 18 years and older with severe eosinophilic asthma, AEC more than 400, and it is the only biological which is given intravenously with a dose of 3 milligram per kg every 4 weeks over 20 to 15 minutes. And it comes in a 100 milligram by 10 ml solution given for the severe asthma patients. Fourth one is benralizumab. It is a humanized fucosylated monoclonal antibody that targets the IL-5 receptor alpha on the eosinophils and basophils, and it causes a cytotoxicity. Administered in the more than 12 years of the age of the patients, and 30 milligrams subcutaneously every 4 weeks as an induction phase, and then every 8 weekly for the maintenance. It is approved in November 2017 and causes a significant reduction in the exacerbation and improves the quality of life of the patient, and more significant in the higher eosinophilic group, mainly AEC more than 300. And there are two trials, Sirocco-Kalima trial, which shows that there is 51% reduction, and Zonda trial, which shows that there is a lesser use of osseous after this. Adverse reactions, it is well tolerated and can lead to hypersensitivity like anaphylaxis, angioedema, nasopharyngitis, upper respiratory tract infections. Then the IL-4 and 13 interleukins. IL-4 is seen in the type 2 high asthma, and it causes a T cell differentiation which induces the production of T2 cytokines like 5, 9, 13 and eosinophil eotexis. It causes this class switching of the B cell IgE, and second is interleukin 13. It causes the tissue remodeling and mucus hypersecretion by the goblet cells, smooth muscle alteration and increased hyperreactivity. And it causes, it also increases the nitrogen oxide levels, and both IL-4 and 5 pathways share the common receptor, that is IL-4 receptor alpha. On these receptors acts the dupilumab. It is a human monoclonal antibody, first FDA approved in 2018 in the age group of more than 12 years, and benefits of the patient mainly in the AEC levels of more than 150 and FeNO more than 25. Dupilumab acts on the alpha receptors of the interleukin 4 and 13. It is helpful in asthma, atopic dermatitis and chronic rhinosinusitis. It is given 200 to 300 ml every 2 weeks, and it causes reduction of exacerbation by 70%. Quest studies shows that after given dupilumab given every 2 weeks for 52 weeks, significant reduction in the asthma exacerbation, and venture study trial shows that there is also reduction in the exacerbation. Adverse effects like injection site reaction, headache, upper respiratory tract infection, nasopharyngitis, increase in the eosinophil count. Then lastly, the tezepelumab. Tezepelumab acts on the TSLP receptor and further decreases all the down mechanism, like acts on the basophil, eosinophil, dendritic cells, neutrophil and mast cells, and decreases all the cytokines. It is an IgG2 monoclonal antibody that inhibits the binding of TSLP and approved in the more than 12 years of the patients. It is it blocks the downstream process of the processing of the further interleukins, and it is given 210 milligrams subcutaneous injection every 4 weeks. Outcome shows that 30 to 70% reduction in the severe asthma and improve the quality of life and lung function. Predictors like high eosinophil and high FeNO levels. It reduces the eosinophilic inflammation, activity of Th2 cells and interleukin cells, ILC cells. Adverse reactions like injection site reaction, anaphylaxis. Trials are pathway, navigator, destination and source. All these trials shows that there is a reduced asthma exacerbation rate by 50% and improve in the FEV1 and reduced biomarkers. Thank you.
Thank you very much, ma'am, for your enlightening talk on biologicals and asthma. So any questions or comments, please? So if there are no questions, we will end your session here. Thank you very much. Thank you. So next we are going to have the lecture on new and old management guidelines for multi-drug resistant tuberculosis. We have 2 absentees here for the lecture. So we have received a video lecture from Dr. Mohanjit, and this lecture was scheduled to be presented tomorrow, but to fill up the time, we are presenting this lecture, video lecture by Dr. Mohanjit. Please play that.
definitions. So first of all, what is multi-drug resistant tuberculosis? A TB patient whose biological specimen is resistant to both rifampicin and isoniazid, with or without resistant to other first-line anti-TB drug, is said to be MDR tuberculosis. On the other hand, mono-resistant tuberculosis is where biological specimen is resistant to one first-line anti-tubercular drug only. And as we know, rifampicin resistant tuberculosis is patient is resistant to rifampicin and of monoresistance, polyresistance, MDR, or extensively drug resistance. On the other hand, polyresistance is resistance of the clinical isolate to more than one first-line anti-TB drugs other than both isoniazid and rifampicin. Now let us see what is extensively drug-resistant tuberculosis. Here the Mycobacterium tuberculosis strain is resistant to fluoroquinolones and moxifloxacin also, and at least one additional group A drug, which is either bedaquiline or linezolid. Pre-extensively drug-resistant tuberculosis is tuberculosis which is caused by MDR strain that fulfills the definition of MDR/RR tuberculosis. In addition, they are also resistant to any fluoroquinolones. So these are few definitions. So let us see how do we diagnose drug-resistant tuberculosis. As we know, these are two methods, genotype and phenotype. Genotype is basically molecular testing, where the underlying genome is tested, and phenotype are the conventional culture and drug sensitivity tests. So we know that genotype or molecular testing is basically with expert MTB, TrueLab, and line probe assays. Here what we do is basically we are observing the nucleic acid or the real-time PCR, where we look for the multiplication of the RNA material. And phenotype or conventional cultures, we know these are either in the solid culture or liquid culture, where we observe the growth of the organisms. So a few words about the next generation sequencing testing. This is important for multi-drug resistant tuberculosis, and it provides a very rapid diagnostic module. Here we have pyrosequencing, Sanger sequencing, and in certain tests, entire genome of Mycobacterium tuberculosis is detected. Basically, next generation sequencing, it targets focus on specific genetic loci which is relevant to drug-resistant tuberculosis. The only negative point being the high cost, and maybe in the future it may be available to the patients at reasonable price. So this is a very important slide, and this shows the integrated algorithm which is provided by National Tuberculosis Elimination Program. I know it is a very busy slide, but what we want to focus here is that first of all, any patient who is classified, notified as TB patient, or patient who is a presumptive case, and maybe on the basis of chest x-ray history, and patients who are living with tuberculosis, active cases. So all these patients, they should undergo the test for sputum testing, and also test for resistant parameters to rifampicin and INH. And suppose patient is found to have Mycobacterium tuberculosis, but rifampicin resistant is not detected, then the patient will undergo conventional treatment, and if out of that we have H resistant detected, then the patient will be on modified regime, including levofloxacin quinolones with RZE regime. But if the patient has Mycobacterium tuberculosis positive, and if we detect rifampicin resistant also, then these are the patients who should be further evaluated properly. First of all, we will see the age of the patient. If the patient is more than 14 years and patient is eligible for BPAL-M regime, then definitely he is a candidate for BPAL-M regime. But if the patient is less than 14 years of age, and if the patient is eligible for short term, that is 9 to 11 months of oral regime, then we start the patient on the recommended oral regimes, which can be with linezolid, levofloxacin, clofazimine, and bedaquiline, any of these drugs, and maybe the longer duration of treatment regimes are available. But here I would like to focus upon the BPAL-M regime, which is a very good regime, and it is the latest in the basket of MTB tuberculosis drug-resistant cases. And in our hospital, we have started putting the patients on BPAL-M, and I will be discussing this in detail also in my subsequent slides. And if we see my hospital data, at present, we have 3 patients who are on BPAL-M regime for multi-drug resistant tuberculosis. So let us see, I would like to say few words about the newer drugs which are available now. So in this category, first and foremost important is bedaquiline. This is diarylphenolone that specifically targets mycobacterial ATP synthase, which is an enzyme essential for the supply of ATP to Mycobacterium tuberculosis. Bedaquiline is a strong bactericidal and sterilizing medicine, and as per Indian guidelines, it has been approved for children who are more than 5 years and weighing more than 15 kg of weight. The next important medicine is dalamanid. This is nitrodihydroimidazole bactericidal drug which is approved for use. And another important point to note is that this is recommended for all ages, but weight should be more than 10 kg. Now the third important drug is pretomanid. It is nitroimidazole category of drugs, and this is basically a prodrug which works by inhibiting the synthesis of mycolic acid. And this is again part of combination therapy alongside bedaquiline and linezolid. So this is what forms the basis of BPAL/BPAL-M regime for treating the drug-resistant tuberculosis patients. So this is what the WHO grouping of drugs is. Basically, we have 3 groups of drugs, group A, B and C. So if we want to start the patient on treatment for multi-drug resistant, so group A, concern will be to include all 3 drugs from group A, which is levofloxacin or moxifloxacin, bedaquiline and linezolid. So all these 6 should be added, and then in group B at least 1 drug should be added. Now group B drugs are clofazimine, cycloserine and terazidone. Then is the group C drug which is added to complete the regime, and this includes ethambutol, dalamanid, pyrazinamide, imipenem, amikacin, ethionamide and prothionamide. So these are the 3 important groups of MDR tuberculosis regime. So basically, if we look at the standardized treatment regimes which are provided by WHO, so it can be either H-mono or poly-drug resistant TB regime, it can be BPAL regime, shorter oral bedaquiline containing regime and longer oral multi-drug resistant TB regime, which basically includes medications from all 3 groups of medicines which I have discussed earlier. So I would like to highlight on this slide, this is BPAL-M regime. Basically it constitutes for 26 to 39, so either short term or extended, and it includes bedaquiline and pretomanid and linezolid and moxifloxacin. So this is what constitutes, and this is what is available now, and this is what we are giving to our MDR TB cases in our hospital also. Let us see the dosage schedule. Bedaquiline week 1 to 2 will be 400 milligram, and then from 3rd week onward to 26 or 39 weeks it will be once daily. It will be 200 milligram 3 times a week, plus pretomanid from week 1 to 26 or 39 it will be 200 milligram daily. So we have to observe that bedaquiline is initially given daily and then it is given 3 times a week. Pretomanid is given daily and linezolid also 600 milligram once daily. Moxifloxacin weeks 1 to 26 or 39 400 milligram once daily. So only bedaquiline is the medicine which needs the dosage reduction after 2nd week of treatment. So let us hurriedly go through the eligibility and exclusion criteria. Basically, any person who is more than 14 years of age, newly detected case of RR tuberculosis, is eligible for BPAL-M regime, And suppose patient already in the past he had exposure to these medications, but it is less than 1 month, again he can be started on this category of medication. So person less than 14 years and documented resistance to any of these medication, it excludes the patient from putting on this particular regime. Now, what are other eligibility criteria? Any patient who has no significant conduction abnormalities in the heart, including structural heart disease, syncope, long QT syndrome, AV blocks, re-entry arrhythmias. These are also the patients who are eligible for BPAL-M regime. Now coming to pregnant women and lactating women. See, here we have to offer the MTP to the patient, gestational, the pregnant ladies who are detected to have MDR tuberculosis, and then we can decide the eligibility of the patient for BPAL-M regime. Now, if we have a patient with significant liver dysfunction or patient who has a very severe form of extrapulmonary tuberculosis like CNS tuberculosis, disseminated miliary tuberculosis, then I think these patients, they need to be evaluated, and they will benefit more from the long-term conventional treatment. So what is the data to suggest the potency and efficacy of BPAL-M regime? We have a number of trials. I will not go into the details, like we have NICS TB trial, CNICS trial, and TB Practical trial. So all these trials, they show good efficacy and the results in patients with MDR tuberculosis. So I think patients should be given a fair chance to receive shorter oral treatments for multi-drug resistant tuberculosis. Now this, I think I have already said, MDR TB regime should include at least 4 to 5 drugs that are likely to be affected. We should incorporate all drugs from group A and 1 to 2 drugs from group B. If any drug from group A or B are contraindicated, then we have to pick up drugs from the group C. And then at least 4 effective TB medications with at least 3 agents continuing for the remainder of the treatment if bedaquiline is discontinued. Also, NTP guidelines suggest that 5 drugs from group A and B and 4 drugs after 6 to 8 months should be given if the patient is tolerating these medications. So these are the weight bands I think we should take into consideration, because the treatment will be based on the weight of the patient. Any adult patient who is more than 18 years, they are classified in the weight band. It is less than 16 kg, then 16 to 29 kg, then 30 to 45 kg, 46 to 70, and more than 70 kg. Now, what is the role of steroid in drug-resistant tuberculosis? Any patient with severe respiratory deficiency, respiratory insufficiency, pericardial disease, severe CNS involvement, they should be put on steroids. But we have to make sure that they receive an appropriate anti-tuberculosis dosage also. Now, very briefly, indications of surgical intervention. Suppose patient did not have any bacteriological or clinical response to chemotherapy after 6 to 9 months of effective treatment, or maybe high degree of drug resistance or extensive parenchymal involvement, which increases the risk of treatment failure or relapse, and then extensive parenchymal disease with the side effects like hemoptysis, bronchiectasis, bronchopleural fistula, empyema. And then if the patient has recurrence of disease, all this subset of patients, they should be put on surgical intervention also. So what is my take-home message? Prevention, diagnosis, and treatment of MDR is essential. Genotypic and phenotypic methods are available and should be used. New oral drugs are available which offer short-term courses, and they show promising results. So friends, this is a very, this is what we are doing in our center. So this is one patient who is put on BPAL-M regime, and this is how we maintain his card. And we can see that the patient had history of 80 to 20 years where the patient was, previously treated, and then patient was diagnosed to have rifampicin treatment. And this patient is 38 years, and patient is put on CBNAT was already sent, and patient is put on BPAL regime. So this is how we maintain all the card of the patient. BPAL-M initiated by the DOT worker. So patient comes under the, here HIV status is also mentioned, and the basic parameters LFT is also mentioned. So patient comes in the weight band of 30 to 45 kg. So this is the medication which is available in our center. So these are the bedaquiline tablets, 100 milligram, pretuminate tablet, which comes under the name of Doperella, 200 milligram, and then this is linezolid tablet, 600 milligram, moxifloxacin, 400 milligram, and pyridoxine, 10 milligram tablets are available. So this is what we are, this is the total short term, this is what we, the ATT package which we are giving to our patients, BPA-LAM regime. So the patients are doing well, and so far there has not been any side effects. So with that, I thank you so much for involving me in this conference. Thank you. Good morning, my dear friends and colleagues. I, Dr. Mohanjit, take privilege of presenting this important topic for
Our next talk will be delivered by Dr. Deepak Bansal, MS Orthopedics and President of IMA Bathinda. His topic is when to do TKR.
I will like to thanks to Dr. Vital Gupta and organizer of the MAPICON to invite me to give lecture on when to do TKR. I am just starting my lecture. Thank you. In this lecture, we will study about anatomy of the knee joint, common condition leading to TKR, unicondylar knee replacement, total knee replacement, and robotic knee replacement. The anatomy of the knee joint is mainly consists of tibia, femur, and patella, 3 bones, and it makes 3 compartment: medial compartment, lateral compartment, and patellofemoral joint part compartment. Knee is stabilized by mostly soft tissue. It does not have its inherent stability. On the medial side, it is stabilized by medial collateral ligament, which is the main stabilizer of the knee joint. On the lateral side, LCL, lateral collateral ligament, are the stabilizer which resist the valgus stress. On the anterior and posterior side, there is anterior cruciate ligament and posterior cruciate ligament, which give stability in anterior and posterior transition of the joint. Rotation stability is also assisted by anterior and posterior cruciate ligament. Common condition that lead to damage of the knee joint is osteoarthritis. It is mostly idiopathic, and second most common cause is rheumatoid arthritis. Third is the post-traumatic osteoarthritis. As you all know, osteoarthritis is a degenerative joint disease. It caused by wear and tear of the joint that cause cartilage cushion of the bone of the knee soften and wear away. This will cause the bones rub against one another and causing knee pain and stiffness. Rheumatoid arthritis is a chronic inflammatory, can damage the cartilage, eventually cause cartilage loss, pain and stiffness. Post-traumatic arthritis is a condition where fracture or soft tissue injury of the knee joint which cause damage to the cartilage and causing the ultimately damage of the cartilage and ultimately arthritic changes develops. Knee arthritis is far more common than hip osteoarthritis in Asian population. In the 80% above 75-year population, knee is osteoarthritic. Sex, in most male and female, there is a 45 to 50% year of age, equal incidence in both the sexes, but in female after 55 years of age, osteoarthritis of knee is more prevalent. Most common risk factor of the osteoarthritis is increasing age. By the age in increasing, incidence of the osteoarthritis is increases. Obesity, mostly obese and healthy patients develop early osteoarthritis. In female sex patients, mostly wear and tear of the joint is more common, and osteoarthritis of the knee is more common as compared to male patients. It is maybe due to some hormonal changes that increase the incidence of osteoarthritis knee in female patients. Trauma, infection, and repetitive occupational trauma are other causes which can cause to increase the risk of osteoarthritis. Clinical feature of osteoarthritis, it is depend upon the stage of the involvement. Initially, patient develop the pain and then develop the loss of function, stiffness, swelling, which increases with the increasing stage of the osteoarthritis. And in the last stage of the osteoarthritis, patient develop deformity and captus. Bony captus are the last, and deformity and bony captus are in the lastmost stage of the osteoarthritis. This is the radiological osteoarthritis staging. In stage 1, there is a medial and lateral joint line is normal, and normally joint space is normal. In grade 2, there is a mild joint space narrowing. In grade 2, there is a minoid osteophytes and doubtful joint space narrowing. In grade 3, there is a moderate joint space narrowing. Medial joint space is greatly reduced, which causes friction of the both cartilage, medial and femur and tibial cartilage, which causes pain. And in severe osteoarthritis, there is no joint space, subchondral sclerosis is there, and even sometimes subchondral cysts are there. This is the radiological picture of a osteoarthritic knee, which shows all the 4 changes, like joint space narrowing. There is a patellofemoral joint is also involved, which shows multiple osteophytes, and joint space is I think difficult to see any joint space in there. Now management part. The mostly osteoarthritic patients are managed with initial stage 1, stage 2. We try to manage with patient with patient education, use of assistive devices, weight loss, and physical therapy, occupational therapy. But in advancing stage of osteoarthritis, we will have to manage the patient with some analgesics, glucosamine supplements, and intra-articular steroids can all be given to relieve the symptoms of the patient. Intra-articular hyaluronic acid injections are one of the option to delay the progression of the disease. And if the patient does not manage with non-operative treatments and some conservative management, then we have to go for the operative treatment. Operative treatment for the stage 2 or stage 3 consists of mainly arthroscopic lavage of the joint. Osteotomy, it is in stage 2 or stage 3 where joint space is narrowed but joint cartilage is still there. So we can plan for the HTO, high tibial osteotomy, which can align the axis of the tibia to the femur and reduce the medial joint line pressure, and which relieve the symptom of the patient. Nowadays, unicondylar knee replacement surgery is also in early stage of osteoarthritis, where second or third stage osteoarthritic patients can be relieved with the unicondylar knee replacement surgery. It is a technical demanding surgery and require technical expertise. In the last stage, stage 3 or stage 4, we have to no other options than go to the knee replacement surgery. And nowadays, robotic assisted knee replacement surgery is also in trend. This X-ray shows the partial knee replacement where the medial side of the cartilage is replaced, and in the total knee and advanced osteoarthritis, we replace the total medial and lateral condyle, even tibial whole surface is replaced. Evolution of TKR. TKR is initially started in 1816 by the Ferguson. Initial arthroplasty, resection arthroplasty is done where the damaged arthritic part of the cartilage is totally removed. In 1940, first artificial implant was tried when mold was fitted in the femoral condyle. In 1950s, combined femoral and tibial articulation surface replacement appeared as a simple hinge. In 1971, Frank Gunston developed a metal on plastic knee replacement system. John N. Install is father of the modern day TKR. He designed what has become the prototype of current total knee replacement. This was a prosthesis made of 3 components which would resurface all the three surfaces of knee, femur, tibia and patella. Natural mechanical alignment philosophy is initially given by Professor John S. N. Insall, and he is also known as father of modern day total knee replacement system. Definition: total knee replacement is also known as joint arthroplasty. The surface in the joint where the bones meet are resurfaced. There is very minimal or no risk that your body will reject these components. It is a surgical procedure in which damaged part of knee joint are replaced with artificial part prosthesis. During this procedure, an orthopedic surgeon replaces an arthritic or damaged joint with an artificial joint, inserting prosthesis same size as removed bone cartilage and making the joint stabilized knee for survivorship of the knee and painlessly. Evaluation of patient before surgery: a complete medical history through physical examination and laboratory workout for any infection or any other bleeding disorders, any anemia, so that patient can be fit for surgery. And finally, anesthetic assessment to get the pre-anesthetic checkup. Somehow there was some contraindication for the total knee replacement. If there is any infection, recent or current joint infection or any infection in the body, it is an absolute contraindication for the total knee replacement. Neuropathic arthropathy joints are also a contraindication because most of time these joints are non-stable after the replacement. Relative contraindications are severe osteoporosis, dilapidated poor health, non-functional extensor mechanism. Extensional mechanism is a main mechanism which make the patient move after the surgery. If it is non-functional, the results will be doubtful. Painless and well-functioning arthrodesis, significant peripheral vascular disease. It is a picture showing the unicondylar TKR where the medial femoral condyle and medial tibial surface is replaced with a prosthesis. It is an unconstrained TKR where the whole of the femur and whole of the tibia is resurfaced, and there is a unconstrained type of TKR. And this shows the constrained TKR which give medial and lateral stability, even anterior posterior stability, and it is more stable than unconstrained TKR. Now, $1,000,000 question: when to do TKR? The quality of life is severely affected, which causes daily pain and restriction of ordinary activities. Evidence of significant radiographic changes of the knee are the main indication when you have to go for the TKR. The picture is more elaborating, which shows severe knee pain and stiffness, swelling, no relief from other treatments, non-conservative treatments are failed, joint deformity is there, reduced quality of life. If patient does not do the daily routine to activities, even going to washroom is very much painful, so it is recommended better to go for replacement. And if the arthritis is advanced, if rheumatoid arthritic patients, osteoarthritic patients, those who are in a very advanced stage, they can do their routine activity, are candidate for total knee replacement surgery. And what is the timing of the time for replacement? Old age with more sedentary lifestyle, young patients who have limited functions, progressive deformity, other treatment modalities have failed. TKR should be done before things get out of hand. The patient experiences a severe decrease in range of motion, deformity, contracture, joint instability, or muscle atrophy. But we are talking about total knee replacement, and what is the goal of TKR? It is transforming a deformed arthritic knee into proper axial, sagittal and rotational alignment of a knee joint, which will relieve pain relief and restoration of normal limb alignment, restoration of functional range of motion of the patient. When I am studying in my MS, then there is a good result is walking, going up down stair of the after the TKR. It is considered good results. Playing with grandchildren and gardening, these are considered good results. But nowadays, patients are more demanding. They are expecting jogging, cutting sports, skiing, martial art, and hard physical labor after the TKR. These are the some X-rays of some patients. We have done TCAB and get excellent results. There are some other patients which shows before surgery and after surgery X-rays. These are all constrained knee. We usually prefer constrained knee as it is more stable and it is better to get early movement. Some other patients. To get successful result depends upon precise surgical technique, sound implant design, appropriate material, patient compliance with rehabilitation. Patient compliance with rehabilitation is the, I think, once the surgery is done, it's a patient's compliance which give excellent result to, in the post-TCAR time. Patient's compliance increase the patient's mobility and it helps the patient to gain better movement. Patient-specific personalized functional alignment is in trends nowadays. It is preferred over the kinematic alignment and which is preferred upon the mechanical alignment. As we are talking about alignment, different alignment have different advantages. In 1970, when father of orthoplasty, Dr. Insal started, they are doing mechanical alignment, and which is shifted into 1990 into anatomical alignment. In the era of 2000, it is shifted into kinematic alignment. But nowadays, restricted kinematic adjusted mechanical alignment is preferred. And with the time, in the coming years, it is considered functional, personalized, patient-specific alignment, which is mostly achieved with the robotic assisted knee replacement. We have installed meso-robotic system at our center. We're doing replacement with mostly cases with meso-robotic system. It is meso-robotic system is it is a fully active robotic system, and it will give agile, precise cuts and better implant fixation. It is a safe as whenever there is some movement, it stop automatically, and it is personalized as mostly patients CT initially done on the basis of planning was done, and final execution of the surgery was performed according to planning. This picture shows alignment before going to surgery. We will check the alignment before going into surgery, and patient's cuts are initially assessed before going into surgery. There are some results of our patients. This patient is having severe varus deformity and unable to do his routine daily activity. It is this is post-operative video. There are some more patients. We just celebrated our 100 knee cases in last month, and we are watching 150 cases in next month. Hoping for best. So pick your stick wisely. Get checked with the knee replacement surgeon. Thank you.
Thank you, sir. The session is now open for discussion if there are any questions. Thank you, sir.
Thank you, ma'am.
Our next talk is on approach to headache, and it will be delivered by Dr. Abhishek Garg, who's DM Neurology and is consultant neurologist, Crystal Healthcare, Bathinda.
स्लाइड तो ये वाला ना. Good afternoon. Hello. Hello. Good afternoon, everyone. Today, my topic of discussion is approach to headache. So, without wasting time, let's start with the topic. Why discussion of headache is important? Because headache patient come to OPD of each and every specialty, and global burden of headache is very high. We see 1 in every 3 person in this world has severe headache at some stage of their life. And if we see worldwide, almost 40% adult population has headache at least once a year. In our neurology OPD, almost 25% referrals are for headaches, but good thing is majority of headaches are benign headaches. So chief objectives of this talk are to learn about major types of headache, to understand the basic difference between primary and secondary headache, how we can differentiate these secondary headaches from primary headaches, how we should approach a patient of headache in our OPDs or ER, and lastly, treatment and prophylaxis of some of the primary headaches. So first of all, it is important to differentiate between primary and secondary headache. What is primary headache and what is secondary headache? So primary headache is headache when there is no underlying structural or metabolic abnormality in body. Secondary headache when there is some underlying structural abnormality in brain, outside brain, or some metabolic abnormality in the body. Common examples of primary headaches are migraine and tension type headache. How secondary headache arises. I have told that secondary headache is headache which originate due to some structural pathology, like some extracranial structural pathology like sinusitis, otitis media, glaucoma. Intracranial pathology like tumor, abscess, meningitis, dissection can give rise to headache. Some metabolic disorder like CO2 retention, OSA can give rise to headache. Some systemic disorder like accelerated hypertension, viral fever can also cause secondary headaches. So first of all, we will discuss some of the common primary headache. And among primary headache, migraine and tension type are 2 most common headache. So first we will discuss migraine and what is the diagnostic criteria for migraine. A patient who is having recurrent episodes, recurrent attacks of headache, and at least 5 attacks should fulfill criteria B to D. And what is this criteria B to D? Headache should last for 4 to 72 hours. Headache should has at least 2 out of these 4 features. It should be unilateral, it should be pulsatile, it should be moderate to severe in intensity, it should be aggravated by routine physical activities, and it should be associated with at least 1 out of these 2, nausea and vomiting, photophobia and phonophobia. And lastly, this headache should not be attributable to other disorder. So migraine headache is very common among society. Almost 15% of general population is affected by migraine, more common in female, and in almost 50% cases, family history is positive. Common precipitants for migraine are caffeine, chocolate, alcohol, stress, hormone replacement therapy, etc. So what are the clinical characteristics of migraine? Basically, there are 3 phases of migraine. First is prodrome, second is aura, third is ictus, that is true headache. So prodrome may be non-specific. It usually occurs hours to days before headache in the form of irritability, mood disorder, mood swings, lethargicity, followed by some sort of aura. Most common type of aura is visual aura.
in which patient may feel scintillating scotoma, zigzag lines, blurring of images, flashes of light. This aura usually lasts for 5 to 60 minutes, followed by actual headache, that is ictus. Coming to treatment of migraine. Migraine is basically, there are two aspects of treatment. One is abortive treatment, basically treatment of acute attack, and second part is prophylaxis of migraine to prevent the occurrence of episodes. So in acute treatment, if patient is having mild episodes, you can use paracetamol or NSAIDs like ibuprofen, naproxen. But in moderate attack, you can use NSAID plus dopamine agonist like napradine, Exdom. Apart from these, we can use 5-HT1 receptor agonist. These are of two types, non-selective and selective. Among selective, we can use sumatriptan, rizatriptan, zolmitriptan, etc. But sometimes patient of migraine present in emergency with severe attacks of headache. In those cases, we can use sumatriptan subcutaneously or nasal spray of zolmitriptan or oral strips of rizatriptan. And rarely we use DEXA in single dose. This is basically to abort the acute attack of migraine. So coming to prophylaxis, when patient needs prophylactic treatment for migraine, basically prophylaxis is needed when a patient is having 3 or more than 3 attacks per month, which are causing impairment of his quality of life. What are the common prophylactic agents for migraine? First line agents are beta blocker, tricyclic antidepressants. Second line agents are topiramate, divalproex sodium, flunarizine, and other options are SSRI or SNRI. Some special consideration, if migraine patient is having comorbid hypertension, then our choice should be beta blocker. If migraine patient is obese, treatment of choice is topiramate, as this also causes weight loss. If migraine patient has comorbid depression, our treatment of choice should be tricyclic antidepressant, SNRI or SSRI. So coming to common case scenario, classical prototype patients. This 28-year female presented with headache for last 3 years. Headache was intermittent. Frequency was 6 to 8 attacks per month, and each episode starts with flashes of light for few minutes, followed by severe pulsatile headache, which usually lasts for 5 to 6 hours. And if she takes painkillers, this headache subsides early. Headache is usually more on one side, but side may switch. Sometimes it becomes holocranial. And during these headaches, she is not able to carry out her daily routine activities. On examination, there was no neurological deficit and there was no disc edema. So from this presentation, from this clinical picture, it is clear that patient is classically having migraine with visual aura. So in such type of cases, investigations are usually not required. Patient needs abortive treatment as well as prophylactic treatment. Coming to second variety of primary headache, which is very common, that is tension type headache. In this headache, basically patient should have recurrent episodes of headache, and at least 10 episodes should fulfill criteria B2D. And what is this criteria? Headache should last for 30 minutes to 7 days. Sometimes this headache for prolonged period, almost 7 days. Headache should has at least 2 out of these 4 features. Non-pulsatile in character, mild to moderate in intensity, usually bilateral, and this headache is usually not worsened by daily routine activities. And patient should have both of these following 2 features. There should be no nausea, no vomiting. But they may have one of 2, either photophobia or phonophobia. Treatment of tension type headache is very simple. Simple reassurance, relaxation, proper sleep, massage, or sometimes simple painkiller. But if patient is having recurrent headache and not responding to reassurance, simple painkillers, you may choose SSRI, SNRI or TCA, tricyclic antidepressants. Coming to other important variety of headache is chronic daily headache. When headache is present for more than 15 days in a month for consecutive 3 months, we termed it as chronic daily headache. Chronic daily headache may again be of 2 types, primary and secondary, depending upon presence of red flag symptoms and sign. And what are these red flag symptoms and sign? We will see in coming slides. 2 most common type of primary chronic daily headaches are chronic migraine and chronic tension type headache. So what is chronic migraine? If a patient is having migrainous headache for more than 15 days per month for consecutive 3 months, that is called chronic migraine. And here treatment of choice are topiramate, divalproex sodium, or sometimes Botox. What is chronic tension type headache? If a person is having tension type headache for more than 15 days per month for 3 months, usually CTTH is associated with anxiety and depression. So here treatment is usually SSRI, SNRI or TCS. What is trigeminal autonomic cephalgia? It is third important group of primary headache. When patient is having recurrent episodes of headache, and these headaches are associated with some autonomic features like lacrimation, redness of eye, nasal stuffiness, meiosis, sweating over face. These headaches, these primary headaches are termed as trigeminal autonomic cephalgia. Depending upon frequency of attacks and duration of attack, these attacks are divided into 4 categories: cluster headache, paroxysmal hemicrania, hemicrania continua, and last variety is Sankt and Suna. How to differentiate among these 4 category? Cluster headache usually have 1 to 8 episodes per day. Duration is 15 to 180 minutes. Paroxysmal hemicrania duration is almost 2 to 30 minutes, but episodes may be 4 to 10 per day. In hemicrania continua, headache persists for many days, even for weeks and months. And Sankt and Suna patient may have almost 100 attacks per day, but duration is very short, usually from few seconds to 10 minutes maximum. Some other variety of primary headaches are primary stabbing headache, primary cuff headache, exertional headache, hypnic headache, etc. So other important variety of headache is medication overuse headache. This is very interesting category. These are rebound headaches due to overuse of analgesics or prophylactic medicines. And in our OPDs, almost 25% patients who are referred for intractable headaches actually have medication overuse headache. Coming to secondary headaches. When headache is secondary to some structural pathology in head or outside head or some metabolic abnormality in the body. But in OPD, secondary headache accounts for less than 1%. But in emergency setting, almost 5 to 10% of headaches are secondary headaches. So how to differentiate? How you can differentiate secondary headache from primary headache? For this, there is a mnemonic SNOOP4. This is a very simple mnemonic with which we can easily differentiate secondary headaches from primary headache. What is this? As for systemic symptom, if patient is having history of fever, weight loss, jaw claudication, some underlying systemic disorder like malignancy, coronary artery disease, inflammatory bowel disorder, or history of trauma. So as for systemic symptom, and for neurological symptom or sign, if patient reports double vision, diminution of vision, behavioral or personality change, altered level of consciousness, or any sort of sensory motor deficit. O is for onset. If patient has sudden onset thunderclap headache, or if there is new onset persistent headache, this again becomes a red flag. If age of onset is more than 50 years, if a person more than 50 years present with new onset headache, this is again a red flag. Previous headache history. If a patient of headache has past history of headache, but there is sudden change in character and severity of headache, this again becomes red flag. Then papilloedema, pulsatile tinnitus, postural association, and precipitation by Valsalva maneuver. These all are features of secondary headache. We will see cases of secondary headache one by one with the help of cases. So this is our case number 2. This is 65-year male who is a known case of coronary artery disease and on regular treatment, dual antiplatelets and statins. He presented with headache for last 15 days. This headache was continuous, dull aching. There was no history of fever, nausea or vomiting. But on examination, patient was lethargic and there was slight pronator drift in right upper limb. So in this case, there are multiple red flags. Age is more than 65. Patient have underlying systemic disorder, coronary artery disease, and taking dual antiplatelets. Third is continuous headache for last 15 days. And fourth one is mild weakness in right upper limb. So this is probably a secondary headache. This patient was went for CT and CT was showing acute SDH on left side. So ultimately needed surgery. Next case, 45-year male presented with sudden onset excruciating headache for last 2 days, which was associated with recurrent vomitings. Sudden onset excruciating headache. And on examination, there was mild neck stiffness. Rest of the examination was normal. So in this case, two red flags are there: sudden onset excruciating headache of short duration, and second one is neck stiffness on examination. So CT was done, which showed blood in right sylvian fissure. So this is a case of acute subarachnoid hemorrhage. Fourth case, 48-year female, presented with headache for 6 months duration, episodic mild holocranial, no nausea, vomiting, visual symptoms, systemic complaint, but she reports slippage of sleeper from left foot and decreased left hand grip. On examination, there was bilateral disc edema, power on left side by 4/5, and left plantar was upgoing. So here red flags are papilloedema and left-sided weakness. MRI contrast was done, which showed large SOL on right side, right frontoparieto-temporal region. This is high-grade glioma, ultimately needed surgery. Next case, this 40 to 28-year female was admitted in gastro unit for active ulcerative colitis. Call was made for headache. This lady was having headache for last 7 days. This headache was continuous, severe, holocranial, and it was associated with nausea and vomitings. That headache was not responding to routine painkillers. So here two red flags are there: history of active ulcerative colitis, any underlying systemic disorder, and second is new onset continuous headache. So there are two red flags. On examination, fundus showed papilloedema, and rest of the neurological examination was normal. MRI was done, which is showing, yes, this subarachnoid bleed in sulcal spaces in right temporal region and ICH in right temporal region. Then CT angio was done with venous phase, which showed thrombosis in right transverse sinus and sigmoid sinus. So here diagnosis was cerebral venous sinus thrombosis, and patient was started on anticoagulation. Next case, this 30-year female presented with headache for last 1 year. She tells intermittent severe holocranial headache, but these headaches are more in early morning while in bed and relieves after assuming upright posture. I have already told that if headache has postural association, this again becomes a red flag. She also tells history about tinnitus and occasional vomitings. On examination, there was disc edema. Rest of the examination was normal. MRI was done, which showed empty sella, tortuous optic nerve, and prominent perioptic sheaths. These are features of raised intracranial pressure. CSF was done, which showed pressure of 350 mm of CSF. So here diagnosis was idiopathic intracranial hypertension. Patient was started on carbonic anhydrase inhibitor. This patient responded very well to carbonic anhydrase inhibitor like Diamox, but in some cases, if patient does not respond to carbonic anhydrase inhibitor, or in severe cases where vision is threatened, we have to go for CSF diversion procedure like VP shunt or LP shunt. This was our next case, 28-year female who delivered by lower segment cesarean section 2 days back for eclampsia. She presented with sudden onset severe headache for last 1 day. Then she had single episode of GTCS followed by altered sensorium. On examination, patient was stuporous. There was no disc edema, but plantars were bilateral upgoing. So in this case, red flags are sudden onset severe headache of short duration. Second is altered sensorium. So immediate MRI was done, which showed edema, white matter edema. White matter edema in bilateral parieto-occipital region. This condition is known as posterior reversible encephalopathy syndrome PRESS, and this condition is completely reversible with treatment. Next case, this 40-year female, recently married, presented with headache of 2 months duration. Headache was daily, continuous with occasional vomitings. There is no history of fever. She was also having low mood, so being treated for depression outside. But on leading questions, she told to have occasional diplopia, and on examination, there was bilateral disc edema. So here red flags are new onset daily headaches. Second, history of double vision, and on examination, there was papilloedema. So MRI contrast was done, which showed multiple ring enhancing lesion in both hemispheres. So here diagnosis was CNS tuberculosis, multiple tuberculomas. So coming to approach of headache, whenever a patient of headache come to your OPD or emergency, you should take detailed history in terms of duration, onset, whether onset was sudden or chronic, gradual, severity, it is mild in severity or severe in intensity, headache is daily or intermittent, is headache has any postural association, does it worsen with upright posture or lying posture, is there any underlying comorbidity, is there any drug history, history of trauma, or any systemic symptom. So history should include all these features, and after taking proper history, there should be meticulous neurological examination to find out any focal neurological deficit, any motor weakness or sensory deficit. You should do fundus examination to look for disc edema, and lastly, look for meningeal signs. If patient in history and examination if patient is having any red flag symptom or sign, you should always go for further investigation to rule out secondary headaches. So here I conclude my talk with saying headache is one of the common presenting symptom in OPDs and emergency in each specialty. Almost 1/4 patient in our OPD come for headaches, but good thing is most of the headaches are benign. Secondary headaches account for less than 1% case, but in emergency almost 10% cases are secondary headaches. Exact diagnosis of primary headache is mandatory for proper management. We should always keep in mind the red flag symptoms and signs to rule out the secondary headaches, and every patient of headache needs detailed clinical evaluation. Investigations are based upon our provisional diagnosis. Thank you.
Thank you, Dr. Abhishek,
Thank you, sir.
for great talk, because headache is universal thing. कि मेरा सिर दुखी जाता है, सिर दुखी जाता है, and generally what happens is phone ते बंदा कहता है कि Dolo 650 ले ला. Dolo is like, very staple diet. So great.
Simple mnemonic वाला चार्ट एक चार्ट अपन ओपीडी में भी रख सकते हैं ग्लास के नीचे. अगर ये फीचर है तो सेकेंडरी रूल आउट करना है.
So basically detailed history will clinch the diagnosis. That is clinical medicine is more important, but not that के headache आ गया जी, now battery of tests, and that is why we appreciate you as a clinician and great workup. So if there are any questions or additions, diabetes related headache.
Yes, sir.
Yes. One of the cause for headache
Definitely,
in diabetic patient, if the diabetic patient is having headache, especially early morning headache, or in between headache, one should rule out hypoglycemia. This is the message I give.
Systemic disorders, multiple systemic disorder present with headaches. Obstructive sleep apnea patients present with headache. Patient is taking nitrates for coronary artery disease, they present with headache. So, मतलब drug related, underlying disease related, there are many.
And sometimes it is fight or tension related also. कि माना लड़ते ऐसे यार सिर दुखन लग गया. Yeah, thank you very much.
Thank you, sir. Thank you.
Now till Dr. Puller gets his PPT ready, I'll invite Dr. Naveen Mittal. He's a great friend, great consultant from DMC, professor and head department of endocrinology. He will speak on diabetic ketoacidosis management. So it is pleasure to have you here during MAPICON. Thank you very much for coming. Thank you.
I am really thankful to Dr. Vitul for inviting me and giving me this opportunity to come to this place and interact with you people. What I am going to talk to you today is diabetes ketoacidosis. I tell my residents, it is very easy to remember about diabetes ketoacidosis. It has got 3 words: diabetes ketoacidosis. Diabetes means high blood sugar, ketones means ketones are positive, and acidosis means patient is having acidosis. So it is diabetes ketoacidosis. How you diagnose the patient to be suffering from diabetes ketoacidosis? Diabetes, blood sugar to be more than 200 milligram per deciliter, or patient is having prior history of diabetes. Ketosis, if blood ketones, beta hydroxybutyrate is more than 3 millimole per liter, or urine keto strip is showing 2+ ketones. Acidosis means pH should be less than 7.3 or bicarbonated less than 18 millimole per liter. 3 DKA, diabetes ketoacidosis. आ गया इसमें तीनों भाई, DKA. Initially we were considering blood sugar to be more than 250. Now the criteria has been changed to 200 milligram. Or even if the blood sugar is normal, patient is having history of diabetes and ketones are positive and acidosis is there, you diagnose the patient to be suffering from diabetes ketoacidosis. Another acute complication that comes to your mind is hyperosmolar coma. How would you differentiate between the two? Both are having polyuria, polydipsia and weight loss and dehydration, but nausea, vomiting and abdominal pain is more common in acidosis, and often diabetes hyperosmolar coma often co-represent with other acute illnesses. Ketoacidosis patient is usually alert, hyperosmolar coma patient is rather very drowsy or unconscious. Ketoacidosis develops in hours or days, hyperosmolar coma develops in days to week. Often patient is having other comorbid condition along with this, like cerebrovascular accident, myocardial infarction, pneumonia. But in diabetes ketoacidosis, patient might not be having underlying disease. Just stoppage of insulin might have led to the diabetes ketoacidosis. And 1/3 of the patient are having both the condition together. What are the causes of morbidity and mortality in diabetes ketoacidosis? First, you have to look for the precipitating illness. Myocardial infarction, stroke, sepsis, pancreatitis and pneumonia. Because if you don't take care of these things, these might take the patient away. Then patient can develop acute renal failure, acute respiratory distress syndrome, vascular thrombosis. Along with that, patient can develop shock, hypokalemia during treatment, hypoglycemia during treatment, cerebral edema or hypophosphatemia. You have to look for these complications and take care of them. What are the pathophysiology of decay? Why the patient develops a diabetes ketoacidosis? There is absolute insulin deficiency plus there is stress, infection or insufficient intake. So there is a counter-regulatory hormone excess. What are the hormones which oppose the action of insulin? Glucagon, catecholamines, cortisol and growth hormone. There is excess of these. What they lead to? Glycogen lysis means breakage of stored glucose and new protein synthesis, that is gluconeogenesis, new glucosenogenesis by protein lysis. Protein is broken down and it is converted to glucose. It leads to hyperglycemia, glucosuria, loss of water and electrolytes, dehydration and impaired renal function. Increased lipolysis. What it leads to? Increased lipids are catabolized. It leads to increased free fatty acids used, increased ketogenesis, increased ketones body formation, which are converted to keto acids. So what it ultimately leads to? Uncontrolled gluconeogenesis leading to hyperglycemia, osmotic diuresis leading to dehydration, unchecked ketogenesis lead to ketosis, which are broken down to hydrogen ions and ketones bodies, which leads to anion gap metabolic acidosis. So high blood sugar, dehydration and metabolic acidosis. Often a precipitating event like infection and lack of insulin is also there. How you diagnose a patient to be suffering from diabetes ketoacidosis? Any diabetic patient who comes to you with nausea, vomiting, thirst, polyuria, shortness of breath or abdominal pain, suspect the patient to be suffering from diabetes ketoacidosis. What do you feel on signs? What are the signs that you would look for? Tachypnea, Kussmaul respiration, respiratory distress, dehydration or hypotension, tachycardia, abdominal tenderness, lethargy, cerebral edema or possibly coma. What I tell my residents, any diabetes patient who is unconscious is dry, having difficulty in breathing, look for diabetes ketoacidosis. Any diabetes patient who is unconscious, is wet, is sweating profusely, it is hypoglycemia. So these are the differential. So clinically, any diabetic patient having nausea, vomiting, having difficulty in respiration and dry, look for diabetes ketoacidosis. How you confirm the diagnosis? Just check the blood sugar with glucometer, more than 250, check the blood ketones, more than 3 millimole per liter, or check the urine ketones, more than 2 plus, patient is diagnosed to have diabetes ketosis. If you have got the facility of a ABG, get the ABG, pH is less than 7.3, patient is having diabetes acidosis as well. Such an easy thing to make a diagnosis. So you have made a diagnosis of diabetes ketoacidosis. High blood sugar, ketones are positive, patient is acidotic clinically and biochemically. How you are going to manage the patient? First is where to keep the patient. Assess the severity of patient, diabetes ketoacidosis. Look at the mental status. Patient is stuporous or coma, it is severe ketoacidosis. Patient is drowsy, it is moderate. Patient is alert, it is mild. Look at the pH. pH is less than 7, it is severe ketoacidosis. 7 to 7.25 moderate. 7.25 to 7.3, it is mild ketoacidosis. So what an easy diagnosis. Look for the bicarbonate. More than 6, severe ketoacidosis. 3 to 6, moderate. 3 to 6, mild. More than 6, it is severe ketoacidosis. So a patient who is stuporous or comatose, pH is less than 7, bicarbonate more than 6, is severe ketoacidosis, should be managed in ICU. Patient who is drowsy having moderate ketoacidosis might be managed in HDU, and patient who is alert having mild ketoacidosis might be managed in general ward as well. This is one page statement which is available on the net. You can put it in your emergency, all the nursing homes, and to manage so that your junior resident can manage the ketoacidosis themselves. What are the 3 basic principles to manage the diabetes ketoacidosis? IV fluids, number 1. Second is potassium. Third is insulin. It is not that the insulin comes number 1. First thing is IV fluid, IV fluid, IV fluid. Then you have to take care of, we would discuss each and every step, IV fluid, potassium and insulin. First thing you have to give IV fluid. Then avoid hypoglycemia during the treatment. Give the dextrose when the blood sugar comes below 250. And transition to subcutaneous insulin is also important. So first thing we are going to discuss is fluid for diabetes ketoacidosis. When the patient comes to you, first thing is to start with normal saline. 1.5 liters over 2 hours, 500 ml rush, next 500 ml rush, next 500 ml rush. 1.5 liters in 2 hours. By the time if the sodium report is available, depending on the sodium level, if the patient is having low sodium, give normal saline. If the patient sodium is normal or high, give half normal saline at the rate of 250 ml per hour. But when the blood sugar becomes less than 250, by fluids and by insulin, give dextrose 5% or dextrose normal saline. Don't stop the insulin and don't continue with the normal saline when the blood sugar is less than dextrose, when the blood sugar is less than 250. Because if you don't give the dextrose at that time, patient would land up in hypoglycemia. So fluid, first thing to be given is normal saline fast at about 700 ml at 800 ml per hour, 1.5 liter in first 2 hours, then shift to 200-250 ml per hour. Then when the blood sugar comes less than 250, shift to dextrose. This is the IV fluid. Fluid, fluid, fluid. This is the treatment. This is the first line treatment. Then comes insulin. Insulin is for the management of acidosis, not only to lower the blood sugar. Whenever we speak about insulin, इंसुलिन देना है डायबिटीज कीटोएसिडोसिस में, मैं अपने रेजिडेंट से पूछता हूँ वन कॉन्ट्राइंडिकेशन टू गिव द इंसुलिन इन डायबिटीज कीटोएसिडोसिस. आप सबको पता है इंसुलिन देना कीटोएसिडोसिस में। एक कॉन्ट्राइंडिकेशन भी है, किसमें आपने इंसुलिन नहीं देना? इफ द पोटाशियम इज लेस देन 3.3, don't give insulin. First you correct the potassium, then you give the insulin. If the potassium is more than 3.3, give insulin. If it is less than 3.3, first correct the potassium, then you give the insulin. If pH is less than 7 or some people say less than 6.9, then only give the bicarbonate. Insulin is given to correct the acidosis and correct the anion gap, but also to low blood sugar. But even the blood sugar has become normal. If acidosis is persisting, continue to give the IV insulin. What should be the rate of giving the insulin? How much insulin you should give? This is an important thing to remember. कि इंसुलिन देना कितना है? आपके पास कीटोएसिडोसिस का पेशेंट आ गया, 0.1 यूनिट पर केजी पर आवर एट स्टैट पेशेंट को इन्फ्यूजन में देना है. इन्फ्यूजन लगने को टाइम लग गया, घंटा लग गया, आधा घंटा लग गया, इन्फ्यूजन पंप इज नॉट अवेलेबल, गिव एन IV पुश 0.1 यूनिट पर केजी स्टैट. 60 किलो का पेशेंट आया आपके पास, 6 यूनिट इंसुलिन उसी को लगा दो उस समय IV. देन स्टार्ट विथ 6 यूनिट्स पर आवर विद इन्फ्यूजन till the blood sugar comes less than 250. When the blood sugar is less than 250, reduce the rate to half. That is about 3 units per hour. Along with that, you give the patient dextrose. But this rate is not 100%. This depends on patient to patient. आपके पेशेंट का शुगर कम ही नहीं हो रहा, आपने उसको 6 यूनिट्स पर आवर पे इंसुलिन दिया. What should be the optimal rate of fall of blood sugar in a diabetic patient? About 30 to 50 milligram per hour. पेशेंट का शुगर कम नहीं हो रहा, आपका पेशेंट आया 460 ब्लड शुगर है, 2 आवर्स बाद भी उसका 450 ही है. वुड यू कंटिन्यू विद द सेम डोज ऑफ इंसुलिन? नो, इंक्रीज बाय 25%. इफ द ब्लड शुगर फॉल इज नॉट ऑप्टिमल, इंक्रीज द रेट बाय 25%. Even if the patient is not responding, you are giving proper IV fluids. पेशेंट को फ्लूइड भी दे दिया 2 लीटर, 2.5 लीटर, 3 लीटर. Even then the blood sugar is not falling, might be you have to give more insulin. Patient is having severe infection. Insulin resistance है patient का. Patient obese है, might be 0.1 unit per kg is not acting. So this dose is not generalized rule, but you have to see the individualize the treatment depending on the patient. So हमने फ्लूइड डिस्कस कर लिया, इंसुलिन डिस्कस कर ली. पोटाशियम, आपके पास पेशेंट आया, उसका पोटाशियम इज अराउंड अबाउट 5.2, 5.3. पेशेंट का पोटाशियम तो नॉर्मल है. शुड वी गिव द पोटाशियम टू दिस पेशेंट? यस, पोटाशियम हैज टू बी गिवन because life-threatening hypokalemia can develop during insulin treatment. Potassium re-enters the cell when you give the insulin, and extracellular potassium falls suddenly. In a diabetes ketoacidosis, because of osmotic diuresis, potassium is lost in the urine, and patient is having potassium deficiency as well. What are the guidelines to replace the potassium? If potassium is between 3.3 to 5.2, in each dextrose 5% or each normal line you give 1 ampule of potassium chloride, 20 milliequivalent of potassium in each 1 bottle of dextrose 1 bottle of normal line. That would be sufficient. But if potassium is less than 3.3, give only normal line with potassium, don't give insulin, as already have been discussed. But if the potassium is more than 5.2, don't give the potassium. First give the normal line, first give the insulin, bring the potassium less than 5.2, then only give the potassium. अब मेरे पास रेजिडेंट पूछते हैं, सर हमारे पास तो पोटाशियम की रिपोर्ट 3 घंटे बाद आती है. पेशेंट आपके पास आ गया, पहली बॉटल में दूसरी बॉटल में आपने पहले 1 लीटर फ्लूइड दे दिया, 1.5 लीटर दे दिया. अब पोटाशियम देना या नहीं देना कैसे डिसाइड करें? रिपोर्ट तो अपने पास है नहीं. And ABG is there, in DMC ABG is there. Many of the centers are not having the facility of ABG. Then how would you decide whether potassium has to be given or not? Look at the patient clinically. Patient is passing good amount of urine. Get an ECG. ECG is not showing hyperkalemia, tall T wave, replace the potassium. If the patient is anuric, Patient is not passing urine, get an ECG, ECG is showing tall T wave, don't give the potassium. ECG is showing U waves, give potassium, don't give the insulin. So you can detect the potassium level, have the estimation of potassium level by an ECG done at the 0 time without having the serum potassium level from the lab, which would come after 3 hours. So potassium की guidelines हो गई, अब IV fluid की guidelines हो गई, insulin की guidelines हो गई, contraindication to insulin हो गया, potassium की contraindication हो गई, potassium की indication हो गई. Fourth thing people ask, when should you give bicarbonates? Bicarbonate, 99.90% of the patient would not require bicarbonate administration. It should be given only if the pH is less than 6.9, patient is unconscious and on vasopressor, not responding to IV fluids. Then only you should give soda bicarb. That also 1 ampule in half normal saline over 1 hour until the pH is more than 7. After that you should not give soda bicarb. Why? Because it leads to hypokalemia and it shifts the oxygen dissociation curve to the left, patient develops hypoxia. You should avoid soda bicarb as much as possible in diabetes ketoacidosis. Treatment of diabetes ketoacidosis is IV fluid, insulin and potassium. Soda bicarb should be given only in a desperate situation. Okay. Patient को आपके पास आया unconscious, you have given the IV fluid, you have given the insulin, you have given the patient potassium, patient has become conscious, patient has started taking orally. अब क्या करना है? When the patient has become conscious, semi-solid or liquid diet patient has started accepting, you should shift the patient to subcutaneous insulin. What are the criteria in which patient should be shifted from IV insulin to subcutaneous insulin? When the blood sugar is less than 200, venous pH is more than 7.3, bicarbonate are more than 15, in iron gap is less than 12 milliequivalent. You should start with subcutaneous insulin. Although ketones might be positive even at that time, you should not you should not that the ketones are negative, only then you would stop the IV insulin. If the pH is resolved, bicarbonate has become normal, blood sugar has become controlled, you can shift to subcutaneous insulin. How you shift the patient from IV insulin to subcutaneous insulin? What is the dose you have to give? First thing, how much, when you should give? When the patient has started taking orally or accepting relative feed, acidosis has disappeared, start subcutaneous insulin. Which insulin to be given? Both basal as well as rapid acting. Analogs are better than the traditional with the human insulin because it leads to less of hypoglycemia. Important thing is there should be an overlap between the IV insulin and subcutaneous insulin. When you give subcutaneous insulin, IV insulin should be stopped 2 hours after giving subcutaneous insulin. Why? Because subcutaneous insulin को काम करने में थोड़ा टाइम लगेगा. यदि आप IV insulin इधर से बंद करो, subcutaneous दो, 2 hours would be there when there are no insulin in the body, or 1 hour would be there when there is no insulin in the body, और patient को फिर से ketoacidosis में चला जाएगा. So there should be an overlap of 1 to 2 hours before you stop the IV insulin. Dose calculate करना कैसा करना है subcutaneous insulin का? There are 2 or 3 ways. One thing is you calculate how much insulin patient is requiring in last 24 hours IV insulin. You give the subcutaneous according to that. If patient has just stopped the insulin, patient is already on insulin and there is no infection, you can start with the subcutaneous insulin whatever the patient was taking at home. But if the infection was there, you see the IV chart, how much insulin a patient has received in 24 hours, you decide the rate according to that. If patient is insulin naive, newly diagnosed type 1 diabetes, you can start with 0.6 or 0.7 units per kg per day. This is the approximate dose of the insulin that you should give to the patient. Use early insulin in basal insulin as well to prevent the rebound hyperglycemia during the insulin infusion. Cerebral edema usually seen in pediatrics age group, having high mortality, what the studies have shown, insulin dose in first 2 hours is significantly associated with high risk of cerebral edema, and it is not the rate of fluid administration which is responsible. If you diagnose the patient has become conscious, suddenly he loses consciousness, becomes drowsy, get a CT scan. CT scan is showing there is an edema, give the patient mannitol. Okay, patient has improved. What are the pitfalls? हमें analyze भी तो करना है, हम कहाँ गलती कर सकते हैं. What are the pitfalls in the management of diabetes ketoacidosis that you should be take care of? Not assessing or treating the underlying cause of diabetes ketoacidosis. Ketoacidosis तो बना लिया, लेकिन patient को ये सोचना है patient ketoacidosis में गया क्यों? Either it is a stoppage of insulin, okay, or patient has developed some infection. Patient को pneumonia है, pneumonia का IV antibiotic नहीं दिया, patient ठीक नहीं होगा. Or patient has got myocardial infarction, must get an ECG. It would tell you about potassium level, but it could also tell you patient might have silent myocardial infarction. 35 years old male है, diagnosed है diabetes का, पिछले 5 साल से diabetes है, और 40 years male है, आपके पास आया, young patient है, silent myocardial infarction might be there, and you are missing altogether. Must get an ECG, look for a precipitating cause. If you don't treat the myocardial infarction, just treat the diabetes ketoacidosis, you might not be able to save the patient. Look for the underlying cause. Patient is unconscious. Sensorium improve नहीं हो रहा. Look के patient को देख लो या कहीं patient को cerebral vascular accident ही ना हो साथ में. You have to treat it according to that. Patient was having mild pain abdomen. Patient का pain abdomen नहीं ठीक हो रहा. आपने IV fluid भी दे दिया. Look for यार कहीं patient को pancreatitis ना हो, underlying cholecystitis ही ना हो. Look for the underlying cause. Take care of these things. If you don't take care of the underlying pathologies, patient would never improve. Not watching potassium closely and monitoring replacing the potassium aggressively. Almost all the patient of diabetes ketoacidosis will require the potassium replacement. If you don't replace the potassium, patient are going to have hypokalemia, patient is going to have arrhythmias. The third thing is falling urine ketones rather than serum ketones. Urine में ketones बहुत late disappear होंगे, serum ketones जल्दी हो जाएंगे. So blood ketones कराने हैं, serum ketones को follow नहीं करना. Interrupting IV insulin too soon, कि patient का sugar तो control हो गया, चलो यार अब IV insulin की जरूरत नहीं है, patient hypoglycemia में ना चला जाए. No, you have to give IV insulin till the acidosis has disappeared. You have to give dextrose along with insulin. Don't stop the insulin when the blood sugar has just come to 50. Unless acidosis is corrected, patient would never improve. Then occurrence of rebound ketosis consequent to inadequate insulin dosing at transition. आपने subcutaneous insulin नहीं शुरू किया तो पेशेंट को रीबाउंड कीटोसिस हो जाएगा. चलो ये भी कर लिया आपने, सबक्यूटेनियस इंसुलिन भी दे दिया, पेशेंट इंप्रूव भी कर गया, पेशेंट खाने पीने भी लग गया. बिफोर डिस्चार्ज यू हैव टू गिव द पेशेंट, टेल द पेशेंट दैट ही शुड नॉट डेवलप द कीटोएसिडोसिस अगेन. सिक डे रूल्स पेशेंट को समझाने हैं. If the patient gets an infection, patient gets the fever, patient has to travel outside, how he should carry the insulin, what are the precautions if the patient becomes ill, क्या करना है उसने उस समय. I tell the patient, patient is having nausea, vomiting, patient is not able to take any much orally. Diabetic patient है. अब patient क्या करेगा, सर मेरे को vomiting हो रही थी, fever हो रहा था, मेरे से खाया नहीं गया कुछ भी, इंसुलिन बंद कर दी मैंने, खाया ही नहीं जा रहा तो मैं इंसुलिन नहीं लूँगा ना, मैं हाइपोग्लाइसीमिया में ना चला जाऊँ. No. The patient would land up in diabetes ketoacidosis. If patient is type 1 diabetes or patient type 2 diabetes who is on insulin is not able to take much, not able to eat much, he should take small fluids, small amount of fluids. Might be with some sugar and with some of the नींबू पानी बना के उसमें थोड़ी सी चीनी डाल के पीता रहे. Check his blood sugar repeatedly and depending on the blood sugar he has to take the insulin. If the patient is able to take orally and patient is having fever, acute infection, his blood sugar would rise. Why? Counter regulatory hormones ज़्यादा होंगे, cortisol ज़्यादा होगा. Diabetic patient able to take it or able to consume orally, having the fever, he should increase his insulin dose by 25% if the ketones are positive. Then the third thing patient पूछता है कि मैंने travel करने जाना है, मैं सर घूमन जाना जी आज अपने हिल स्टेशन ते जाना है. How should I carry my insulin along with that? मैं 5 दिन लिए बाहर जा रहा, कल भी मैंने एक बड़े बंदे ने पूछा मैं दुबई घूमन जा रहा सर 5 दिन लिए मैं इंसुलिन बंद कर देना की फर्क पैंदा, कित्थे लेके जाऊँगा, मैनू प्लेन वाले मना कर देंगे इंसुलिन लेके जाना. No, you have to carry insulin along with you when you are going out. How you should carry it? I tell the patient, एक तो है इंसुलिन आइस पैक्स में ले जाओ, बट यूजली वो 4 to 6 आवर्स रहते हैं और कई जगह रेफ्रिजरेटर नहीं मिलता, तो उसमें आप होटल में ना रेफ्रिजरेटर नहीं मिलता, वैसे ठंडा हो जाता है लेकिन उसमें फ्रीज नहीं होगा, फ्रीज़र नहीं होता, उसमें जमेगी नहीं इंसुलिन, आपको यदि लेके जाओगे तो. व्हाट हाउ आई टेल माई पेशेंट हाउ यू शुड कैरी द इंसुलिन लॉन्ग विद दैट. एक थर्मस ले लो, थर्मस जो कि बच्चे पानी लेके जाते हैं जिसमें ठंडा रहता है पानी, उसमें आइस पैक, उसमें उसमें इंसुलिन रख दो प्लास्टिक के लिफाफे में और ऊपर से बर्फ़ रख दो, आइस रख दो. कहीं भी जाते हो 6 घंटे बाद आपने कहीं खाना खाने रुकना है, इत्थों दिल्ली जाना यार, दिल्ली जाना, दिल्ली जाके फ्लाइट पकड़नी है, नाल ले जाओ, कितने रोटी खान रुकोगे, जिथे खाना खान रुकोगे, किसी रेस्टोरेंट च रुकोगे, अपने यूजली सुखदेव ढाबे रुकते अपने सारे पंजाबी, वहाँ पे रुके, वहाँ पे जो अपनी वो बर्फ़ का पानी बन गया उसको फेंक दो, वेटर को बोलो नया बर्फ़ उसमें डाल दो, अगले 6 घंटे आपका इंसुलिन फिर से कैरी हो जाएगा. फिर पेशेंट मेरे से पूछता है सर मैं फ़्लाइट में कैसे लेके जाऊँगा, मुझे तो दुबई जाना है, मेरा तो प्रॉब्लम हो जाएगा, अंदर इंसुलिन लेके नहीं जाने देंगे. व्हाट द पीपल टेल यू कि फ़्लाइट वाले क्या कहते हैं 100 ml तक लिक्विड लॉ करते हैं. क्या मेरे को किसी एयरपोर्ट वाले ने बताया था कि 100 ml से लिक्विड से ज़्यादा लेके जाओ तो उससे बॉम्ब बन जाता है. तो मैं क्या कहता हूँ पेशेंट को क्या करना है, जब आपने सिक्योरिटी चेक के लिए जाना है, मेरा स्लिप साथ में ले जाओ कि आपको इंसुलिन की ज़रूरत है. जब सिक्योरिटी पे गए, थर्मस में अपनी इंसुलिन रखो, अप टू 10 वाइल्स यू कैन कैरी, 100 ml हो गया, 10 ml की वायल है, जो बर्फ़ है सारी फेंक दो, सिर्फ बॉटल में इंसुलिन रखो. सिक्योरिटी को क्रॉस किया, वाइन वाली शॉप पे जाओ, वहाँ से बर्फ़ फिर से ले लो, बर्फ़ फिर से डाल लो उसमें. मुझे कहता है पेशेंट की बर्फ़ कहाँ से मिलेगी एयरपोर्ट पे और फ्लाइट में, वाइन वाली शॉप पे जाओ यार, हर जगह इंसुलिन मिल जाएगी ऑल ओवर द वर्ल्ड, वहाँ से बर्फ़ लेके उसमें डाल लो, आप इंसुलिन कहीं भी कैरी कर सकते हो. फिर पेशेंट पूछता है सर फिर से आगे से जब मैं सिक्योरिटी पे जाना है, फ़्लाइट पड़नी है, फिर से मेरे को प्रॉब्लम आएगी, उस समय बर्फ़ फिर से फेंक दो, यदि वो सिक्योरिटी वाले कवर करते हैं, अंदर जो एयर होस्टेस है उसके पास तो बर्फ़ पड़ी होगी ना, उससे ले लो. सो यू कैन कैरी द इंसुलिन लॉन्ग विद इट वेयर एवर यू गो. And don't put the insulin in the luggage bag, always carry it in your hand, with your hand. Okay? Then inadequate patient education and training can lead to ketoacidosis. And then you must call the patient of diabetes ketoacidosis for the follow-up after 1 week and see how the patient is doing. Because inadequate follow-up would land up the patient again in ketoacidosis. ये बड़ा इंपॉर्टेंट है SGLT2 inhibitor. For last 5 to 10 years we are using SGLT2 inhibitors and now GLP-1 receptor agonist in type 2 diabetes. होता क्या है, when you are using SGLT2 inhibitors, they shift the metabolism from glucose metabolism to fat metabolism, predisposing the patient to ketonemia and diabetes ketoacidosis during SGLT2 inhibitor use. And these patients might be having normal blood sugar and modestly elevated blood sugar, and yet they land up in ketoacidosis. So a patient who is using SGLT2 inhibitor is not feeling well, having nausea, vomiting, is dehydrated. You have checked his blood sugar is 200, but must check the ketones. And you can diagnose the patient having euglycemic ketoacidosis. Means blood sugar is less than 200, even then ketoacidosis is there. That's why criteria for diabetes ketoacidosis has now been changed. It is not only the high blood sugar, but presence of diabetes with ketones positive is ketoacidosis. So if you are diagnosed the patient to be suffering from diabetes ketoacidosis, what you should do? Patient is having on SGLT2 inhibitor. Stop SGLT2 inhibitor immediately if symptoms of diabetes ketoacidosis are there. If patient has to undergo emergency surgery, stop SGLT2 at that time. If it is an elective surgery patient को cholecystectomy करना है, hysterectomy करना है, उसको 24 hours पहले SGLT2 बंद करो. और एंटिसिपेटरी स्ट्रेस एक्टिविटी, पेशेंट ने मैराथन करनी है, बहुत ज़्यादा फिजिकल एक्टिविटी करनी है, इस संडे तो आपका बहुत भजना है जी, 15 किलोमीटर की सैर करनी है, सैटरडे संडे SGLT2 नहीं लेने, फ्राइडे ले लिया बहुत है. एंड थर्ड थिंग, डायबिटीज कीटोएसिडोसिस in SGLT2 measure blood ketones. Urine ketones might be negative and only blood ketones might be positive. What are the precipitating factors for SGLT2 induced diabetes in SGLT2 patient for diabetes ketoacidosis? There is a mnemonic derails. What it is, if the patient having decreased intravascular volume like diarrhea, vomiting and exercise, it can lead to ketoacidosis. Or ketones prone states like reduced oral intake, alcohol intake, inpatient hospitalization, LADA, latent autoimmune diabetes in adults, or surgery. These can lead to ketoacidosis. So you have to be extra careful about these patients. What are the complications of diabetes ketoacidosis? Hypokalemia and hyperkalemia, you have to monitor the potassium and correct it accordingly. Hypoglycemia, you have continued to give the patient insulin and have acidosis persisting but have not started with dextrose. So when the blood sugar falls less than 250, must give the patient DNS or dextrose 5%. Cerebral edema in pediatrics age group. How I would summarize my talk. Diabetes ketoacidosis and hyperosmolar coma should be suspected any patient with diabetes who is ill, and if you diagnose patient to be suffering from diabetes ketoacidosis, look for precipitating factor and treat it. These are medical emergencies who are having multiple metabolic abnormalities. It is not that only high blood sugar is there. Patient is fluid deficit, patient might be having hypokalemia, and patient is having acidosis. You have not to treat only the high blood sugar. You have to treat fluids, you have to treat potassium, you have to treat acidosis. Third thing, normal patient आपके पास सिक आया, डायबिटिक पेशेंट, आपने सस्पेक्ट किया कीटोएसिडोसिस है, लेकिन उसका शुगर चेक किया जस्ट, शुगर इज 200 or 250, it does not rule out diabetes ketoacidosis, especially a person is pregnant or the person is using SGLT2 inhibitor. Euglycemic ketoacidosis is well known entity. Diabetes ketoacidosis requires IV insulin for its resolution. Thank you. So, any question from the audience?
For great tips, especially the pitfalls while managing the diabetic ketoacidosis. Those are really important to give patient appropriate care and treatment of diabetic ketoacidosis. Any comments or addition?
Dr. Naveen, you explained the topic very well. It was fantastic talk. You explained each and every part of ketoacidosis very well. My one query is there. Suppose myocardial infarction is a precipitating factor for diabetic ketoacidosis. The fluid management remains same, because in MI we used to give less amount of the fluid, not that much.
Yes, you are absolutely right, ma'am. One of the thing is, important message is, myocardial infarction can precipitate diabetes ketoacidosis. Patient has come to you with diabetes ketoacidosis with myocardial infarction. Would you give the same fluid? It depends on the ejection fraction of the patient. You have to see the patient clinically first. Elevated JVP and edema feet, you have to restrict the fluids. If you have got the facility for echocardiography, I would get an echocardiogram. If the patient is having reduced ejection fraction, I would reduce the fluid intake. Now the facility is there, you can get the BNP levels. BNP levels are elevated, I would restrict the fluids. BNP levels are normal, patient is clinically not having raised JVP, no edema feet, chest is not showing any clefts, and echo is normal, I would give the normal fluids. I would give the fluids as recommended in diabetes ketoacidosis, depending on the clinical situation of the patient. Yes, ma'am. And if the facilities are available, you are in a very multi-specialty hospital, you can get a help of the cardiologist, If the person can, he can put the Swan-Ganz catheter and you can give the fluids accordingly. If you are just having an internal medicine facility like me, you can put the central line and you can give the fluid according to that.
So thank you very much, Dr. Naveen, for an enlightening talk. We are really honored to have you here in Bathinda. Thank you very much.
Thank you, sir. Thank you, sir.
So next I invite Dr. Swaranjit Singh Pullar to talk on rather important topic which has gained importance after COVID, approach to a patient of interstitial lung disease. Dr. Pullar, please.
So thank you. Thank you. Before I start a talk, I should thank you, Dr. Vitul, and the entire MAPICON organizing committee for giving me such a honor to present this small talk on a patient, approach to a patient with interstitial lung disease. It will be a concise evidence based informed clinical guide. I will try to short it as much as possible. So, don't worry, but I try to be on time. So, what are the learning objectives from today's talk? It is basically understanding the classification and the common causes of ILD and recognizing the key HRCT patterns and their diagnostic implications. Outline a stepwise diagnostic workup like histories, PFTs, HRCTs, serology and pathology. Reviewing the contemporary management strategies including antifibrotics, immunomodulation and supportive care, and how to monitor, how to referral criteria and the prognostic factors in the ILD. So what is an ILD? These are basically not a single disease. It's a group of 200 disorders causing an inflammation or fibrosis of a lung interstitium. It ranges from reversible inflammatory disease to a progressive fibrosing ILD. So what are the key concepts? Basically, it has clinical, radiological and pathological patterns which basically label a separate every separate ILD, and they helps in guiding the diagnosis and treatment of that particular ILD. All ILDs are not same, all ILDs, the treatment is not same, the investigations are not same. So the epidemiology, incidence and prevalence are always vary by region and subtype. In India, the most common cause of ILD is hypersensitivity pneumonitis, but all over the world, the most common cause is the interstitial pulmonary fibrosis. Out of that, the progressive fibrosing phenotypes, they carry the highest morbidity and mortality. And the timely diagnosis of these diseases improves the management options and outcome. So these are the classification of ILD. We'll not go into too much of detail. The most important being is, these are the idiopathic interstitial pneumonias. So all of these lists in IIPs, basically these are idiopathic interstitial pneumonias. It includes idiopathic pulmonary fibrosis, idiopathic NSIPs, RBILD, desquamatic pneumonia, cryptogenic organizing pneumonia, earlier it was called as BOOP, then acute interstitial pneumonia, idiopathic lymphoid interstitial pneumonia, idiopathic pleuroparenchymal fibroelastosis, and other unclassifiable IIs. Second most important classification is the autoimmune ILDs. Autoimmune ILDs like in Sjogren's syndrome, SLE, rheumatoid arthritis, systemic sclerosis, mixed connective tissue disorders, polymyositis, dermatomyositis, all of these can cause various presentation of ILDs. So these are radiological presentations like cryptogenic organizing pneumonia, NSIP, UIP. So all of these, if they come in a CTD, in a connective tissue disorders, we label it as an interstitial pneumonia or an ILD with autoimmune features, something like that. So all of these has a different treatment lines. Then coming to hypersensitivity pneumonitis. Hypersensitivity pneumonitis is the most common cause of ILD in India. The most common being the farmer's lung and the pigeon breeder's lung, basically to the bird proteins.
and it is a specific hypersensitivity reaction to a bird proteins. Then we have another set of ILDs, sarcoidosis. Sarcoidosis is entirely a different ball game, a totally a different disease, but it is also a ILD, but it has a granuloma as a specific feature. Then other ILDs like lymphangioliomyomatosis, specifically in ladies, then Langerhans cell histiocytosis in males. Drug-induced ILD like codron, amiodarone can cause drug-induced ILDs, bleomycin, busulfan, anti-cancer drugs, all of these can cause drug-induced ILDs. Radiation can cause drug-induced ILD. Even paraquat oxygen, sometimes high amounts of FiO2 can cause a drug-induced ILD. Then ILD is related to occupational exposures like silicosis, pneumoconiosis, and other asbestosis. Then we have ILDs related to vasculitis and granulomatosis diseases like we have in Churg-Strauss and Wegener's granulomatosis. And then there are a lot of other rare ILDs. So we will be only going into the common ILDs what we found in our country and we in routine practice. So what are the clinical presentation? I think everyone knows the symptoms are same: progressive exertional dyspnea with a non-productive cough, fatigue, and signs specifically, classic signs are bivascular velcro crackles, but they may not be present in all ILDs, but if they are present, they are very characteristic of ILD. Then digital clubbing, oxygen desaturation on exertion. Already if there is an oxygen desaturation on rest, if the saturation is less than 90% on rest, then you may think about it as the disease is already far more progressed. But most of the diseases in OPD practice, you can see if you just take patient to walk, do a 6-minute walk test or some exercise, they will have a desaturation. What are the red flags in ILD? In clinically, always important to see in OPD practice is the rapid progression. Any rapidly progressive ILD, it is a red flag. Then any significant hypoxemia. I've already told, if your baseline saturation is less than 90% in OPD, then definitely that is a red flag. Then any hemoptysis in ILD. Hemoptysis is not the symptom of ILD, but if there is a hemoptysis, there may be some complication or some vasculitis that already has developed. Then any systemic sign suggesting CTD. Systemic signs means if it is a systemic signs, that means the disease may not be only involving the lungs, disease may be involving other organ systems like kidneys, liver, brain, cardiac, like in sarcoidosis or CTDs. So any systemic manifestations are red flags. Now coming to the history and examination, always take a detailed occupational history. Very, very important history. What we found is, if I see a suspected ILD in our part, especially in Punjab, always ask for, one is the occupation is the farmer's lung and the second is bird fancius. I have seen this disease in pigeon breeders. Here in like areas around Bathinda, you will see a lot of rural population, even in urban population, people keep pigeons as a recreational purposes for different, they play with the different games or do a betting on with their on the pigeons. So they have like 200, 250 pigeons somewhere in their own house. Most of my hypersensitive pneumonitis I have seen the exposure to pigeons is significant. So that is the most important thing. And second history you always take is, I have also seen it in poultry farms. So people working in poultry farms are owning a poultry farms. So there also the exposure to bird feathers are pretty high. And so these are the common occupations in our part. Outside Punjab, you can see coal worker, silicosis, asbestosis. You have to take the different occupations in mind. Then coming to environmental, we have already discussed about the farmers and the pigeon breeders. Coming to the drug history, codron is very commonly used. So always take a drug history of codron. Always take a drug history of methotrexate, bleomycin, busulfan, all of these drugs. Any background history of radiation. Sometimes I see in practice radiation pneumonitis in a patient who was having a breast cancer some 20 years back, got some radiotherapy later on, and then you see a particular ILD in that particular on single side. Then you most probably you can correlate with that
drug or a medical history. Then smoking history. If patient is smoker, the chances of IPF increases. Idiopathic pulmonary fibrosis, 90% of idiopathic pulmonary fibrosis are smokers. It is very difficult to label IPF in a non-smoker patient. Second is Langerhans cell histiocytosis. Most of these patients are smoker. Good pasture syndrome, these patients are smoker. So all of these diseases, they have a very, very strong association with smokers. Now coming to exposures to birds, molds, hot tubs, we have already discussed this. Then important thing is systemic symptoms. Systemic symptoms, especially in connective tissue disorders like presence of arthralgia, presence of Raynaud disease, presence of rash, presence of salt and pepper appearance, presence of any small joint pains, sclerodactyly, other skin thickening. All of these are very, very important. Whenever we see an ILD, the first thing we see, all of this systemic manifestation, at least 10-20% of the ILDs, you will have some connective tissue clearly sitting there. Now coming to the initial investigations, most important investigations are CBC, we all know renal, hepatic panels, autoimmune serology like ANA. ANA should always be done by immunofluorescence and not by ELISA. That is a recommended thing. And if ANA is positive, it should be followed by ENA profile where all the antigens should be worked upon, and even a myositis panel should also be asked for. Then anti-CCP and RA factor for ruling rheumatoid arthritis. Then for the functional status of the patient, we have to do the baseline saturation, 6-minute walk test, pulmonary function tests including a routine spirometry to look for FVC, and diffusion capacities to look for DLCO. This is the minimum workup that has to be done in all ILD patients. Now, most important thing in an ILD after the basic investigation is the CT. The entire treatment, the entire management of ILD is based on HRCT. There is a significance of pathology also, but the most important test, if somebody asks you which is the most important test, the entire ILD is sitting on basically the role of HRCT. So every ILD should be subjected to HRCT. So what are the high resolution tests which are pattern recognition? The pattern recognitions are UIP, NSIP, OP. Will go into this. HRCT can allow a definitive diagnosis of IPF when definitive UIP is present in a particular history. It also describes the distribution, whether a disease is subpleural versus peribronchovascular, extent of the disease, the extent of fibrotic part of the disease, and features of activity. The more the fibrosis, the disease progresses, already there is a significant disease progression and patient may not respond that well to treatment. If there are features of activity, then whatever treatment you are offering, there are chances that this patient may clinically and pathologically respond to this particular treatment. So that is, it also helps us in the looking for an extent of damage and also the prognostically. So before going into the different presentation, you should know this slide. This is the most important slide on HRCT. So what are the different presentations? So you should know. So any ILD, either you see a lot of ground glass, so this is the ground glass, you see a lot of ground glass, or you see a disease here somewhere down in the subpleural areas, you see a honeycombing. Any presence of honeycombing in subpleural areas, it is a sign of fibrosis. More the honeycombing, the higher is the progression of disease, and lesser you can expect a treatment results in this patient clinically as well as radiologically. Now coming to, these are the nodular patterns. You see these are small nodules. Nodules you will see in hypersensitivity pneumonitis or sarcoidosis. This honeycombing you will see in UIP, in IPF. Ground glassing you mostly see in either diffuse alveolar damage like presentations of ARDS or you see in NSIPs, non-specific interstitial pneumonia, or like in CTDs, connective tissue disorders. Then you may also see a parenchymal consolidation. It is a classic consolidation we see in bacterial or viral pneumonias also with the air bronchograms, and you can see a atoll sign, a halo sign, a pseudo halo sign basically. So that is called as atoll sign. These are classical of BOOP, cryptogenic organizing pneumonia. So the entire patterns of different ILDs sits on these 5 or 6 radiological presentations. Now, coming to the various idiopathic interstitial pneumonias, we'll not go into too much of detail. The most important being, it is UIP and NSIP. So these are the, you should know what are the UIP and NSIP if you are going into any lecture on ILD. UIP is usual interstitial pneumonia, NSIP is non-specific interstitial pneumonia. Please don't go by the names. These are just names, somewhere come from some previous nomenclature. It doesn't mean there is anything usual, or it doesn't mean there is non-specific. It is also a very specific disease. NSIP is a very specific disease. Just they have labeled a name as NSIP. And the usual interstitial pneumonia, there is nothing usual in that. So these are just names which are running on, but you should know these two different patterns. The most important difference is in UIP you see lot of fibrosis and less of inflammation. In NSIP you see lot of inflammation, less of fibrosis. That is the most important crux. In UIP, since there is lot of fibrosis, these patient doesn't respond much to treatment. The treatment options are also limited. You don't give too much of immunosuppressives, you don't give too much of steroids. You may offer them antifibrotic therapies like nintedanib, pirfenidone, some of these drugs. In NSIP, since there is a lot of disease activity, there is a lot of inflammation, you may offer these patients steroids, immunosuppressives like azathioprine, methotrexate, mycophenolate, all of these drugs. In the subset of patients, these drugs may have a significant role, including steroids. So most important differentiation is bilateral reticular opacities are present in UIP. Ground glasses is not prominent, absence of ground glassing, and it is basal and subpleural predominance. There will be a fibrosis and honeycombing with or without traction bronchiolactasis. Any presence of traction bronchiolactasis is also an indicator of airway, small airway fibrosis. Coming to NSIP, there is bilateral reticular opacities. There is lot of bilateral ground glass opacities. There is basal predominance, it is diffuse, subpleural. Honeycombing is minimal or absent. There may be traction bronchiolactasis. The most important differentiation is the ground glasses versus honeycombing. In this UIP, you see a lot of honeycombing. In NSIP, you see a lot of ground glassing with absence of honeycombing. So this is the most important differentiation. And okay, this is how it looks like. So this is a UIP pattern, subpleural honeycombing you see in a basal regions. This is the classic UIP pattern, and in NSIP you see a lot of ground glassing. You see a lot of consolidations or ground glassing in NSIP pattern. So these NSIP patterns respond much better. They have a better prognosis compared to any disease coming with UIP. Then coming to OP. OP you see a lot of consolidations, and you may also see a atoll sign. So dense consolidation, it will appear like more of an infective disease. It may also look like a tuberculosis or any other infective non-tubercular mycobacteria or some lingering on infection. But cryptogenic organizing pneumonia, these respond beautifully to treatment. This is one of the ILD. If treated well, their HRCT may come back to normal. So it means cryptogenic organizing pneumonia, it is one of the few ILDs which may be completely reversible. It's very, very rare to have a reversible ILD. Cryptogenic organizing pneumonia is one of them. Then you have different combinations like NSIP plus OP. Then one more important thing you should know is DAD pattern. This is called as diffuse alveolar damage. Lot of ground glass consolidations throughout the lung fields. This is present, this DAD pattern is present in good pastures. This is present in ARDS. This is also present in acute interstitial pneumonia, previously called as Hamann-Rich syndrome. So this is comparatively rare in ILD, DAD pattern. But if DAD pattern is there, these patients are highly toxic, they are sick, they are mostly in respiratory failure, and their life expectancy is very short, maybe in only few months or even few weeks. So we have already discussed, I think, the this UIP thing, that there is a lot of fibrosis and you have a clinical implications because you can only offer them antifibrotics and not immunomodulatory drugs. Compared to a NSIP where there is a lot of ground glassing and less architectural distortion, these are usually associated with connective tissue or the drug-related ILD. Organizing pneumonia we have already discussed. These are peripheral patchy perilobular consolidations with the reverse halo sign. In hypersensitivity pneumonitis, you may have a mosaic attenuation, air trapping on expiratory images, and there are centrilobular nodules. These pattern recognition shows the differential and directly targeted the various investigations and treatment. Now coming to the management of ILD, once we have labeled an ILD, we have found out some pattern, we have fit it into some pattern. How to fit it and who can fit it? The most important thing till date, which has proven results in as far as management of ILD is concerned, is multidisciplinary approach. No single person can treat ILD. Multidisciplinary approach means there has to be a discussion between a pulmonologist, radiologist, and a pathologist to improve the diagnostic accuracy. It has to be decided between a clinical radiological diagnosis versus a need for histology. When to take a histology or should be directly treat on basis of HRCT. Then shared decision making about the diagnostic procedures based on this risk and benefit. And if there is a suspicion of connective tissue disorder, then the role of rheumatologist also come into picture. So these are the four persons which have to basically, it's just like a tumor board. In any malignancy patient, if you go to any referral center, there will be a tumor board, there will be a radiation expert, surgeon, and a medical oncologist who will be sitting on that tumor board and then decide on every single case, whatever simple or difficult oncology case comes to their picture. So same thing goes with ILD. These are the persons. Till date in my own practice, I discuss every ILD case with my radiologist, at least have a discussion of minimum 10 minutes on every single thing. I give her a history. She tells me everything about whatever, whatever patterns she is seeing, what are the things, and then we make a shared decision making. And then if required and we take a histopathology sample, then we rope in a pathologist also. This is a standard practice at most of the places to manage a ILD. Now coming to the very, very important thing like role of bronchoscopy, BAL and biopsy. In bronchoscopy, the bronchoalveolar lavage may support diagnosis, especially in hypersensitive pneumonitis, where you may have a lot of lymphocytosis and altered CD4, CD8. There will be a lot of CD8 cells compared to CD4 cells in BAL, in hypersensitive pneumonitis. In hypersensitive pneumonitis, even a biopsy, simple transbronchial lung biopsy, or in sarcoidosis, a simple transbronchial lung biopsy can make a definitive diagnosis of hypersensitive pneumonitis and sarcoidosis. But nowadays in NSIP and other things, lot of centers are trying transbronchial lung cryobiopsies. Earlier, whenever we used to do a transbronchial biopsy in ILD, the sample was never enough. So always a surgical lung biopsy was the diagnostic test of choice and bronchoscopy was not offered. With coming of cryobiopsies, now we are offering a transbronchial cryobiopsies. The only problem is chances of hemoptysis is pretty high. But otherwise, if the bleeding doesn't happen, nowadays we get a larger chunks and we can label most of the ILDs with the a proper pathology also. The gold standard is always surgical lung biopsy, but whenever there is no histology, whenever we require an histology, whenever we are not sure about the any ILD, or if it is a rapidly progressive ILD, then we offer the surgical lung biopsy. Not going to nursing. So management principles, the most important things in management principles. Always look for the treatable of like identifiable cause. Any drug, any antigen, like in pigeon breeders disease, the most important thing I always advise them is to change the house. It is, even if you tell them to just remove the pigeons from that house, it is not enough. The antigens, the feathers, the bird droppings, they stay on their beddings, on their bed sheets, on their clothes for at least a year or even 1 year and a half. And these patients may still have an exposure even after proper cleaning, multiple times of cleaning rounds of their houses, removing all the birds, cats, everything. They may have continued exposure for a year or so, even more than a year. So we always tell them, if possible, change the house. If they are not able to change, then obviously for few months I have always advised them to remain away from this thing, because these are the most dreaded diseases, the hypersensitivity pneumonitis. If they have a continued exposure, ultimately we will lose this patient in few years. Then coming to the drugs, if there is a specific drug, you can always change the drug to a pulmonary safe drug. And if there is a connective tissue disorder, start treating connective tissue disorder, your ILD will improve, or it will at least stabilize. Just like in RA, in connective tissue ILD is the most common disease in India, it will be, I think, RA, rheumatoid arthritis. So you just treat the rheumatoid arthritis on standard lines like DMARDs, methotrexate, with the small doses of steroids, and if required you can add rituximab or something. And all of these drugs, they will also help. The same treatment will work on the ILD part also. Then coming to antifibrotic therapies. In antifibrotic therapies, most important being the nintedanib and pirfenidone, and these are specifically for IPF. These drugs were basically researched for IPF, but nowadays any progressive fibrosing ILD, including hypersensitive pneumonitis and systemic sclerosis induced ILDs, mixed connective tissue disorder ILDs, we are offering these drugs wherever there is a significant fibrosis on HRCT. So these are the antifibrotic therapies. There are a lot of new drugs coming, including a lot of, you can say, sisters of nintedanib. Lot of things are on research in India, which is happening. Maybe another 2-3 years we will find some new drugs also. But nowadays the two important drugs which are available is nintedanib and pirfenidone. We should know the side effects of these two drugs. The nintedanib, the most important side effect is diarrhea, and pirfenidone, the most important side effect is hepatotoxicity and photosensitivity. So these are the common side effects of these two drugs. Immunomodulatory therapy, the most important being corticosteroids and steroid sparing agents, including azoran, mycophenolate and cyclophosphamide. Nowadays we are not using cyclophosphamide much. Mycophenolate has already taken role. So most of these patients, non-RA patients like MCTD, Sjogren's, connective tissues, SS, we preferably offer them mycophenolate along with steroids at the first go, and most of these patients usually do well on mycophenolate. A careful patient selection should be there. Some fibrotic ILDs do not respond, and in some patient immunosuppression may harm. We have already discussed that, especially in IPF. Any patient who has lot of fibrosis, less of ground glassing, these patients may not respond well to immunosuppression, and you may have that side effects of immunosuppression. So whenever there is CTD ILD, always coordinate with the rheumatology for a disease specific regimens. Then coming to the supportive care. Once we have started on the medical therapy, then supportive care is also important. Any patient who has a saturation, resting saturation less than 89%, these patients are a candidate for long-term oxygen therapy. And then there is also a role of pulmonary rehabilitation in these patients and role of vaccination. All pulmonary patients, they should be routinely vaccinated for pneumococcal, influenza and COVID. This is a standard. Then early referral for lung transplant evaluation, especially the disease which is progressing, they should be early referral to lung transplant. Nowadays in India, more than 1,000 cases of lung transplant has already happened. So nowadays, lot of centers are coming with lung transplant, the biggest being in Hyderabad. So you can always refer these patients to and enlist for lung transplant. Then coming to palliative care and symptom management as the disease progresses, just like any chronic disease. So all of these patients should be serially monitored with the PFTs, diffusion capacity, 6-minute walk test, oxygen saturation, and maybe a serial HRCTs also as indicated. Then we have to basically see the progression of the disease. The most important progression we see is on the symptoms and PFTs and diffusion capacities functionally, and sometimes on if we have to do a repeated HRCT also, on the radiologically also we can see the progression. And if the fibrosis is increasing, we can always add an antifibrotic drugs, and always individualize the follow-up frequency based on the symptoms and trajectory. ILD is a varied disease. Some patient, they progress very, very fast. Within few months, I have lost a patient from the just diagnosis till treatment. Even they were regularly on follow-up, taking proper medication, properly compliant. I have lost them in a year or so. I have also seen the same ILD, 10 years of follow-up. I have also seen 4 or 5 patients of where I'm not offering any therapy. I'm just giving them like 6 monthly, I'm monitoring their PFTs and diffusion. They are just not progressing. So it is just like malignancy. Some of these patients may progress very fast. Some of them progress very slow. So if they are progressing very slow, the treatment, your intensity will also be low. Coming to the prognostic factors, any baseline and change in FPF, FVC and DLC are very, very key predictors. Extent of fibrosis, especially the presence of honeycombing, it indicates a worse outcomes, and comorbidities. Presence of pulmonary hypertension, it is a bad sign. Presence of a coronary disease, they also worsen the prognosis. So let's go into the summary. Today's whatever like we have discussed. So any ILD patient, we require a history, an examination, baseline PFTs and lab. Then the most important thing being an HRCT. If there is a definitive UIP, directly label it as an IPF with absence of connective tissue and consider clinical diagnosis and antifibrotic therapy. If it is a non-diagnostic HRCT, then go for multidisciplinary therapy, may consider TBLB, BAL, serology, other investigations. And treat the cause if found. If particular drug or there is some exposure to like cat, birds, something, then you need to eliminate that allergen. Immunosuppression for inflammatory ILDs, antifibrotic for progressive fibrosing phenotypes, and supportive care and transplant referral whenever indicated. So these are the selected references I've got. Thank you for the patient listening.
Thank you, Dr. Puller, for presenting us a beautiful approach to rather, evidence-based approach to ILD. And that slide where you compared all the pictures of HRCT in one slide is most significant to compare for us physicians to just see and label that this is this. So thank you very much. Any questions or comments? Thank you, sir. So now I'll request Dr. M.R. Gupta to proceed with our next RSSDI session.
Thank you, sir. Thank you, MAPICON. Thank you, Dr. Vitul, for giving me this opportunity.
Now I invite Dr. Rohit Agarwal for the next talk on type 5 diabetes. Dr. Rohit.
So this will be very, very important because generally we talk about 4 types of diabetes, and Dr. Rohit is going to make us aware about the type 5 diabetes, which is an upcoming subject. Dr. Rohit, please.
So first of all, thank you, sir, Dr. Vitul Gupta, inviting me. No issues. On this for this MAPICON, this new topic, type 5 diabetes, again, I think it's new for me also. Lot of controversies still there. It's a old diabetes, it's not a new one, but recently because of you say so many meetings, gatherings are happening, and the people are looking for some other sort of cases which are not fitting exactly into type 1, type 2 or other type of diabetes. So they are making a new entity of diabetes as a type 5 diabetes, but still there is a lot of controversies also. So this presentation is only for the controversial presentation, not a exact one. So type 5 diabetes, previously also known as malnutrition related diabetes mellitus, what we called as MRDM. The word is of obesity. Now everyone, we are obese, the BMI is high, and we say the obese people are more prone to become diabetic, developing cardiovascular diseases, so and so and so on. Now, but the entity that those people who have lean BMI, that is a BMI less than 18.5 kilogram per meter square, they are becoming diabetic without any positive family history or without any positive antibodies levels. So the first case, which was seen way back in 1965 by Hughes and Jones in Jamaica, and they found the people are too weak, their BMI is low, they belong to a very poor socioeconomic usage strata, and they are protein deficient also, but they are becoming diabetic. And when they evaluate at that time what the investigations were available, they found they are not type 1 or type 2, but they are a separate type of diabetes. But because of the lack of scientific basis or the lack of investigations, they weren't able to label it, and they labeled as a specific diabetes. If someone recalls the MBBS, it was called as J type of diabetes. So J type of diabetes was nothing but the type MRDM, which was initially labeled in 1965. So does malnutrition play a role in diabetes mellitus? The answer is yes. So malnutrition, we know that it is a nutritional condition which results from imbalance of energy, protein and nutrients. So WHO recognized this malnutrition as a distinct entity and has incorporated MRDM as a category of classification of diabetes in 85. But afterwards also, because ADA is the main society which label as type 1, type 2 diabetes, still, sir, Dr. Whittle has said type 3, type 4 diabetes. Just to remind you, there is no type 3 diabetes, no type 4 diabetes also. So type 3 word is given to other type of diabetes, that is secondary diabetes, which are related to either drug induced or related to some pancreas involvement or related to maternal inherited diabetes, something like that, like the MODI which we used to hear. Then the type 4 is nothing. Type 4 we labeled as a gestational diabetes. So still the people are saying ki type 3 is not there, type 4 is not specifically labeled. Why labeled lean BMI as a type 5 diabetes? This is again a controversy. So this diabetes is being characterized by insulinopenia. There is a deficient, there is an insulin secretory defect, insulin resistance is there. Some can ask me, the aadmi da palla hi patla hai, the BMI is less than 18, how the resistance is there? And hyperglycemia definitely is there, and there is a partial failure of the beta cells in the pancreas. So the word is very important. It's a partial failure, not a total failure, which we see in type 1 diabetes patients. So the ADA, they reclassified this MRDM into two subgroups. One is fibrocalculous pancreatic diabetes, and second they labeled as a protein deficient pancreatic diabetes or protein deficient diabetes mellitus. So this was the historical timeline or the classification which I was talking you earlier. That is 1985, WHO first introduced MRDM as a distinct category. In 1999, so they again remove MRDM as a distinct category in a revised classification. They thought that it could be a secondary form of diabetes. But lately in 2025, the idea which happened in the Bangkok this year, this was expected, it was expected that they might reconsider classification of MRDM as type 5 diabetes. But still they have not labeled. They have labeled it is a distinct entity, but they have not labeled as a type 5 diabetes. They say you can relate them as a MRDM, not as a type 5. The main work from for this diabetes MRDM was done by our own Dr. Tripathi from Varanasi. So he had a multiple publications long back from Varanasi in the BHU about this diabetes. So looking by the worldwide distribution, if you see, so as awareness regarding the pancreatic diabetes as a separate entity is increasing, Western data reveals 10% of newly diagnosed diabetes belongs to type 5, and they say could be calcific pancreatitis is present in 8% in Uganda and something like that. But in India, the caseload is slightly higher, but the maximum cases, if you see, they are from the African countries, mainly from the Jamaica, Togo, and the Cairo countries. So what are the factors? Why we are becoming MRDM? What the basis reason is this? It is not like that, aaj hame malnutrition hogi, we become diabetic. So the story goes back, it right from the maternal malnutrition. They say if the maternal at the time of pregnancy is taking a low protein diet during pregnancy and lactation, it can cause permanent altered hypothalamic expression of genes in the rat offsprings. So these genes, what are those genes? These are those genes which are involved in insulin signaling, lipid and glucose metabolism, which may outline the metabolic process. And so, if that child is born to a protein deficient mother, if the child nutritional status again is deranged, it is not good, or there is a short period of moderate to very severe undernutrition during the postnatal development, it again increase the risk of developing diabetes later in the adulthood also. So what is MRDM? What are the key characteristics? Key characteristic is, first is age, less than 30 years, number one. Second is BMI, less than 18.5 kilogram per meter square. Third, you can have a history of childhood malnutrition. Fourth, calcification in the pancreas can be there, may not be there. Patient usually they require insulin for the treatment, and in some subset of the patients even your oral anti-diabetic drugs can be effective. The most important is these patients, even if they are off insulin, they won't go into ketosis like in type 1 diabetes, which they cannot survive without insulin for a day or so. So without insulin, where the requirement is high and the requirement is goes up to 2 units per kilogram of the body weight. If someone is say 50 kgs and the requirement can go up to 100 units in a day, this high much of requirement is there to control the blood glucose level. Last but not the least is absence of autoimmunity. Autoimmunity means looking for those antibodies like GAD65 antibodies, zinc transporter 8 antibodies, ICA or IA2. These are the few antibodies which we usually do when we find this patient might be type 1 or not be type 2, or when we are looking for a LADA onset of patients. Absence of these antibodies, again it is the hallmark of MRDM. So historically we dividing into two categories: fibrocalculous pancreatitis and protein deficient diabetes mellitus. So what are their clinical characteristics? The most important for the FCPD, it is the presence of the pancreatic calcification, what we saw as a pathognomic feature. Usually how they present, the patient they present with the history of recurrent pain abdomen since childhood. There is an evidence of exocrine pancreatic insufficiency. Along with endocrine, with the patient is becoming diabetic, there is an exocrine pancreatic insufficiency. And how to check the exocrine pancreatic insufficiency? The simple test is do the fecal elastase. That is available. Progressive beta cell failure requiring insulin over the time, and absence of ketosis despite the patient is insulin dependent and the markers, autoimmune markers, are negative. So this is a clinical course. Stage 1, pre-diabetic. Just recurrent pain abdomen starting in childhood. With you do the ultrasound, calcifications are present, but there is a normal glucose tolerance. Stage 2, transition phase. Calcification increased. We have repeated the sonography, the CT scan. Now you did the OGTT, or you find the patient has got impaired glucose tolerance and there is intermittent hyperglycemia. Usually the patient कहता है कदे-कदे sugar बढ़ जाती है जब stress ਹੁੰਦਾ या मिठा खा लेने, वैसे sugar मेरी ठीक रहती है. This is the most common the words by the patients. Third is overt diabetes, when they require insulin therapy for the management, or there is extensive calcification. Extensive means like you say that 50 to 80% of the pancreas is calcified. And last is the advanced stage, when the patient develops microvascular complication, or there is a beta diabetes, kabhi 400, kabhi 40, something like that. And this type of patients who have advanced FCPD, there is increased risk to develop the malignancies. On the contrary, the second part which we is discussing is the PD, that is the protein deficient pancreatic diabetes. In this, there is no pancreatic calcification. But clinically, you can see the markers for the protein energy malnutrition. Insulin is required for controlling sugars, but if patient is off insulin, जैसे Dr. Mittal ने कहा कि you can't keep the insulin in your pockets also. If the patient has gone somewhere, insulin पीछे रहेगी, जो normally हमारे सब पेशेंट्स के साथ होता है, they won't go into ketosis. The last but not the least is low C-peptide levels. If the facilities are available, we can go for the stimulated C-peptide. The C-peptides are there, but on the lower side, meaning by that there is a slight insulin secretion from the pancreas, and possibly there is an exocrine pancreatic insufficiency also. Looking for the pathophysiology. अब इसमें भी गड़बड़ है कि what could be the reasons? Multiple factors are coming into play. Genetic factors are there, nutritional factors are there, protein energy malnutrition is there, so many factors are there which are interplaying with one and another. So one person is saying, I am weak, my BMI is low because my sugars were not controlled. हम पतले हो गए क्योंकि शुगर बढ़ी हुई थी. हम ये कह रहे हैं कि तेरी शुगर जो है वो पतले होने की वजह से है, तो आपस में लड़ाई हो गई. So these are the two things, na? So which we have to be very careful what we are saying and how to address this type of the issues. So dietary factors, we say increased consumption of the cassava, which is available in the South Indians. Immune-mediated immunological destruction of the beta cell of pancreas. On radiological, you can find the calcification, pancreatic dysfunction, nutrition deficiencies in the form of micronutrients, mainly your sulfur-containing amino acids, or genetic factors may contribute, which I am just going now. Yes, oxidative stress because of the decreased free radical and peroxidase removal, chronic pancreatic diseases and metabolic abnormalities are there. So multiple factors are there. So these are the few genetic factors which are there in MRDM. The most important is this SPINK-K1 mutation. This mutation is seen in 40 to 50% of FCPD patient. Once there is this gene is mutated, it leads to the premature activation of the trypsin. When trypsin is activated, autophagy will occur, your pancreas starts injured and there will be auto-digestion of the pancreas. Another genes are like PRSS1 and PRSS2 variants. These two things are important for hereditary pancreatitis. Just approximately weeks back, I had one patient, उसके दादाजी died of pancreatitis. Now बेटे को pancreatitis हो गया at the age of 30 years. अब उसका छोटा बेटा आया है at the age of 5 years with the diabetics. So I am just looking for the hereditary pancreatitis in that case, and I am looking for this genetic evaluation, contacted the Gangaram people for this PRSS1 or 2 genes. Then cystic fibrosis transporter receptor variants, we know that, and other candidates like chymotrypsin C, carboxypeptidase A1 and calcium sensing receptors. So these are the few genetic ones which are there. Now another question is, why the people are ketosis resistant? They require a lot of insulin for sugars control, still they are not ketosis. Reason is very simple, because fat ही नहीं है, because of reduced lipolysis, because of the decreased fat store. Second is decreased glucagon secretion because the cells are not working, your islets is not working, not only the beta but the alpha cells are not working. Still you have got a residual, there is a partial beta cell function which is sufficient to prevent ketogenesis and reduce substrate availability for ketone production. So these are the few things why the patients are not becoming ketotic. So how to diagnose? I think most important is the glycemic assessment, which we do. C-peptide not available anywhere, everywhere. If available, I think we should do it. It is low, but typically not absent. Autoimmune markers, if facility is available, we must go for these 4 antibodies, anti-GAD, anti-IA2, anti-insulin antibodies, or you can go for the zinc transporter 8 antibodies also. If you want to rule out autoimmune pancreatitis, then you have to go for the IgG4 levels. Amylase and lipase may be elevated or may be normal. They are elevated in acute phase settings, we know that. Fecal elastase, I told you earlier, we should do, it should be less than 200 microgram per gram, which suggests the patient has got exocrine pancreatic efficiency. Or you can go for the 72 2 hours fecal fat. I think this is slightly laborious. Imaging, 3 things: ultrasound, CT scans, or through this ERCP or endoscopic sonography, and this is a typical so this is a typical calcification which you see on a plain X-ray of the abdomen, large discrete pancreatic calculi. Remember, अगर patient alcoholic है, calcification है, उसमें smaller calculi होंगे, small ducts में होते हैं. In FCPD, large calculi in the larger ducts. So this is the difference on the sonographics. This is the ultrasound imaging of the pancreas in FCD patient, and this is ERCP of the FLC patient, where you see the whole pancreas is calcified. So how to diagnose? Clinical suspicion, most important. Evaluation, which we have discussed. Pancreatic imaging, which I have discussed. So the confirmation comes from diabetes plus pancreatic calcification, FCPD. Diabetes, no calcification, patient is lean, BMI is low, sugars are high, consider protein deficient pancreatitis. Be careful labeling them as type 5 because still controversial, but we can label them. So how to differentiate? क्या ये type 1 नहीं है क्योंकि insulin requirement इतनी ज़्यादा है? Type 1 diabetes में usually they have positive antibodies. They are more prone to ketosis. There is no pancreatic calcification, simple. And they cannot live without insulin. In type 2, usually they are higher BMI with strong family history and insulin resistance. In this type of cases, insulin resistance in MRDM is there, but it is lesser as compared to type 2. And in MRDM, there is a slight insulin secretion from our own pancreas also. So the C-peptide is there, but it is a lower side. In type 2, the C-peptides are always higher because of hyperinsulinemic phases. So MODY, which we have to rule out through the genetic testing. There are usually the pedigree charts, 3-4 family history hai, vertical transmission hai, these type of things are there. Alcoholic related usually you find a different calcification pattern which we have discussed, and there is a history of alcohol abuse. So treatment is control of sugars, nutritional rehabilitation with the help of proteins or multiple vitamin supplements, and the pancreatic sport which we do with this this panlipase or other enzymes. So the insulin therapy, you start with a smaller dose of basal acting, then depending on the you say your requirement, you can go for twice a day or thrice a day or the basal bolus therapies. Oral anti-diabetic drugs can be there, mainly the sulfonylureas and the metformin. DPP-4 does not have a much of role. SGLT2 we should avoid. GLP-1 not much role because of pancreatic involvements. So nutritional, high protein intake, close to 1.2 to 1.5 gram per kilogram of body weight. How much calorie we should give? 35 to 40 kilocalories per kilogram per day. Complex carbs should be 50 to 55% of the total calories. And gone with the micronutrient supplements in the form of vitamin A, D, K, and B, and iron if deficient. So this I think we should know how we should manage this exocrine pancreas with the help of pancreatic enzyme replacement therapies, 10,000, 25,000 or 40,000, and acid suppression might you need. And the most important is the medium chain oils that should be given rather than saturated fats. And if the patient is complaining of pain, the first line therapy is always acetaminophen with a paracetamol. Second line is tramadol, pregabalin, and interventional approaches like celiac plexus blocks, I don't know who is doing it. Endoscopic procedures for ductal obstruction, or you can consider for surgery if there is an intractable pains. Most important is the risk. The risk for pancreatic cancer is very high, and this goes up to 15 to 25 times higher, which typically occurs 10 to 15 years after you have diagnosed the patient with FCPD. So we have to be very careful when you are following this patient, and you can do your CA99, but we say it's not a marker for a follow-up also, but we should know it ki udhar to nahi ja raha. So annual pancreatic imaging either through ultrasound or CT is required once the duration of disease is more than 10 years. So just to summarize, this is a distinct type of pancreatic diabetes, type 3C or 5, what the people are saying. So clinical phenotype is changing because now we are seeing a more better nourished patients with a slightly higher BMI. Now we are seeing in an older population also. I think the hallmark feature is the absence of ketosis despite high glucose and high requirement of insulins. Exocrine pancreatic deficiency may precede onset of diabetes. Chronic pancreatitis and FCPD are pre-malignant condition for pancreatic cancers. So early recognition is essential to avoid the misdiagnosis as type 1 or type 2. Comprehensive management, as we know that we should screen for these complications which can happen earlier, and screening for pancreatic carcinoma is very critical. So, just to end, FCD is more than just a disease, it's multifaceted disorder, requires your vigilant multidisciplinary care to prevent complication and to improve the outcomes. Thank you for the patience hearing.
Thanks, Dr. Rohit Agarwal, for an excellent talk on this controversial and newer subject. This topic is generating a lot of interest in the academic circles. Thanks for the topic.
Thank you, sir. Thank you.
When you chose this subject, I stopped reading this, that I will listen to your lecture for
Thank
my,
you,
information,
sir,
you can say.
it was supposed to be there by the IDF, but IDF ने फिर वो बंद कर दिया because we don't have a sufficient scientific data with us. जिससे कि type 3 अभी label नहीं है, type 4 label नहीं है, क्या type 5 बोलें ना बोलें. Previously ये Dr. B.B. Tripathi ने किया था वाराणसी में. He was a pioneer in looking after that. So they said it is type 3C basically. It was diagnosed मतलब कि 65 से ही ये चलता आ रहा है. तो जो अभी cases आ रहे हैं, spurt of cases with the different epidemiological pictures, that is the main reason now the people have started thinking on these lines.
So I must appreciate your lecture because I have listened to 2 lectures on same topic, but your was more comprehensive and more straight to the point, giving us a broader, uncomplicated view of what we are going in for type 5 diabetes.
Thank you, sir. Thank you.
Thank you very much.
Thank you, sir.
Our next speaker, who is again a endocrinologist, Dr. Arpit Garg. He will be talking on management of thyroid eye disease. This topic is rarely discussed in academic circles, so I invite Dr. Arpit Garg.
Yeah, good afternoon, everyone. First of all, I would like to thank Dr. Vittul for organizing this conference and inviting me here on this esteemed platform. I am going to talk about management of thyroid eye disease. We all know that thyroid disorders are very common and a lot of patients suffering from hyperthyroidism or Graves' disease, they come to us with thyroid eye disease. And as clinicians, we always face this difficulty how to improve the cosmetic picture of these patients, because this disease is particularly more common in females as compared to males, and they are very worried about their eyes. When their eyes start protruding or bulging, it gives them a very a sense of lack of confidence. They come to us asking that what can you do for my eyes. So I think when we manage Graves' disease, it is very important to take care of this eye disease also from the very beginning to prevent and stop its progression. It is also called as thyroid-associated orbitopathy or Graves' orbitopathy. So it is a very strong message in this only that it is not only an eye disease, rather it is an orbital disease, which means it is not involving only the eyes, rather the part behind the eyes, this is extraocular muscles, nerves, everything is involved. The whole of orbit is involved, and that's why nowadays it is called as thyroid-associated orbitopathy. It is a major extrathyroidal manifestation of Graves' disease. Female preponderance is there, but whenever it is there in males and elderly, it is more severe. This thing we have to remember. So if we are seeing any male patient suffering from this eye disease, we will expect it that it is going to be more severe as compared to females. It is typically bilateral and rather symmetrical eye disease. And unilateral Graves' orbitopathy occurs in approximately 10% of the patients. So if any unilateral eye disease is there, it is an indication for imaging, because in most of the patients, Graves' eye disease is bilateral. So if you are seeing a unilateral disease, you need to rule out other causes of unilateral proptosis. Coming to the clinical pictures, it can be easily remembered by a mnemonic, that is nose pecs. It is being traditionally taught since many years. First of all, 0, no signs and symptoms. 1 is the only signs, no symptoms. Patients often complain of grittiness in the eyes, dryness in the eyes, and some pain. Then comes the soft tissue involvement, in which there is eyelid and conjunctival swelling and redness. And as you can see in this picture, there is typical eyelid swelling which is there, redness is there, and if you see by the slit lamp, there will be chemosis or conjunctival swelling will be there. Then proptosis, which is measured by an instrument called as Hertel's ophthalmometer. Proptosis is basically bulging of the eyeballs. Extraocular muscle involvement, which will lead to diplopia, impaired eye motility, which can be easily checked by clinical examination. Then the corneal involvement, which will lead to keratitis and ulcer, and it is one of the severe form of thyroid eye disease. Then the sight loss due to optic nerve involvement, which we call as dysthyroid optic neuropathy. It can be assessed by fundus examination, or sometimes imaging in the form of MRI may be done. So whenever we are treating thyroid eye disease, we have to know two things. One is the severity of disease, second is the activity of disease. There are two separate things. One is the severity, second is the activity. Activity is regarding the inflammation, whether it is an active inflammatory disease or inactive disease. Severity is the grading, like how severe is the eye disease. So it is classified into three forms: mild Graves' orbitopathy, moderate to severe, and the sight threatening. In mild disease, there is patient often complains of only symptoms, and signs in the form of minor lid retraction less than 2 mm, mild soft tissue involvement, exophthalmos, and less than 3 mm of the normal for race and gender, or no or intermittent diplopia may be there. It is classified as mild disease if any of this sign is there. In moderate to severe disease, patients are not having any sight threatening Graves' orbitopathy, but two or more of the features are there, like lid retraction more than 2 mm, moderate or severe soft tissue involvement, exophthalmos more than 3 mm, and inconstant or constant diplopia. And thirdly is the sight threatening disease, which may be due to corneal breakdown or optic neuropathy, optic nerve involvement. So you have to categorize the patient whether the patient is having mild disease, moderate to severe, or sight threatening disease. Then comes the disease activity, which I was telling before. This is basically because of the inflammation. So this is the clinical activity score. We have to calculate the score, and only then we can tell whether the patient is having any active disease or the inactive disease. There are various pointers. One is a pain, spontaneous pain or pain on movement, redness of eyelids or redness of conjunctiva, swelling of eyelids, swelling of caruncle or plica, and swelling of conjunctiva, that is chemosis. These are the things, pain, redness and swelling, which are assessed at the initial visit of the patient at the first visit. And when you follow up the patient, impaired functioning is checked, which is increase in proptosis of more than 2 mm in 1 to 3 months, decrease of more than 8 degrees in the eye muscle motility in any direction over 3 months, and decrease in visual acuity of more than one line in Snellen's chart over 3 months. So to say it is active disease, at presentation if the score is more than 3, we consider it as an active disease, and at follow-up if the score is more than 4, we consider it as an active disease. So depending on the activity and the severity, we treat this disease. Coming to the orbital imaging, a lot of clinicians, they perform CT scan or MRI in all the patients of Graves' orbitopathy, but it is not always necessary. There are very specific indications when you need to do orbital imaging. One is to look for dysthyroid optic neuropathy. Second is in euthyroid patients or hypothyroid, if you are seeing proptosis, you should perform imaging to rule out other causes. In unilateral proptosis, again you need to do imaging, and it is often performed by CT and MRI. And whenever you are planning to perform surgical orbital decompression, you need to do orbital CT scanning to assess the bony orbit. What is the anatomy of the orbit? To assess the anatomy, you need to do imaging. So treatment, the most important thing is to control the risk factors. Smoking is one of the major risk factors which leads to worsening of thyroid eye disease. Also, all the patients who are suffering from hyperthyroidism or Graves' disease, they must be strictly told that they have to abstain from smoking. If they are smokers, they have to stop smoking immediately. Otherwise, smoking increases the risk of worsening of this disease by 3 to 5 times. Then thyroid dysfunction, you have to make the patient euthyroid. Don't make the patient hypothyroid. Even the hypothyroid state will also lead to worsening of this thyroid eye disease. Reduce the oxidative stress. You can give antioxidants to the patient. And radioactive iodine treatment. If the patient is having established thyroid eye disease, then you should be cautious of giving radioactive iodine, because it has been seen that if the patient of Graves' or myopathy is administered radioactive iodine, it leads to worsening of the eye disease. So in patients who are suffering from eye disease, it is better to avoid this radioactive iodine treatment. Then the local measures which are very important, we should prescribe artificial tears during the daytime, and at the night time patients can be given lubricants in the form of ophthalmic gels or ointments with possible taping if there is a gross proptosis and the patient is unable to close the eyes at the night time. Patients may also use swimming goggles at the night time, because the major problem is because of the air exposure, which leads to keratitis. So since swimming goggles, they create an insulation, air cannot enter the inside the goggles, so they can also use the swimming goggles at the night time. And botulinum toxin injection, that is Botox injection, can also be given in the levator muscle, because it will reduce the tension and it will help in closing the eyes if there is proptosis is not that much. So Botox can also be given. Coming to the management of the mild Graves or myopathy, general recommendations, as I have already told, they should be done along with local measures. Then mild Graves or myopathy, there is no much treatment. You have to just normalize the thyroid profile of the patient, try to normalize T3, T4 levels. And there is a particular drug, that is selenium, which can be given in mild disease, and it has shown that if you give selenium in mild Graves or myopathy, there is some degree of improvement which is seen in the patients. It is given in a dose of 200 micrograms daily for 6 months, and selenium is very easily available in a lot of nutraceuticals which are available in the market. And but if there is active disease, the severity is mild, but if you see the activities, then the patient is qualifying for the active disease, is the score is more than 3, then you can discuss with the patient regarding the steroid therapy. If the active disease is there, you can give steroid for a short term. Coming to moderate to severe and active Graves or myopathy, which deserves the treatment, and the results are good if treated early. If you delay the treatment, then gradually the disease is going to become inactive, and no treatment is going to give any benefit. So all the treatments which are there for the Graves or myopathy, they are there for the active Graves or myopathy. If once the disease becomes inactive, that is no inflammation is there, then we are not left with any therapy, only the surgical treatment is left. So it is very important to recognize this active disease in the very early stage. So the drugs which we have with us are the steroids, and the IV methylprednisolone is the drug of choice for the treatment of active disease. It is given in the it is given in an weekly administration. So cumulative dose of 4.5 milligram is given. Initially 0.5 milligram weekly is given for 6 weeks along with mycophenolate mofetil, and if response is there, we give an additional dose of 0.25 milligram weekly for 6 weeks. So it makes a cumulative dose of 4.5 milligrams. Once the response is there, then you need to stop the therapy. But if there is no response after the initial dose of like 0.5 milligram weekly for 6 weeks, then you have to go to the second line treatments, which I'll be showing in the upcoming slides. But if there is severe disease, then you can go up to higher dose of 7.5 milligrams also. In this, you give 0.75 milligram IV for weekly for 6 weeks, and followed by 0.5 milligram weekly for 6 weeks. But if again there is no response, then switch to second line treatments. But if the disease is inactive, there is no activity, there is no redness, only proptosis, severe proptosis is there, and patient is having diplopia, then we are left with only surgery. There is no other option in that case as of now. So coming to the second line treatments, we have a lot of drugs like repeated course of IV methylprednisolone. We can give oral prednisolone also, cyclosporin, azathioprine, oral radiotherapy is there. Then teprotumumab, it is a humanized monoclonal antibody, which is a newer drug, and I'll be discussing about this in the next slide. Then the rituximab and tocilizumab, these are still under research. All these drugs are being tried because they ultimately carry anti-inflammatory properties, and somehow if the patient is not responding to steroids, these drugs are being tried because the side effects are less as compared to steroids, and but concrete evidence has still not emerged with these therapies. But once the disease becomes inactive, go for the rehabilitative surgery. How to assess the treatment outcomes? One is a subjective improvement. Patients tell about the improvement, whether the grittiness has decreased, whether any improvement in the diplopia. And objectively, you can assess the improvement by seeing the clinical activity score. If there is improvement in more than 2 features in one eye without any deterioration in the other eye, then we can say that your patient is responding to the treatment. Coming to the systemic glucocorticoid therapy, as I've already told, that cumulative dose of 4.5 milligram methylpred given in 12 weekly infusions, 6 weekly infusions of 0.5 grams followed by 6 infusions of 0.25 grams are given. Then higher cumulative dose of 7.5 grams is reserved for more severe cases. Oral prednisolone has also been tried. It can be given in a dose of 1 milligram per kg, gradually taper down over to 5 to 10 milligrams per week until withdrawal over 6 months. But the response rates with IV methylpred are much more as compared to the oral therapy, that is 77% versus 51%. So when to consider second line agent? One, if the patient is has some contraindication to steroids, like if the patient is having any hepatitis, which is very common in hyperthyroidism, which the patient is already having transaminitis, then you should refrain from using steroids. Adverse effects outweigh the benefits, like some patients are having uncontrolled diabetes, and you cannot prescribe IV steroids because otherwise the blood glucose levels will surge too much. Failure of glucocorticoid therapy and recurrent disease. In such scenarios, you should consider second line therapies. Coming to another drug, that is mycophenolate mofetil. It is inosine monophosphate dehydrogenase inhibitor. It is also approved for the treatment of active disease, given in the dose of 1 gram BD for 24 weeks. But we have to monitor CBC and LFTs whenever you are prescribing mycophenolate mofetil. Cyclosporin and azathioprine, they have also been tried, but no definitive advantage has been seen in the clinical trials. Coming to teprotumumab, it is a newer drug. It is a fully humanized monoclonal antibody which inhibits IGF-1 receptor signaling. It was approved by US FDA in 2020, and OPTIC trial was the landmark trial which was conducted with teprotumumab. It showed significant improvement as far as proptosis is concerned, clinical activity score, diplopia, quality of life. And I must tell here that teprotumumab, it is the only drug for the management of Graves' orbitopathy which has shown improvement in proptosis. All the other drugs like glucocorticoids or any other immunosuppressive therapies, none of the therapy results in improvement in the proptosis. But teprotumumab is the one therapy which has shown improvement in proptosis. As you can see from these pictures, these are from the OPTIC trial. In the A, patients were given placebo. As you can see here, there was no improvement in proptosis. But in B, patients were administered teprotumumab, and at 24 weeks, you can clearly see the improvement in the proptosis. So it results in significant improvement in proptosis, but it is yet not available in India with us as of now. Coming to the management of sight-threatening disease. So if the patient is having sight-threatening Graves' orbitopathy, it may mostly optic neuropathy. So in this, you have to give pulse methylprednisolone, which is 0.5 to 1 gram once a day for 3 days. Consecutively, you should give, and monitor the ophthalmic parameters. Ideally, sight-threatening Graves' orbitopathy patients are admitted in the hospital. They are given methylpred 1 gram daily for 3 days. Daily ophthalmic assessment is done, and assess the patient after 1 week. If there is any response is there, then continue methylpred in a dose of 0.5 milligram weekly. Up to 6 weeks you should give. And if there is no response or partial response, then go for the surgery. Don't wait much, because otherwise the patient is going to lose the sight because of optic neuropathy. So it is a very emergency condition, and it should be handled very aggressively, otherwise patients will lose their sight. Coming to the role of surgery in the management of this Graves' orbitopathy, decompressive surgery is indicated in severe exposure keratopathy when the patient has developed corneal breakdown or ulcers are there, and dysthyroid optic neuropathy when patient is not responding to medical treatment. Local surgeries in the form of tarsorrhaphies, corneal patches or gluing may be done to prevent exposure keratopathy, and combination of decompression, ophthalmic plastic surgery and strabismus surgery is required in the ultimate inactive state, when you can say it is a kind of palliative treatment if the patient is having gross Graves' orbitopathy and no activity is there. then there is a role of these palliative surgeries in the form of decompression or plastic surgeries. To conclude, whenever you are treating Graves' orbitopathy, restoration of euthyroid state is must. Control the risk factors, and local measures are most important. IV methylprednisolone and mycophenolate mofetil is the standard of care in moderate to severe and active Graves' orbitopathy. Biologicals, especially teprotumumab and to a lesser degree tocilizumab or rituximab, they hold a great promise in the future management of Graves' orbitopathy. Teprotumumab has been proven to improve greatly the results in Graves' orbitopathy, but it is not yet available in India with us. Thank you. Thanks a lot for the patient hearing. I'm happy to take any questions.
Thanks for the excellent and informative talk on the subject.
Thank you, sir.
Any comments and questions? Most welcome.
It was a nice presentation. Just like as a clinical this thing, supposedly we have given this IV methylprednisolone for the treatment of Graves' ophthalmopathy, and the maximum dose they say is close to 12 grams, 8 to 12 grams. Some people are giving 1 gram weekly and some are giving 500 milligram weekly for 8 weeks. And what we have seen, the response is there definitely, but it is close to 40 to 50%. 50% still remain there. So my question is, would you like to go with the oral steroids after you have finished with the IV pulse therapy, or would you love to give a say 3 months pause, then again you will love to start with the IV? Is there any guidelines? And because high dose of steroids to the tune of 1 gram per kilogram, patient is not going to tolerate. So this is my is there any experience with you?
So sir, if we talk about the one is the maximum tolerated or maximum recommended dose, there is no consensus, but studies are there in which up to 12 grams have been tried of methylprednisolone. But it was seen that the results were there till 8 grams of the cumulative dose. Beyond 8 grams, or you can say between the 8 to 12 grams of window, the clinical results were not there. So practically now the guidelines, they mentioned that you can go up to 8 grams of methylprednisolone as a cumulative dose, one thing. Secondly is regarding the repeat course of methylprednisolone. Again, this is mentioned in the guideline that at least 6 months gap should be given. Once you have given the pulse therapy of 12 weeks, you have given pulse therapy of methylprednisolone, and still the patient is having some sort of active disease at the end of 12 weeks, repeat course can be given after 6 months. In the 12 weeks, in this 6 months period, I think after giving 12 weeks of IV methylprednisolone, there is not going to be much benefit of giving continuing oral glucocorticoid therapy. It is better to give second line drugs in the form of mycophenolate mofetil you can try, or other drugs like rituximab which are available with us as of now. You can try these therapies, but a repeat course is to be given after 6 months, not before that.
Thank you.
Thank you, Dr. Arpit, for a great talk, especially the clinical signs. Sometimes the patient comes to us कि जी लोग कहते हैं तेरी ना निगाह जड़ी घूरदी है. So that is the early sign of ophthalmopathy, I think, sometimes. And you must investigate for thyroid disease.
So sir, if you are suspecting any patient, like we get a lot of patients, particularly 2 diseases. One is a thyroid eye disease, second is a acromegaly, in which your visual appearance changes. Yes. Sometimes the patient don't know. Even their husband, their family members, they don't know. But when you see the patient you suspect, then better to ask the patient to show their photograph for about 5 years back. Everybody is carrying smartphones, they are having their photographs. So जब उनको photo दिखाओगे ना, भी फर्क है, then they say appreciate कि हाँ जी फर्क ता है. Then they agreed for the test. Otherwise they won't agree for the test also. ये कहेंगे जी बचपन तो है जी अक्खा ने.
Thank you so much.
Thank you. Thank you.
Now I invite our next speaker, Dr. Tanish Dheer, nephrologist from DMC Ludhiana. He will be enlightening us on diabetic kidney disease, prevention and management. Dr. Tanish Dheer.
Good afternoon, everyone. I would like to thank Dr. Vital Gupta sir and the management team. It is a great pleasure over here from being a student of him. and his allowing me this opportunity to present this topic. So I'll be starting the topic, diabetic kidney disease, prevention and management. So I'll be covering the topic under 3 headings: introduction, prevention of diabetic kidney disease, treatment of diabetic kidney disease with the 4 pillars. So firstly, why diabetic kidney disease is important? 1 in 8 Indians have chronic kidney disease, that is 17%. Out of this, 3 lakh per year develop end-stage renal disease, and among these, 30 to 40% have diabetic kidney disease as per the latest ICMR criteria. When we talk regarding the numbers, 2 lakh patients need dialysis or transplant, and out of this, 1 lakh patients undergo dialysis and 15,000 transplants per year occur, while the rest are lost. When we talk regarding the economic section, the major budget of Ayushman is being spent on dialysis, and also the diabetes is associated with high cardiovascular morbidity and mortality. So when we compare healthy individuals having CKD and diabetes at the age of 30, we can see that there are approximately 17 years lost of the life, and this is quite a significant value because of the low deaths and the increased profile. So how do we define diabetic kidney disease? It is defined as abnormalities in kidney structure or function which is present for more than 3 months with implications for health. And how do we define it? It's the presence of albuminuria, UACR, more than equal to 30 milligram per gram, and or reduced kidney function with an eGFR of less than 60 ml per minute per 1.73 meters square, in the absence of signs or symptoms of other primary causes of kidney disease. I'll be focusing mostly on albuminuria. So why is the assessment of albuminuria considered crucial in type 2 diabetes patients? As we can see, increasing urine albumin creatinine ratio is the risk factor for cardiovascular death and all-cause mortality, even at lower value of 30 milligram per gram. That is between normoalbuminuria and moderately increased albuminuria. So it is just not an early predictor of kidney disease, but also for cardiovascular outcomes. So what does the guidelines recommend? It recommends annual assessment of eGFR and UACR to be done in a single voided spot urine sample. And we need to rule out the physiological causes like exercise within 24 hours, infection, fever, heart failure, marked hyperglycemia, menstruation, marked hypertension, which may physiologically elevate UACR independent of kidney damage. And what does the ADA and the KDIGO recommends? That is, a need for reduction of 30% or greater urine albumin is recommended to slow the CKD progression. But this annual measurement is not fixed. As we can see, by increasing stages of CKD, we can, from the G1 to the G5 and A1 to A3, increasing from the low risk to very high risk, we need to increase the screening from once per year to approximately 4 per year as per increasing GFR category and albuminuria. If we talk regarding the albuminuria, then there is also a need to mention non-proteinuric kidney disease. So how do we define non-proteinuric diabetic kidney disease? There is absence of proteinuria, more interstitial involvement, slower eGFR decline, similar risk of progression, most predominantly in females and in older age individuals with the absence of diabetic retinopathy. So we need to inform the patient regarding the projected 2 and 5 year risk of kidney failure by these variables. What are the diagnostic tests available? The diagnostic tests available are glomerular biomarkers, tubular biomarkers, biomarkers of oxidative stress, biomarkers of inflammation, the diagnostic markers, the therapeutic response markers, the prognostic and the follow-up markers, and also albuminuria. And we need to incorporate into the genetics, transcriptomics, proteomics, metabolomics, and then we need to personalize the treatment. So secondly, for the prevention of diabetic kidney disease, the only proven primary intervention I can say is blood glucose control and blood pressure control. This is not a fixed value of HbA1c control, it is as per the category or the stage of the GFR. There is no evidence that RAS inhibitors or any other intervention prevent the development of diabetic kidney disease in the absence of hypertension or albuminuria, as per the various trials. Also, the ADA, KDOQI and KDIGO guidelines recommend ACE inhibitors or ARBs and the other supportive treatment in diabetics with albuminuria and or hypertension, and do not recommend these routine medications for the purpose of prevention of development of diabetic kidney disease. The third is the treatment of diabetic kidney disease. So this is just a 4-pillar strategy. Firstly, including the non-pharmacological therapy in the form of diet. We need to have a low salt diet. Exercise by moderately activity 30 minutes per week for 5 days. Smoking cessation, weight. Then is the first line therapy, which includes metformin, SGLT2 inhibitors, RAS blockers, statins. Then the next additional drugs which have cardiorenal protection in the form of GLP-1 receptor agonist, antiplatelet therapy, non-steroidal mineralocorticoid antagonist, and we need to look forward for the glycemic control, the blood pressure control, and the lipid management. I'll be focusing mostly on these 4 headings. So as I've just said, healthy diet with the physical activity, with smoking cessation, weight management, with the risk assessment every 3 to 6 monthly should be done. So what has been the progress in the treatment of diabetes and kidney disease as increasing from 1980 to 2025? In the 1980, there was no specific therapy for CKD. Then came ACE inhibitors and ARBs, which have been demonstrated in the captopril and the enalapril trials. For the ARBs in the renal and the IDNT trial. Then came the SGLT2 inhibitors shown in the DAPA CKD, IMPA kidney, CREDENCE trial. And then the non-steroidal mineralocorticoid antagonist, Finrenon, in the Fidelio trial, and recently the GLP-1 receptor agonist, which have been shown in the FLOW trial. So I'll be focusing mostly on these 4-pillar approaches: the RAS blockers, the SGLT2 inhibitors, non-steroidal mineralocorticoid antagonist, and GLP-1 receptor agonist. So firstly, RAS blockage. The RAS blocker, as per the renal and the IDNT trial, have shown that there was a 15 to 20% relative risk reduction in diabetes and CKD, but it has no significant reduction in the overall mortality. So while initiating RAS inhibitors, there is a risk of fall in the GFR till 30%. But if there is a fall of more than 30%, we need to rule out various causes, like if there is a bilateral renal artery stenosis, if the patient has sepsis, hypotension, he's in shock, or if he's on NSAIDs, we need to rule out that. Also, the 2025 AHA guidelines have recommended for the prevention or the management of blood pressure in adults in diabetics, have recommended ACE inhibitors and ARBs as the first line therapy. Secondly, the SGLT2 inhibitors. So what happens in diabetes? There is glomerular hypertension, hyperfiltration, nephron loss in CKD progression. And what does SGLT2 inhibitor does? It decreases the hyperfiltration. So how does hypertension occurs? As in diabetes, there is increased filtration of sodium and glucose, which gets distributed and increased in the macula densa in the distal convoluted tubule, which leads to more efferent arteriolar dilatation with increased glomerulomegaly, increased filtration of sodium and glucose, and distal delivery to the macula densa, and thereby increasing the glomerular pressure. So what does SGLT2 inhibitor does? It decreases the reabsorption of SGLT2 in the proximal convoluted tubule, thereby increasing the delivery of sodium and glucose in the macula densa in the distal convoluted tubule, decreasing the glomerular pressure, decreasing the efferent arteriole diameter, decreasing the glomerular hypertension, and thereby decreasing the filtration. That's why there is a physiological decrease of up to 30% after initiating SGLT2 inhibitors, which is just a temporary dip. So these are the various trials which have been done pertaining to the kidney disease. There have been the CREDENCE trial, the DAPA CKD trial, IMPA kidney trial. So what have these trials told? That these are basically used in patients of diabetic kidney disease With the, like we can see that in the CREDENCE trial, these were included patients with the eGFR up till 30, that is G3B and UACR more than equal to 300 milligram per gram. In the DAPA CKD trial, they further increased the UACR and decreased the eGFR, that is up to 25. And in the EMPA kidney trial, they further increased and included patients who were having at least normal to mildly increased albuminuria. So what does SGLT2 inhibitors have done? By incorporating all these trials and the meta-analysis in the SMART-C study, that SGLT2 inhibitors reduce the CKD progression by 40% regardless of the CKD etiology, and also this effect appears similar regardless of the GN type, as has been shown in the DAPA CKD and the EMPA kidney trial. Like we can see, it is decreasing the progression of the CKD in basically which has been referred in the IgA nephropathy. So what does SGLT2 inhibitor does? It has renoprotection across spectrum of the GFR, including eGFR less than 20. It decreases death due to heart failure, decreases non-atherosclerotic cardiovascular disease. Also, the SGLT2 inhibitors have a role to play in fibrosis, which is mostly regulated by ferroptosis, which has recently been discussed in the EACD conference in 2024. So what does SGLT2 inhibitor does? If it is initiated at eGFR of 85, it decreases or delays the need for renal replacement therapy by approximately 27 years. But if it is initiated at late stage or eGFR approximately 20, then there is just a benefit of only 2 years. So the SGLT2 inhibitors along with this also have benefits beyond the glycemic control, like it has cardioprotective effect, it acts as a smart diuretic, it decreases the pro-inflammatory cytokines, it decreases the weight, it decreases the blood pressure. But SGLT2 inhibitor also cause recurrent genital infection. So what do we need to counsel the patient? That washing of genital organs followed by urination or defecation, use of clean water for washing or mild soap if required, and air dry best rather than wiping with the towel. Mostly the infections associated are mycotic infection, out of which Candida is the most common one. We can advise regarding the use of cream or the fluconazole once or alternate day for 3 days or weekly. But the thing to be kept in mind that SGLT2 inhibitors, if the side effects are there, if there is persistent genitourinary infections, we can continue the drug without stopping it. So we need to inform the patient that there might be or there will be a slight dip in eGFR after starting the drug, but we need to rule out dehydration, infection, NSAIDs. We need to stop or reduce the diuretic, and we need to stop if the decline is more than 30%. And we need to follow the sick day rule by telling if there is a need for surgery, or if there is the patient is unable to eat or sick, we can stop the drug that day and then can continue after the patient feels well. So as per the KDIGO guidelines, SGLT2 inhibitors, as we have seen, is recommended in type 2 diabetics CKD patients with the eGFR of more than equal to 20 ml per minute per 1.73 meters square, and has been shown in the EMPA kidney trial that 30% of the patients who were diabetic non-albuminuric, SGLT2 inhibitors also have a role to play in non-albuminuric diabetic kidney disease. So this was just an effect of SGLT2 inhibitors on discontinuation of RAS blockage, which was a joint analysis of the CREDENCE and the DAPA CKD trial. This shows that even after temporary or permanent discontinuation of ACE inhibitors randomized to SGLT2 inhibitors and placebo, it showed that SGLT2 inhibitors facilitate persistent use of the RAS blockage. So despite these two drugs have been shown in the RAS inhibitors like the RENAL and the IDNT trial, and for the SGLT2 in the CREDENCE, DAPA CKD and EMPA kidney trial, there still remains a residual renal risk. So what do we do regarding this residual renal risk? There is the introduction of GLP-1 receptor agonist. So what has been recommended by ADA is in adults with diabetics and CKD who have not achieved individual glycemic targets despite use of metformin and SGLT2 inhibitors, who are unable to use these medications, they recommend a long-acting GLP-1 receptor agonist. So what is the role of GLP-1 receptor agonist for the mechanism of renoprotection? It activates the protein kinase A, decreases the inflammation, decrease the oxidative stress, increase the natriuresis, decrease the tubular injury, decreasing renal fibrosis, decreasing glomerulosclerosis, and thereby responsible for renoprotection. There have been multiple documented trials for the renal protection by the GLP-1 receptor agonist, but the most widely trial is the FLOW trial for the semaglutide. It was a multi-centric trial, internationally blind, and included patients of type 2 diabetes and CKD with the eGFR till 25. And it has been shown that there was a benefit, a significant difference for the major kidney disease events, for the kidney failure, more than 50% reduction in the GFR, death from cardiovascular or kidney related events. So after the 3 drugs, which drug to use? Either the SGLT2 inhibitors or the GLP-1 receptor agonist. This was studied in the Darwin renal trial, which was a real world retrospective multi-centric trial by the Italian Diabetes Society, which was recently discussed in the EASD 2024 conference. It showed that there was a better preservation of GFR, increased reduction of UACR, and favored SGLT2 inhibitors, but HbA1c reduction was better with the GLP-1 receptor agonist. So this molecule was discussed yesterday also. Tirzepatide, it is an agonist of both GIP-1 and GLP-1 receptor. It has a role in obesity by decreasing the body weight, blood pressure, albuminuria, and has been recently documented in the SURPASS-4 trial. So after these 3 drugs, LAS blockage, SGLT2 inhibitors, GLP-1 receptor agonist, there also remains a slight risk for kidney fibrosis, and then their roles comes of non-steroidal mineralocorticoid antagonist. It has a role to play and decrease the inflammation and fibrosis and also hemodynamic effects. So what evidence does non-steroidal mineralocorticoid antagonist Finerenone has? By the Fidelity trial. It was done in patients with diabetics and CKD, and Fidelity was a pooled analysis of Fidelio, DKD, and Figaro, which included 13,000 patients from stage 1 to stage 4 CKD. It had a run-in period of 4 to 16 weeks, and patients were on maximum tolerated doses of ACE inhibitors or ARB. Patients were randomized to 10 milligram or 20 milligram of Finerenone as per the eGFR and the potassium levels, and there was a long follow-up of 3 years. And mostly the patients included were who had eGFR of 30 to 60, that is the G3A and the G3B. 66.4% of the patients had severely increased albuminuria, but one thing needs to be kept in mind and need to be followed here is that 40% patient of these had preserved kidney function, that is eGFR of more than 60. So the baseline UACR was 515 milligram with the mean eGFR of 57. Mostly these patients were on RAS inhibitors, that is 99.8% of these patients, and approximately 7% of these patients were on SGLT2 inhibitors and GLP-1 receptor agonist. It had both a cardiovascular and a kidney endpoint, and it showed that there was a 23% relative risk reduction for time to kidney failure, sustained eGFR decline, or kidney related death, and also a benefit in patients who were on dialysis by a 20% relative risk reduction. What did it show? That it decreased UACR by 32% after initiating at least after 4 months by 32%. It had similar side effects as compared with placebo, with increased incidence of hyperkalemia, but the impact was minimal. So how do we initiate Finerenone? We need to start and look after the potassium levels and the eGFR. If the eGFR is between 25 to 60 and there are normal potassium levels, we need to start the dose at 10 milligram. But if the eGFR is more than 60, we need to initiate at 20 milligram. We need to monitor the eGFR and the potassium levels at month 1, month 4, and 4 monthly afterward. And if the potassium levels rise by 5.5, we need to stop the drug and then restart if the potassium is less than or equal to 5. So there is a rule of 5 for Finrenon. Firstly, we need to start if the potassium levels is less than 5, stop if the potassium is more than 5.5, eGFR should be more than or equal to 25, stop if the GFR is less than 15, and it reduces CKD progression and hospitalization for heart failure by 1/5. So, as per the KDIGO, it has been recommended in diabetic patients with an eGFR of more than 25, normal serum potassium concentration, albuminuria, ACR more than or equal to 30 milligram per gram, and despite maximum tolerated doses of RAS inhibitors. So, are there any other therapies? We need to, as I've discussed earlier, statins for all patients, bicarbonate levels target should be more than 18, aspirin is not used for primary prevention, uricosuric agents also do not have a role in primary prevention. We need to look after the hemoglobin levels and the mineral bone disease for these patients. So after these 4 drugs, RAS blockage, SGLT2 inhibitors, Finrenon, GLP-1 receptor agonist, what's next? There is the role for pentoxifylline, baricitinib, atrasentan, pirfenidone, roscobitin, selonsertib. These are the pipeline drugs. Also, the stem cell therapy, the miRNA antagonist, we need to look after the antifibrotics, anti-inflammatory. So what is new? The new is the confidence study, which was published 2 months back, which showed combination of Finrenon and SGLT2 inhibitors for cardiorenal protection. It was a multi-centric, 3-armed phase 2 study. It basically screened patients 14 days, randomized into 1:1:1 criteria, and there was a comparison of Finrenon 10 milligram or 20 milligram as per eGFR and potassium levels, and empagliflozin compared individually with Finrenon and placebo, compared along with empagliflozin and placebo. The eligibility of these patients were eGFR of 30 to 90, UACR, it has decreased the value up till 100. Rest of the studies had UACR approximately 200 to 300. So this is quite a significant thing with the UACR included till 100. Exclusion was serum potassium more than 4.8. One thing needs to be seen that in this study, approximately 17% were Indian populations. And most of these patients were on ACE inhibitors or ARBs, that is 98% of these were on ACE inhibitors or ARB, and 23% were using GLP-1 receptor agonist. So what did it show? That after simultaneously initiation of Finrenon and SGLT2 inhibitor, there was a reduction in UACR up to 52%, with a 30% reduction seen just after initiating after 2 weeks. And this effect persisted and remained below the baseline even after stoppage these drugs. So as the AD recommends and the KDIGO recommends, there is need for reduction of more than 30% UACR. But in this study, it showed that 70% of these patients simultaneously initiated achieve the AD recommended criteria. But as the drug has benefits, there are also the risks associated. After simultaneous initiation, it was associated with a reversible reduction in systolic blood pressure and eGFR decline, but this was not associated with any serious kidney adverse events, and the effects were mostly hemodynamic. The potassium levels were also documented to be more than 6%, but they did not have any significant serious adverse events which may lead to hospitalization. So what did the confidence trials showed? That simultaneous initiation of Finrenon and SGLT2 inhibitors in patients with CKD and diabetes led to an early reduction in UACR, which was significantly greater than either agent alone, an additive reduction in UACR up to 52%. 70% of these achieved the AD recommended target of more than 30% UACR reduction, and the adverse event profile was similar to either agent alone. Also, the clinical guidelines now recommend for a combination of drug therapy to optimally reduce the risk, with Finrenon being recommended as a core treatment pillar. So the combination, what is the evidence? It had shown that approximately After initiating these combination therapy, there is decrease for kidney failure by approximately 5% and composite kidney outcome by 7 years. So to summarize, the guidelines recommend both eGFR and UACR testing at least annually for comprehensive CKD screening, but this is not fixed and it is variable as per the eGFR and UACR. Early stage CKD management is frequently missed, yet appropriate intervention can slow or halt the disease progression. Despite the standard RAS blockage, SGLT2 inhibitors, GLP-1 receptor agonist, patient remain at significant risk for CKD progression. And there comes the role for non-steroidal mineralocorticoid antagonists to decrease MR overactivation, decrease the cardiorenal disease progression in diabetic patients, and a combination of finerenone and SGLT2 inhibitors have demonstrated efficacy in slowing CKD progression and preventing cardiovascular event with good tolerability as per the confidence trial. So thereby a combination of drug therapy to optimally reduced CKD progression is needed. Thank you.
Thanks, Dr. Dheer, for your very useful and informative talk on the subject.
Thank you, sir.
Now any comments and queries are most welcome.
It's just not a comment. Dr. Dheer, I think probably in recent time, SGL2 and GLP-1 probably is like an Aladdin Chirag, na? For every damn thing you see, reduced ejection fraction, for obesity, for diabetes. Now, today you see you're talking about CKD. Probably I think only time will tell you see where we are going for. And I'm not sure see what is going to happen in the near future. That means every patient with CKD, then you are talking about diabetes.
Yes,
Suppose the patient is not diabetic. Can these SGL2 and GLP can be helpful there also?
Thank you for the question, sir. SGLT2 inhibitors have been recommended in non-albuminuric or non-diabetic patients also as per the DAPA CKD and the EMPA kidney trial. So SGLT2 inhibitors have a role in non-diabetic CKD patients as well.
And the titration of SGL2 irrespective of the level of creatinine?
So we need to start the drugs like the dapagliflozin, we can start at 10 milligram and we can continue up till all spectrum of the GFR, even if the patient is dialysis dependent, by at least explaining the risk, what are the side effects associated with it.
Okay, thank you.
Thank you, sir.
Now I invite our next speaker, Dr. Ginny Agarwal, consultant ophthalmologist from Civil Hospital Jalandhar. She will be delivering her talk on diabetic retinopathy.
Hello. Hello, good afternoon everyone. I thank the organizing committee for giving me this opportunity to come and talk about this topic today. So let's start. So diabetic retinopathy is a microangiopathy which is caused because of hyperglycemia. Now we know the small blood vessels are very susceptible and they generally do not tolerate high levels of glucose. So the global prevalence and burden of diabetic retinopathy, almost 22.3% of people today suffering from diabetes have DR and 6.2% have vision-threatening diabetic retinopathic complications. And grossly over 103 million individuals are affected worldwide, which is 1 in 3. And the staggering question now is that the working population, the age between 40 to 50 are also getting affected by it every day. So the lifetime risk of developing diabetic retinopathy, there was a very good cohort study conducted on Wisconsin, and the study showed that over a period of 20 years, 90% type 1 diabetics have some degree of retinopathy, whereas the same percentage is 50 to 60% in type 2 diabetics. Now this is a very significant number. Then let's talk about a little bit about the pathogenesis. Normally what happens is that the glucose, it gets into the glycolysis and the Krebs cycle to produce ATPs, NADPs, which provide energy to the cells. But when the glucose molecules are very high in number, that is what, when the glucose is high, what happens is that the glucose is diverted towards the polyol pathways, creating advanced glycation end products, the reactive oxidative species, and sorbitol. Now these three are quite toxic. They cause membrane damage, they cause intracellular and extracellular protein malfunction, and they cause osmotic toxicity. There is also thickened basement membrane of the capillaries, and there is pericyte death. Now pericyte death, let's just take a minute here. Pericytes are the cells which sit on the basement membrane of the epithelium. Once these cells are lost, there is outpouching and there is microaneurysm formation. These cells cause endothelial cell loss further, and which results into hypoxia. Now, we all know wherever there is hypoxia in the body, the vascular endothelial growth factors come into play, and that is when angiogenesis starts. But the problem with these blood vessels, these new vessels, is that they're very fragile. They keep leaking. There is leakage of blood, there is leakage of fluid, and that is what causes edema of the retina. Also, there is breakdown of blood-retinal barrier, which causes vascular hyperpermeability. So this is just a short video. Sorry. Okay, since it's not working, let's skip to the next point. So clinical symptoms associated with diabetic retinopathy are loss of central vision. The patients complain of blurred vision. Then there is fluctuating vision and eye pain. So talking about the risk factors, the most important risk factor is the duration of diabetes. The longer the duration, the more are the chances of developing features of retinopathy. So type 1 diabetics, as already mentioned, over the period of 20 years, almost 80% progress towards retinopathy, and type 2, 50 to 60%. The next important is obviously the control of diabetics, which is measured by glycosylated hemoglobin, HbA1c levels. Now, there was a study which recently, sorry, excuse me, please. Now, there was a study recently which showed that every 1% reduction in HbA1c causes 35% reduction in diabetic retinopathy, and maintaining HbA1c around 7%, less than 7, really decreases and slows the progression of diabetic retinopathy. For hypertension, it's just a basic understanding that if the blood pressure will be high, there will be more leakage from the damaged vessels. So tight BP control reduces the progression and risk of vision loss by 47%, which is very significant. Lowering the blood pressure from 150 to 130 significantly reduces the progression of PDR. But here I would like to mention that lowering the BP below 110 also poses the risk of ischemia of the retina, so the ideal value should be around 120, 130. Also, increased cholesterol level means more hard exudates. Then triglyceride increase can also lead to production of diabetic retinopathy. Then the role of fenofibrate comes. Fenofibrate reduces the risk of reduces the frequency of laser in edema by 31%. Then let's talk about the normal retina. I don't know what's okay, I'll see. So here is a picture of the normal retina. This is the optic nerve head. Here the retinal arteries enter and the retinal veins leave. And this is the fovea. This is the macula. The peripheral retina is the neurosensory tissue. So all the fibers, they receive the light and then focus all the signals towards this optic nerve, which then conveys the signal to the brain, and that is how we see. So the vision forming center is this part of the retina. So now let's talk about the ETDRS classification. हाँ जी सर Thank you so much, sir. So the ETDRS classification is modified early house classification. In 1980s, a lot of ophthalmologists got together and they compared the fundus photographs, and that is how this classification was later modified in 1990s. To our surprise, however, this is still the primary classification system that is used. They classified diabetes into two types, the non-proliferative NPTR and the proliferative diabetic retinopathy. So in mild NPDR, when there are only microaneurysms, there is retinal hemorrhages and cotton wool spots. Now all these changes, they are reversible. You control the diabetic level and everything goes back to the normal. So you call the patient after one year, that's fine. In moderate NPDR, there are several severe retinal hemorrhages, about 20 in 1 to 3 quadrants. There is venous beading and there is cotton wool spots. Now venous beading is where there are pericyte loss, there is outpouching. That is why there is a sausage-like appearance which we clearly see on retinal examinations. Then there is severe NPDR where we follow the 4-to-1 rule. When there are severe hemorrhages in all 4 quadrants, there is venous beading in 2 quadrants, and there is moderate IRMA. Now IRMA is intraretinal microvascular anomalies. These are the shunt tissues which develop because of the hypoxia of the retina from the arterioles to the venules. These patients require surgical management sometimes, and they require very close follow-ups ranging from 3 months to 4 months. Let's show you a few pictures. नहीं आ रहा यहाँ पे अच्छा सर ये ना इतनी पिक्चर्स एनिमेशंस की तरह आ रही हैं से सारी वीडियो नहीं सर पिक्चर्स हैं let me try with this clicking नहीं सर फिर वो पीछे है हाँ जी सर I'll show with this only then I'll use the mouse no problem sir so these were actually animations so I'll just show around these whitish spots are the cotton wool spots. These are the lipid exudates which follow. These are the hard exudates. What happens is this is the lipid, the macrophages which are lipid laden, and the more the cholesterol of the patient, the more this will cause problems. Now see, this is the optic nerve and this is the macula. Now such a deposition of macula, now this patient won't be able to see anything. So these are the hemorrhages. I hope. Yeah, these are the hemorrhages and these are the hard exudates and these small reddish, these are hemorrhages and microaneurysms. These are how we classify our diabetic retinopathy on the fundus examination. Most of our centers do not have very sophisticated machines like optical coherence tomography. So these methods still help us to diagnose the patients on daily basis. Then is the proliferative diabetic retinopathy. Now see, this is the optic nerve. This is the retinal vein. This is the retinal artery. Now retinal artery and retinal vein are differentiated by the presence of laminar flow in the arteries. And these fronts are all neovascularization. Similarly, this is also, this here is the venous beating I was talking about. This is the sausage-like appearance and this is the neovascularization. Now these blood vessels will keep leaking, there will be vitreous hemorrhage and the patient will have visual symptoms. Proliferative diabetic retinopathy is a huge problem for us and this is when we have to do lasers multiple times and these might need surgical intervention as well. Moving on, now this is what an OCT image looks like. This is the optical coherence tomography. This shows all the layers of the retina. I hope everybody remembers, we used to remember the 10 layers of the retina. So these are all those layers. This is the choroid, this is the vitreous, this is the retina, and the retina's basement epithelium membrane, the photoreceptor layer, and the normal foveal dip. Now this architecture, this dip is very important for our vision. Now what happens in diabetes? This is what happens. There is fluid here. Now that contour is lost. Now this is massive collection of water and whatever fluid is leaking. And because of the loss of the normal structure of the fovea, the patient will not be able to see. The next stage which happens is the detachment of the neurosensory retina from the pigment epithelium. Then there is tractional type. This is the membrane formation. And then this is taut posterior hyaloid. These two stages will eventually need surgical intervention. Moving on. Now the screening part, the most important question many of our colleagues ask us. So if a type 1 diabetic patient comes to you, that patient is insulin dependent and very early diagnosed. So send the patient to for retinal examination 5 years after the diagnosis. Retinopathy is a slow process. It takes time to develop. And then we have to see the patient yearly. However, if the patient is type 2 diabetic, we don't know since when the patient has that status. So whenever you diagnose a patient of diabetes, you have to send the patient immediately and for retinal examination. And then depending upon the stage, we further ask the patient to review with us annually or whatever stage the patient is in. Now, if a diabetic female wants to conceive, that time we need to see the patient before conception and in the first trimester, and then every 3 months and first year postpartum. In gestational diabetes mellitus, we are not that much worried because in this, the chances of retinopathy are quite less. So the two important things, ischemia हो रहा है, edema हो रहा है. Ischemia ਲਈ ਆਪਾਂ laser use करना है and जिथे edema है पानी सुकाना है ਆਪਾਂ ਉੱਥੇ ਆਪਾਂ injections use करने हैं and we have to use steroids there. So we have to inform the patient for the need of multiple injections. The choice of injection depends upon the affordability. These are very expensive injections. Then we have to counsel the patient that the injection may not be 100% effective. And on the basis of the OCT thickness and the best corrected visual acuity, we decide whether to stop the infection or injections or proceed with them. So we get a diabetic patient. If there is no retinal findings, we call them after 1 year. If mild to moderate, we tell them to control their parameters and they can come after 1 year. All the changes are reversible, the hard exudates, they resolve, and every finding goes back to normal. If there is a severe NPDR where hypoxia is setting in, then we need to do pan-retinal photocoagulation. We burn the entire peripheral retina. There will be no place for the secretion of VEGFs and hence avoidance of complications. If there is proliferative diabetic retinopathy, then we need to intervene if there is vitreous hemorrhage, there is pars plana vitrectomy and other surgeries which are happening these days. The most common cause of vision loss in patients with diabetes is macular edema. If it is center sparing, go ahead with laser. The laser settings are very low parameters. And if the center is involved, now this gets very tricky. Here, if the vision is 6.6 or 6.9, the patient is satisfied, then do not do anything, kindly observe. If the patient's vision is less than 6.9, we have to go ahead with anti-VEGF therapy. Now, there are these 3 injections which we are using these days, aflibercept, ranibizumab and bevacizumab. Bevacizumab is the cheapest, but unfortunately it is still not approved by the FDA for ophthalmological use. It is used in colon cancer. Ranibizumab is a very good drug and aflibercept is the most expensive, safest, but it costs around 40K to the patient, so it's not easily used these days. However, these 3 options should be given to the patient and all 3 have the same result at the end of 6 months according to the Clarity study which was done in 2021. So the last few slides, we have to optimize HbA1c. If there is NPDR, kindly only observe. Retinal laser is the treatment of choice. In edema, we have to use anti-VEGF and steroids. If a patient has undergone cataract surgery and they already have implant in their eye, then steroid is a very good option. Steroids otherwise cause cataract, so we do not give it to the patients who have not undergone cataract surgery. These are how the implants look like. They are very tiny. We inject them into the vitreous cavity. They stay up to 6 months there. The cost is 25,000. This is dexamethasone, and the other one is fluocinolone. It is used, not yet approved by FDA for the use in diabetic macular edema. However, it is used in uveitis. The life is 36 months, and it is non-biodegradable, does not cause any problems. Next is the surgical management. I'm not dwelling into the details. So this we have already discussed. PDR needs treatment monthly. Edema needs monthly basis follow-ups. So takeaway messages, please maintain HbA1c less than 7. The blood pressure control 130/80. Type 1 diabetics have more common features of retinopathy. The patient to be sent for first retinal examination, type 1 after 5 years, type 2 at the time of diagnosis. Thank you for your patient listening. Thank you.
Thanks for the useful and informative talk. This part of the diabetes is usually neglected part. Usually doctors and patients both neglect this part of the diabetes.
Yes, sir.
Mostly doctors do not recommend retinal examination and patient also neglect.
Yes, yes, yes.
This is a very bad scenario.
Thank you very much for adding to our knowledge the implant, etc. We did not know. In fact, the visual impact is much more than what we read.
Yes, sir. Yes, sir.
So thank you very much. And I must tell you, way back in 1988, when we joined our MD,
yes, sir.
Our boss told us the very first day to purchase ophthalmoscope.
Yes, MC.
And do not enter OPD without ophthalmoscope. We at that time purchased Heinz
Yes, sir.
ophthalmoscope, and it is still in my OPD.
Yes, 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 sir.
Every patient of headache, diabetes, hypertension, upper story.
Yes, sir.
If there is any problem, they taught us how to check the fundus, do fundus examination,
Yes, sir.
and at least see broadly whether we need to refer it to ophthalmologist for detailed examination.
Yes, sir.
But now I find no physician will be having ophthalmoscope.
Very less, sir.
And that is why they, it is neglected. Once you tell the patient to go to ophthalmoscope, half of the time, ophthalmologist, half of the times he will not go.
Yes, sir. They reach to us when they have
So
symptoms.
we are keeping such things to apprise and motivate the physicians to at least go for overview or basic examination to detect whether it is normal or it is abnormal. If abnormal, refer. Normal, you follow it after 12 months or 6 months, whatever the case may be.
Yes, sir.
So thank you very much for apprising us of the newer things for us. May not be for you new, but for us it is new things. Thank you.
Thank you, sir. My pleasure, sir.
I just want to add one thing, according to Dr. Vittal. I mean, everybody should use ophthalmoscope, but unfortunately, NMC will be after you if you start using ophthalmoscope as a physician, you see.
No, sir, please send to us.
Fundus examination,
So every
refer to ophthalmologist.
Every ophthalmologist will like that any diabetic patient must be referred.
Examination for physicians also.
Yes, sir.
They should know it.
No, evaluation, evaluating a patient, or this is a part of the evaluation. So it doesn't become that easy.
Normal है, abnormal है. तुझे abnormal होवे ना पंगा लो.
How many people do the PR now?
How do you define?
Because that is non-touch technique. We are losing faith. We are losing the concept of clinical medicine.
Yeah, that's the problem. The basics. Thank you.
Excellent talk.
Very good afternoon. I think the next speaker is one of friend Aziz, Dr. Rajesh Jindal, and I don't think he requires any introduction or any sort of thing. The topic for him today is, I mean, you all talk about statins, and everybody knows the role of statins in cardiovascular disease. But today he's talking non-statin therapy for dyslipidemia. I think it's very, very interesting, and rather it should be very interesting. And I now invite Dr. Rajesh Jindal for his talk. Dr. Jindal.
Thank you, sir. So again, at the outset, I would like to thank the organizers, especially Dr. Vittal Gupta, for giving me this chance. And thank you, Dr. Noria, for kind words. So as you already said, this topic is going to be very interesting. Even I find this topic very interesting because we all use statins left and right in our daily practice. But non-statin therapy, like statins and beyond, which we call beyond statins, what lies beyond is a, not that much explored area. So today we're going to talk about this. And so as we all know that cardiovascular disease has, reached dramatic proportions in our country, especially in the South Asians, and prevention of cardiovascular disease, especially the primary prevention, because as I say, prevention is better than cure, has also assumed paramount importance. Statins, we know, are the cornerstone for primary prevention of cardiovascular disease, and the various guidelines have recommended statin therapy for primary prevention of disease according to various factors, depending upon whether it's primary prevention or secondary prevention, depending upon, you know, various risk markers. So I'll not go into detail. And even the Lipid Association of India guidelines, you know, they have divided all the risk markers into 3 categories. One is major risk markers, high risk features, and moderate risk features. And according to the presence of one or the presence and absence of these risk markers, patients are categorized into these 5 categories. You know, see, low risk, moderate risk, high risk, and very high risk. And if you see on the right side extreme, this extreme high risk, extreme risk category is one addition which the Lipid Association of India added to the Indian population because of our propensity for having, you know, kind of very high propensity for developing coronary artery disease. So this is an extreme risk category which we will not find in the other guidelines, because we as a subgroup has very high propensity for developing cardiovascular disease. And just a word about CT angio, because a lot of people come to us in the OPD that I got my CT angio done and it revolves such and such calcium score, whether I should take a statin. They gave me statin, whether I should take it or not. So as they say, if you are a high risk, high cardiovascular risk, secondary prevention, very high LDL, secondary prevention, diabetic with the age 40 to 75, you definitely become a statin, you fall in the statin benefit group. If you are a low risk, definitely we can just wait and adopt other lifestyle measures. What happens if you are in an intermediate risk? If you are in an intermediate risk and you are not diabetic, this is for primary prevention, then they say that CT coronary angio is a tool to further risk stratify whether you will be benefiting from this particular therapy or not. If you get a CT angio done in a risk factors to risk of 7.5 to 99.9, and the CT score is more than 100, statins are recommended by the guidelines. If it is less than 0, you don't need statin therapy, and in between 1 to 99, statin therapy is favored. You can still, you may benefit from it, but not that strong recommendation. So just a word about CT angio, how to use this as a clinical tool in defining the risk of the patient and probable benefit from the statin therapy. And again, going into the lipid goals, as I said, extreme risk, very high risk, and according to the risk categories, the lipid goals are very stringent. If you see on the extreme left, extreme high risk, the lipid LDL cholesterol and non-HDL cholesterol goals are less than 40 and less than 70 milligram per deciliter respectively. And so on and so forth. If you go into the lesser risk category, 55 and 85 in very high risk, 70 and 100 in high risk, 100 and 130 in moderate risk, and 100 and 130 in the low risk. So very stringent LDL cholesterol goals and non-HDL cholesterol goals. So how do we achieve them? We have been using statins for them, but as we all know that statins have their own problems. So many patients, they just discontinue. The prospective cohort says 50% of the patients discontinue statin in the due course of time because of one or the other reason. Perhaps the nocebo effect, perhaps they have some kind of a muscle symptoms or whatever. And then, even if they keep taking recommended doses of statin, many of them do not achieve LDL cholesterol goals. So genetic variability, inter-patient variability, absorption issues, and metabolic issues leads to patients do not achieve their LDL cholesterol goals. So here comes the role of non-statin drugs, because the guidelines say that failure to achieve LDL cholesterol goals is a major impediment in reigning this malady, which is cardiovascular disease. So one should always strive for achieving the LDL cholesterol goal as recommended by the guidelines. So just word about high intensity, moderate intensity, and low intensity statin therapy. What is high intensity? When we are expecting 50% reduction in the LDL cholesterol level, it is high intensity. 30 to 50% it is moderate intensity, and we are expecting less than 30% LDL cholesterol reduction, it is low intensity statin therapy. And then, as I said, a lot of reasons for not achieving LDL cholesterol, and physician inertia is also one of the very important reason we are not able to achieve LDL cholesterol, because we just put the patient on a atorvastatin 10 milligram or rosuvastatin 10 milligram and then just forget about that we have to follow up this medication, 4 weekly, 6 weekly interval, titrate the medication, up titrate the statin therapy and try and achieve the LDL cholesterol, because we just don't bother about achieving the goals. We just put the patient on the statin and just forget about it. And so here comes so the role of non-statin drugs, that despite taking some patients the full dose of statins, or some patients who are not tolerant to statins, what do we do about such patients? A lot of drugs have come up in the last few decades. Let us talk about them one by one. So if we start from the top of the table, that is bempedoic acid. I'm sure all of us must be using it in regular practice, but this is something easily available, cost effective, and oral administration. Then inclisiran has been introduced for last few years, and a lot of talk has happened about this particular molecule. PCKS9 inhibitors, that is evolocumab and alirocumab. Ezetimibe we have been using for a long time. Bile acid sequestrants, niacin, fibrates, and omega-3 fatty acids. So these are some of the non-statin molecules which we will be discussing one by one. So how do they act? So this is a very scary kind of a diagram, and I'll not go into much detail, just few words that about the common molecules. This is bempedoic acid. Do we have a laser? Okay. So this is bempedoic acid, right? And so bempedoic acid is a molecule which acts upstream of where the statins act. Statins act on the HMG-CoA reductase, and upstream there is an enzyme called ATP citrate lyase. Bempedoic acid inhibits this particular molecule. That's why they say that bempedoic acid plus statins, they have a synergistic effect, and the combination therapy has 15 to 18% additional lipid lowering, LDL lowering effect. And then if we see these PCKS9 inhibitors, alirocumab and evolocumab, both of these molecules are monoclonal antibodies. What they do is they just go and kind of attach themselves to the PCK9 protein. Now this particular protein is a notorious protein because it is what it does is it goes to the LDL receptors, binds with them, and degrades the LDL receptors. Now this degradation of LDL receptor leads to failure of uptake of LDL and increased level. So by blocking this PCKS9 protein, the LDL receptors, they remain a good amount of intensity on the cell surface, and LDL uptake is increased, and that is how they lower the LDL cholesterol level. So on and so forth, the various molecules, they act on one or the other pathway, and whereby they exert their lipid lowering effect. Various trials have come up starting from 2013 up to 2014. I will not go into detail. Some of the landmark trials are SPIRE, Odyssey trials, and then you have the Fourier trials, Improve It. So the various molecules which we will be talking shortly, they have been tested in this randomized control trial, and most of these trials have come up with some evidence which points towards their use, practical use in the clinical scenario. So ezetimibe, as I said, again we have been using this molecule for quite some time, especially in combination with in statins, and it inhibits the NPC1 protein and reduces the cholesterol absorption at the intestinal level, right? So this is one protein which helps in the transport of the lipoproteins, and by inhibiting the NPC1L protein, it inhibits the absorption, and it reduces by monotherapy reduces 18% of the LDL cholesterol, and combination therapy reduces almost 25%. What are the side effects? The side effects are, nasopharyngitis, myalgia, sinusitis, extreme pain in the extremities, upper respiratory tract infection. These are some of the side effects of ezetimibe. And doses, we all know that 10 milligram once daily, and it can be taken irrespective of the meals, and may be taken any time of the day. And no dose adjustments is required, especially in the hepatic and liver impairment. And bempedoic acid is a prodrug, as I already discussed. It acts upstream of the HMG-CoA reductase at the ATP citrate lyase level, 18% LDL reduction and high sensitivity CRP reduction, and it has got no effect on the triglycerides and lipoprotein A levels. And again, no dose adjustment is required in hepatic and renal impairment if it's not advanced renal impairment or advanced hepatic impairment. And hyperuricemia, nasopharyngitis, and one particular side effect which one should be watchful of is tendon rupture has been reported by use of bempedoic acid. It is cheap and well tolerated option. So PCKS9 inhibitor, as I said, they just go and block this PCKS9 protein which degrades the LDL receptors and thereby increases the density of LDL receptors on the hepatocyte, which leads to the increased uptake of LDL and thereby reduction in the LDL cholesterol level. And inclisiran similarly is an siRNA molecule which doesn't act to the PCKS protein. It actually stops, it goes into the PCKS9 gene and stops the PCK9 production. So again, the inclisiran is given 6 monthly subcutaneous and leads to almost 50% incremental LDL reduction over and above statins. So gradual onset and sustained effect on LDL lowering. On the other side, the monoclonal antibody which we just discussed, evolocumab and alirocumab, they have immediate action, and they have to be given more frequently, like bi-monthly or once a month subcutaneously. But inclisiran is a more gradual onset of action and can be given 6 monthly. So this is the basic difference between these two types of PCSK9 inhibitors. So basically the use of inclisiran is not recommended in the routine clinical practice except in the setting of heterozygous familial hypercholesterolemia and homozygous familial hypercholesterolemia, because a lot of issues, subcutaneous administration, injection site side effects, and also high cost of the therapy is barriers to using inclisiran. So PCSK9 inhibitors and then bile acid sequestration, as we all know, they go into the intestine and bile to the hepatic bile acid pool, thereby reducing its reabsorption, and thereby the liver has to work more to produce these bile acids and then consume the cholesterol, because the bile acids are produced from the cholesterol, and thereby leads to increased LDL cholesterol clearance from the bloodstream. We know that we have cholesterol, cholestyramine, and cholecebulin. They have got different doses. Like cholecebulin is given 6 tablets per oral daily or 3 tablets per oral twice weekly, and similarly cholestyramine and cholesterol. And mean LDL reduction is with monotherapy is around 15%, and with additional 10 to 16% if used with statins. Phytosterols, we know that phytosterols are molecules which chemically resemble cholesterol, and so thereby they compete at the intestinal brush borders with the cholesterol for absorption. So thereby the ingestion of phytosterols actually leads to reduction in the cholesterol absorption and thereby reducing the cholesterol levels. Then there is soluble viscous fiber. Again, soluble viscous fiber reduced to low absorption of the cholesterol because it kind of acts at the micelle level when the chylomicrons are formed in the intestine, and thereby reduces the absorption of cholesterol. The effect on LDL cholesterol is modest, not very high, but still they say that it is one of the most cheapest, easily available, and one of the most health-friendly, gut-friendly option available as a non-statin therapy. And mipomersen and lomitapide are two more molecules. Again, what mipomersen does is it blocks the production of ApoB100. We all know that ApoB100 is a major apoprotein for this bad cholesterol, the LDL and the VLDL. All of these have the ApoB100 as a major lipoprotein. So this is by acting as an antisense oligonucleotide, mipomersen blocks the production of ApoB100 and thereby reduces the production of the circulating levels of ApoB containing lipoproteins, that is LDL and VLDL. And similarly, lomitapide, it inhibits the microsomal triglyceride transfer protein and thereby has more effect on chylomicrons and VLDL, right? And also leads to reduction in the LDL cholesterol level. LDL apheresis, I'm sure this must be a little kind of a new term for all of us. And they say that some patients, especially the patients with familial hypercholesterolemia, even despite giving intensive statin lowering, LDL lowering therapy, with statins, high-intensity statins, PCSK9 inhibitors, and ezetimibe, bempedoic acid, all those things, despite they have very high cholesterol levels. Those are the patients whom can be actually referred to LDL apheresis, which actually selectively removes this ApoB100 containing LDL particles from the bloodstream. They will have a drastic reduction in the LDL cholesterol level. So LDL apheresis has got its own select indication in select patients, and that's a very useful, especially for those patients who suffer from familial hypercholesterolemia. Omega-3 fatty acids and omega-6 fatty acids, we all know that EPA, that is eicosapentaenoic acid, and DHA, that is docosahexaenoic acid, they are basically found in fish oil and green leafy vegetables. Similarly, omega-6 fatty acids. How do they act? They basically, we all know that they have anti-inflammatory properties, membrane stabilizing properties, plaque stabilizing effect, and also they have got marked lipid lowering effect in the form of decrease in the triglyceride-rich lipoproteins, apoprotein B and apoprotein C3. So that is how the omega-3 fatty acids and omega-6 fatty acids, they have a lipid lowering effect. So this is just a general idea how these various group of drugs, what is the quantum of their effect on the LDL lowering. If we see the ezetimibe, roughly 15%, the bempedoic acid, 24%, moderate intensity statin, 30% lipid lowering, LDL lowering effect, high intensity statin, as I saw, almost like 50%. And if we go to the bottom, when you combine all these therapies like high intensity statin, ezetimibe, PCSK9, you can achieve almost 90%, 85% LDL lowering. So we have a lot of tools in our hand. The idea is, the question is how much we use them. The idea is to put them into practice. We have a lot of things in our hand. If somebody has a 300 milligram per deciliter of LDL, you just imagine 90% lowering. That means we can bring it down to 30 milligram per deciliter, but we should be ready to use the tools available in, as the patient demands, as the patient clinical status demands. So putting all this information into clinical practice, let us just go through a few case examples very quickly. So this is a 58-year-old gentleman, hypertensive, had a non-STEMI 3 years back, has an LDL level of 92, HDL of 38. What should we do about this man? Anybody from the house? Should we give him low intensity statin, moderate intensity, high intensity, no statin, fibrate, non-statin? No statin, why sir? He already had a non-STEMI 3 years ago. So any patient who is already has a clinical atherosclerotic cardiovascular disease, he falls into the preview of secondary prevention. All secondary prevention patients have to be treated with high intensity statins. This is the recommendations, right? So there are 4 basically statin benefit groups, which definitely the guidelines say that you have to identify these 4 groups which will definitely drive benefit from giving statin therapy. One is clinically present CAD. Number 2, LDL level more than 90, irrespective of diabetes, hypertension, clinical cardiovascular disease. LDL, very high LDL, that means. So clinical CAD, clinical cardiovascular disease, LDL more than 190, diabetic patients between 40 to 75 years of age. The third, 40 to 75 years of age. And if nothing is present, then the next 10-year risk of having cardiovascular disease should be more than 20%. So these 4 particular subgroups will definitely benefit from. These are called statin benefit groups. So in this patient, definitely we will start the patient on high intensity statin, review after 4 weeks, see whether we have achieved our goal, which is 55 for LDL and 85 for non-HDL. If the patient is still not on goal, add ezetimibe 10 milligram. And then again reassess after 4 weeks. If the patient has still not on goal, then you must considering more non-statin drugs like bempedoic acid or other drugs. So this is how one should be, not just putting the patient on a moderate intensity statin, just forget about this. So this is how. So another example, 54-year-old man had acute MI 3 days ago, had received a stent. LDL is 120 milligram. How should we go about this? So acute coronary syndrome, LDL 120.
So there is a LDI study now, recent study, where all the 3 drugs were started in acute MI. After 1 day, first day the reports came, and they benefited in long run, and target LDL was below 50.
Yes, sir. So this is improve IT study, right? Improve IT study. They said that even in ACS patients, one should aim at early combination therapy rather than monotherapy. in ACS patients, because this is the highest risk subset. So in these patients, not only monotherapy, but early combination therapy, and as Dr. Vitul said, very stringent control of LDL levels, because that has been found to be beneficial as far as MASI or the major adverse cardiovascular outcomes are concerned in the long run. So again, the picture shows 40 milligram rosuvastatin, 80 milligram atorvastatin plus ezetimibe, early combination therapy in ACS patients, then re-examine at 4 weeks, see whether the goal has been achieved or not. If it hasn't been achieved, then add bempedoic acid and move forward, right? So just not stop at, start initiating the statin. You have to review the patient again, see his overall risk profile, see his, likelihood of benefiting from, intensive treatment, and then decide to customize his treatment accordingly. So, what about somebody who doesn't have diabetes, hypertension, is a young man, 52-year-old, but the LDL levels are 240. Somebody comes to walks in the OPD, he has nothing, he says, I am perfectly asymptomatic, no diabetes, no hypertension, non-smoker, no family history, but my LDL level is 240. What should I do?
Lifestyle modification and
cascade screening of the siblings and all those things. Because these are the patients who definitely have very high likelihood of having premature coronary artery disease, malignant coronary artery disease, and these are the patients who will definitely benefit from aggressive lipid lowering, especially with non-statin agents. We have to identify this particular subset. So depending upon the DLCN score, whether the score is more than 6, potential familial hypercholesterolemia, whether it is heterozygous, then you go for cascade screening in children and sibling, lipid profile genetic testing, and then start the lipid lowering treatment with high intensity statins, ezetimibe, bempedoic acid. Patient is not able to achieve goal, add PCSK9 inhibitors. PCSK9 inhibitors has got kind of a very pivotal role in the treatment of meningioma patients with very highly raised LDL levels. So these are the patients whom we can say that we can justify our high cost of PCSK9 inhibitors, because the magnitude of benefit you're going to derive from this subgroup is really very high. So the cost doesn't matter if you're dealing with such a patient. So what are the options? We have evolocumab, alirocumab, as I already discussed, or inclisiran. Evolocumab and alirocumab are, bi-weekly doses, subcutaneous. Inclisiran is 6 monthly doses. Both are very costly medications. They do have their own, because of the parenteral subcutaneous administration, their own local side effects. But still, the amount of incremental lipid lowering is very high. So this is one way of, achieving. And still, if we are not able to achieve goal, LDL apheresis, as I just mentioned a few slides back. So specialized therapies, as I said, mipomorphin and lomitapide, or LDL apheresis. What is the role of these specialized therapies? They can be needed if the patient still has LDL more than 90, has phenotypic homozygous familial hypercholesterolemia, and despite treatment with statins and ezetimibe, PCSK9 inhibitors. So these are the specialized therapies reserved for such patients. And then LDL apheresis I just mentioned, and then ezetimibe, just one word about ezetimibe, there's these 9 particular subsets: CHF, hypertension, age more than 75, diabetes, stroke, CABG, peripheral arterial disease, GFR less than 60, and smoking. These particular 9 subset of patients, they have been found to have, derive more benefit from ezetimibe therapy rather than, adding any other non-statin. So if you have these clinical conditions available, you would just tend to add ezetimibe before adding any other, non-statin drug. So I think this is just, statin intolerance. If we know that patient has statin-associated muscle symptoms, what do we do about this? If the rhabdomyolysis, no statins, significant elevation of CPK, you have to stop statins for 4 weeks. And if mild elevation, stop it. After 2 weeks, you can again re-challenge with a mild dose. If the patient has recurrence of symptoms, you shift to another statin. And some people say that pitavastatin is one statin which can be used if patient is not tolerant to any other statin. If you feel that this is a very strong indication for putting the patient on statins. And so hypertriglyceridemia, we can just skip this for the sake of time. And so just to put everything into perspective, so we see we have a patient who has an indication for lipid lowering therapy. We put the patient on lipid lowering therapy. Target goal is 55 to 70. Has the patient achieved the target? No. Then what is the additional incremental lowering we are desiring? Is it less than 30% or more than 30%? The guidelines say if your additional lipid lowering desiring is less than 30%, go with ezetimibe or bempedoic acid. We want more aggressive lipid lowering, more than 30%, then you can directly go to a PCSK9 inhibitor. So this is a just general kind of a recommendation or an approach, practical approach, how to proceed, while using these non-statin therapies. And so take home, it has got non-statins have attained key status in the last few years, and it leads to targeted intervention and personalized treatment. Initial combination therapy has been found to be very useful, especially in the acute coronary settings, and expanded use of bempedoic acid for not at goal, despite using statins and ezetimibe. PCSK9s are useful adjuncts for LDL goals, especially in select subgroups like homozygous hypercholesterolemia. Thank you very much.
Excellent talk, Dr. Jindal. Very nice. I think most of our physicians probably will in future will try to give more and more benefit of non-statins rather than statins.
Yeah, because these two drugs are bempedoic acid and ezetimibe. They are like easily available. They are very cost effective, not very cheap medication. So at least using these two drugs in addition to statins, this can be at least done at a more widespread, at a more widespread use of these two drugs should be done, because achieving LDL cholesterol goal has been shown to be in various trials to have incremental reduction in the CVD events. So this is one concern which has been raised in all the guidelines that, we are just not following up those patients at regular intervals and titrating our medications, increasing the intensity of statins, adding these non-statin drugs and all those things.
Again, you see, because of the side effects of the statin, most important is the muscle sort of cramps or weakness for that means. And the other thing we have seen, now it has proved beyond doubt that at least in my experience, statin do cause diabetes, And previously it was just our observation. I think now it has been proved beyond doubt that the long-term use of statins do cause diabetes.
Yes. Yeah, there are concerns about, kind of increasing the vulnerability for diabetes.
Like the last patient you mentioned, non-diabetic, high LDL, and once you put him on statins, probably coming 10 years he end up with a diabetes. That's another problem.
Yes.
So very good lecture. I think your lecture will be circulated widely because it is going to address the inertia among physicians. So LAI, Lipid Association of India, has gone for Indian specific consensus statement where they have added the third category, very high risk category C, where LDL goal has been to be the less than 30 and optimum is between 10 to 15. And you cannot achieve this with statin. There comes the role of non-statin drugs. And reducing the dose of statin, adding non-statin drugs will help us to achieve the goal. Thank you very much, Dr. Jindal. And message to all the physicians, go for LDL checkup and try to optimize and achieve the goal as required by the patient's condition and target to be achieved. Thank you very much.
Thank you very much. Thank you.
Any other question or comment?
Do not have?
Without comorbid conditions,
yes.
sir, usually we get the reports of LDL and cholesterol high. Then can we shift on to this lifestyle modification only without drugs?
Can you say it again?
Sir, like... Some people are coming with reports.
You see, lifestyle modification is a, first measure which has
Yes,
been, which has to be recommended for all patients, right?
Yes, sir.
But then we have to see how aggressive you have to approach the patient depending upon the overall risk profile. There are so many, cardiovascular risk profile assessment tools available, or just online also. There are, you just try out ASCVD risk assessment tool, and then the chart will come out, just fill the numbers, and there will be the overall 10-year propensity of having a CVD event, that the risk 10%, 15%, 7. So we have to risk stratify the patient. If the patient doesn't fall into any statin benefit group, and if the patient is having a low to intermediate group, you have to risk stratify those patients. And according to the 10-year risk of CVD event, we initiate our therapy. If the patient is low risk, you can just suffice the lifestyle modification and other things will suffice. If the patient falls into moderate risk, then the guidelines say that statins are recommended for such patients.
Usually people stop taking these fats, like, sir, but we should decrease the carbohydrate intake.
Yes, the dietary prescriptions, especially says that, the carbohydrate content has to be less than 30% of the total calorie intake, especially when you are managing such dyslipidemias. And especially increase in the fiber, increase in the protein, increase in the, the non-saturated fats. You have to replace this with your carbohydrate content.
Yes, sir. Like the
for severe hypertriglyceridemia, the guidelines say that very low fat diet is recommended if the patient has predominantly hypertriglyceride as a abnormal lipoprotein, very low fat diet. But generally the carbohydrate content has got more to do with triglycerides rather than the LDL levels. LDL is more of endogenous production. LDL levels are not very much affected by the exogenous intake of our carbohydrates or lipids and proteins. But triglyceride levels are one thing which are affected more by the carbohydrate intake.
Okay, sir. Thank you, sir.
I think the next speaker is Dr. Nisho. She is an assistant professor, Department of Gynae, AIMS Bathinda. She is going to talk about the ovarian cyst. Do all need treatment? Dr. Nishu, please. She has done her MCH in this gynae oncology. Dr. Nishu.
Good afternoon, everyone, and I thank you for the opportunity and for the kind introduction. I am Dr. Nishu. I'm currently working as assistant professor at AIMS Bathinda, and I'm a gynecologist. And I'm here on the behalf of my head of the department, Dr. Laja Devi Goyal, and we'll be talking about ovarian cysts. Ovarian cysts nowadays, because of the increased accessibility to ultrasound modalities, we are often finding the reports of ultrasound showing ovarian cyst, which is increasing actually the apprehension of patients. So discussing it on the physicians forum, I would like to just simplify the things and say that majority of the ovarian masses which are incidentally diagnosed on ultrasound, they basically are benign, and majority of them, they do not need any treatment. But exclusion of cancer, because this is the cancer belt of the country, so exclusion of malignancy remains the principal aim, and management plan of such cysts, even if malignant, it depends upon the age, the symptoms the patient has, and the risk of malignancy associated. So the management in a younger age group is different than in older age group. To highlight, first of all, to classify the ovarian masses, ovary has various types of cells. So the masses, they arise from either of these cells. So most commonly are the epithelial cells, which is found on the epithelium. These are the surface epithelial cells, then the stromal cells, and then the germ cells. So epithelial cells, depending upon the histology, they can be serous, of serous type, mucinous type, endometrioid type or transitional cell type, and stromal cells, which also includes the sex cord cells and the germ cells. So in germ cell we can see they can be dysgerminomas, yolk sac tumors, embryonal carcinomas, choriocarcinomas or teratomas, and in sex cord stromal tumors they can be the ovarian neoplasms, they can be granulosa cell tumor, thecomas, fibromas, Sertoli cell tumors and likewise. So the ovarian cysts which are diagnosed on ultrasound, 80% of them, as already told, are benign. And the malignancies which are most common in the elder age group, they arise from the epithelial cells, so they are epithelial malignancies. And in younger age group, they arise from the germ cells, so germ cell malignancies. And a woman in life has a 5 to 10% risk of developing a cancer and undergoing surgery because of ovarian cancer. However, the most common gynecological cancer in the country is CA cervix, but ovarian cancer carries a significant burden because it is diagnosed at an advanced stage, because it remains asymptomatic till stage 3 in most of the patients. The differential diagnosis of an adnexal lesion, they can be many. They can be gynecological and non-gynecological. So gynecological, they can be benign as well as malignant, and benign, most common, they are just the simple functional cyst, that is the ovulation from the follicle and then the follicle is turning into a cyst. So they can be functional cysts, endometriomas, any abscess, teomases, because TB is endemic in our country. Reproductive age group, ectopic pregnancy, then dermoid cysts or the serous cyst adenomas, mucinous cyst adenomas, hydrosalpinx and some Mullerian anomalies. Malignant tumors we've already discussed, they can arise from either of the cell lineage. And non-gynecological masses, they can be benign, like in the adnexal location there is appendix, so it can be an appendicular mass or a diverticular abscess. Then tumors arising from the nerve sheath, that is schwannomas, urethral diverticulum. It could be an anatomical variation, that is a kidney from abdomen is now in the pelvis, so a pelvic kidney, any paratubal cysts or bladder diverticulum. And malignant non-gynecological conditions can be any GI malignancy, retroperitoneal masses and any metastatic lesion from elsewhere. Now whenever we encounter a mass, we go ahead with an ultrasound. TVS, because of the close proximation of the TVS probe with the target organ or transrectal probe with the target organ, it gives a very good picture. So TVS remains the first modality of choice, and on TVS, if it is a non-ovarian mass, we do the treatment accordingly. But if it is an ovarian mass, so ovarian mass, if it is solid and the size is more than 10 centimeter, so it is suspicious of malignancy, so we go ahead with tumor markers and we see the markers and perform the surgery accordingly. But if it is not solid and the size is also less than 10 centimeter, unilocular simple fluid filled cyst, anechoic cyst seen on the ultrasound, and if the size is also less than 10 centimeter, in a post-menarchal age group, that is a reproductive age group after menarche, we can wait for 2 to 3 months. We can give oral contraceptives to the patient. That will lead to ovulation suppression, and whatever the functional cyst, which is the most common cause, is there, it will go away with it on itself. But if the size is decreased, we have to do a follow-up. But if there is increase in the size of the same cyst, or there is persistence of the same cyst, then again we'll go with tumor markers, do a risk assessment and perform the surgery accordingly. And in a premenarchal age group, it is said in premenarchal, most of the ovarian masses, they are benign. So if the size is less than 10 centimeter, actually the size should be less than 2 centimeter. If it is 2 centimeter in a premenarchal girl, we can still wait. But if it is more than 2 centimeter, we have to go ahead with surgery. Also, in premenarchal age group, whenever means the menarche has not attained, that means there is no functioning ovary, no follicles are forming, but she still has a mass in the ovary. Then we need to do a karyotype of the patient, because if she is XY, she is carrying a Y chromosome, there is a risk of gonadoblastoma, that gonad turning into gonadoblastoma, later into malignancy. So we need to remove both the ovaries of the patient. Now, diagnostic workup of such masses, a thorough history and meticulous examination cannot replace anything in the medical history, and after which comes the imaging and investigations. So a thorough history. If she has pain, because malignant masses generally they do not present with pain. If she has pain and it is acute in onset, that means either the mass has ruptured or has undergone torsion, or if the pain is cyclical, that means every menstrual cycle she is having pain, which are associated with various conditions, like pain during menstruation can be because of endometriosis, pain during menstruation can be because of the cyclical dysmenorrhea she has. That means there is some blockage in the outflow tract and the blood is accumulating in the body and she is getting pain every time. Or there is abdominal distension, ek mass uske saath distension, that means there is something going on inside, so it could be a malignancy. If she has associated GI symptoms like a mass and vomiting or nausea or anorexia, that means either it is GI origin or the ovarian mass which has metastasized to omentum, and now that omental cake is pressing upon the stomach, causing gastroparesis and leading to vomiting. Other can be fever chills if it is an abscess. Menstrual abnormalities, of course, if the tumor is functional, like it is producing estrogen or it is producing androgen, then it will lead to menstrual abnormalities. Then any palpable mass, if she has already felt a mass inside, we'll need to ask. And very rarely urine retention. We came across a case last week at AIIMS Bathinda where a 20 weeks pregnant woman, she came with a 20 centimeter mass and we admitted her. We were planning to operate on her because it was a huge mass, 20 centimeter. And when we got an MRI done, it was a distended bladder. So 4-liter urine drained and she was all well, and she did not have any symptoms prior to the presentation also. So drug history. Drug history in ovarian masses is important because whenever a woman takes oral contraceptive pills, it is protective for ovarian cancer. So taking a Malwa N for 5 years leads to 50% reduction in the ovarian cancer. So any drug history is important. Then comes the examination. So we see the mass, we try to see the size, the feel of the mass, whether it is cystic or solid, whether it is mobile or fixed with other structures, it is nodular, or if it is bilateral or there is associated ascites or associated metastasis palpable through examination. Then comes the imaging. So the most common imaging is the ultrasound, and it outperforms all the other imaging modalities for an ovarian malignancy. And then comes the CT, MRI or PET. CT is basically to know the metastasis from ovary to the abdominal metastasis, and for MRI can delineate the gynecological as well as non-gynecological region, so we can know the primary. And also in uterine anomalies, MRI is very good, but PET is not an initial imaging for ovarian masses. Then pregnancy test needs to be ruled, pregnancy needs to be ruled out because it can be an ectopic pregnancy which is now palpable as an ovarian mass. Blood investigations, routine, and thyroid profile. A very rare von Grimbeck syndrome where a juvenile uncontrolled hypothyroidism leads to formation of multiple cysts in the ovaries. So the patient will present as a she will have retarded growth, delayed milestone, everything is delayed, stunted growth and short height, everything small, and then she has big ovarian masses. You correct the hypothyroidism and she will be all right. Then tumor markers, AFP, beta HCG, LDH, CA125, HE4 and CEA, and then karyotype, which we've already discussed. So this is the ultrasound criteria. There are B features and M features on ultrasound. So these are the B features. B means benign. So if such type of picture, any of the B feature is present and no M feature, that is no malignant feature is present, so the mass is likely benign. So first we see it is an unilocular cyst filled with black means it is anechoic filled with fluid. So this is unilocular, and even if it is multilocular, the size is less than 10 centimeter, likely benign. Then there should be preferably no solid component. Even if it is there, it should be less than 7 millimeter, and there is presence of acoustic shadowing. By acoustic shadowing, I mean that this is an echo-free area behind the mass, which denotes that it is likely benign because most of the sound waves going from the ultrasound, they are either getting reflected back or they are getting absorbed because of some hard structure present inside the mass. For example, in a dermoid cyst, because of the calcification, because of the tooth present, because of the cartilage, the sound waves are getting reflected back and we see an acoustic shadowing. So if acoustic shadowing is seen on ultrasound, that means it is likely benign. However, it does not rule out malignancy, because malignant features also, they have some calcifications and it can be malignancy. And then if there is no blood flow in the cyst, that means no neovascularization and no less chances of being malignant. Opposite are the M rules. Similarly, if there is even if there is one M present and no B present, so it is likely malignant. So first is irregular tumor, solid tumor, or a multilocular big tumor more than 10 centimeter, or there is presence of ascites, or if there are papillary structures in the ovarian mass, or if there is a strong blood flow. So we can classify on ultrasound. Then tumor markers, CA125, it is loved by everyone. Koi bhi mass ho, get a CA125. If it is raised, so people say, oh, malignancy hai, malignancy hai. But CA125 will rise in any of the peritoneal irritation. So even if a woman is menstruating, you get a CA125 will be raised. So the patients, they come with a simple cyst and raise CA125 fearing it is a malignancy. So this is what the talk is based on. So there are cutoff, but also CA125 is not a specific marker, not at all good for a premenopausal women. In postmenopausal, however, it is still significant, and the other markers are CEA, AFP, beta HCG and LDH. Then management, simply if the patient is asymptomatic, again simple cyst less than 10 centimeter, reproductive age group and no symptoms, we can still wait for 2 to 3 months because the chance of underlying malignancy is less than 1%. But if it is symptomatic or there is suspicion of malignancy, surgical management is very well required. Now, my talk is for the cysts which do not need any management. First is the functional cyst. Functional cyst means ova is released from the follicle and that follicle has now become a cyst. It is simple, anechoic, sonolucent cyst, asymptomatic, no treatment, because it is in the response to FSH, which is a normal hormone in the body. Then the corpus luteal cyst, because after ovulation there is secretion inside the cyst and this will form the corpus luteal cyst. It is thick cyst, it has internal echoes, but still it will go away in the next cycle and hence no treatment is required. Then theca lutein cyst, because of increased HCG production in the body, which is because if it is a multiple pregnancy, if we have a molar pregnancy, we are dealing with GTN, high levels of HCG are there in the body, so multiple cyst formation, they are bilateral and they also generally do not need treatment, but these are very big cysts, so chance of bleeding, that is hemorrhage, rupture and torsion. Parovarian cyst, these are formed due to some developmental remnants of the Mullerian duct. So these are parovarian, ovary ke side mein. Parovarian cysts, they also do not need treatment unless they are very huge. Then tubo-ovarian abscesses. Any abscess in the body has to be managed. So if it is a multiloculated, fluid density filled, thick walled cyst, which shows a typical cogwheel sign or string on beads appearance, this needs management and they are treated medically because they are mostly because of TB or infections. So treat the TB and infection and they will go away, and if not, they are not responding to medical treatment, surgical treatment may be required. And if there is a hydrosalpinx, that means tube is dilated. So we see a linear serpentine-like structure on the ultrasound, that is a dilated tube. Generally no treatment required, but if it is TB, then it has to be treated. Then if it is a symptomatic cyst, for in this patient, the cyst has undergone torsion. So we can see this ovarian ligament, this is the ovarian ligament, which has got 2 or 3 turns on itself. So if such situation happens, sabse pehle venous supply will go, then the arterial supply will also go, and then we'll be landing up with a necrotic ovary. So as soon as the diagnosis of torsion is suspected, emergency laparoscopy is required, and detorsion is sometimes only required. But if there is a long pedicle and you feel that it will again twist on itself, then we might hang the ovary somewhere in the, so surgical management is required for torsion. Then if it is a rupture, these are cases operated at AIIMS Bathinda. This is an interesting case, patient presented. I'll just show Few more slides about this case. So if any rupture is suspected, emergency laparoscopy if patient is stable, or laparotomy is done. And when there is suspicion of malignancy, then of course some surgery, like if it is early, then staging surgery, and if it is advanced, then interval debulking surgery. So combination of chemotherapy and surgery for such masses. So this is, these are the benign tumors which needs to be, these are the tumors which need to be removed. So first is the teratoma, that is dermoid cyst. Dermoid cyst contains all the cells from all the 3 germ layers. So we will find hair, cartilage, teeth inside the dermoid cyst, sebaceous material, and they do not respond to any treatment. We need to take them out. And if it is an epithelial tumor like serous or mucinous cyst adenoma, we also need to operate them. So how the investigations mislead us? This is, I'll just quickly discuss about 2 cases. This is a young girl, 21-year-old. She presented in the OPD with pain abdomen, but no menstrual complaint. She had a palpable mass in the lower abdomen. There was a lot of free fluid in the abdomen, and on ultrasound, bilateral masses, one 10 by 10 and another 6 cross 6. So big masses were there, and CA125 was very high, more than 4,000. So when CA125 is so high, we suspect बहुत सारी peritoneal metastasis leading to increased peritoneal irritation and increased CA125. UPT was negative, that is pregnancy test was negative, and clinically it looked like an advanced malignancy. But on opening, we in suspicion of this such high CA125, it was repeated and again it was high. On exploratory laparotomy, there was a lot of blood inside, blood sucked out, then both the cysts, they were ruptured. So the cystectomy was done, ovaries could be saved and the uterus also, and the patient could be saved. Another case, when all the more younger girl, 16-year-old girl presented with a tender mass up to 20 weeks. Again, menstrual cycle was regular. On ultrasound, again big masses, 15 cross 15 centimeter and 10 cross 10 with minimal fluid. CA125 was marginally raised, rest of the markers were normal. So we see big masses, and then on CT scan, if I can show, on CT scan there were also 2 low density masses, 2 masses are seen with thick walled. So we suspected 2 ovarian masses, and again we did an exploratory laparotomy on her, and it was a rudimentary horn of uterus. So she had a Mullerian anomaly. एक horn जो बना ही नहीं था, it was very large, filled with a lot of blood, and उसी side का tube twist होके दूसरी side जाके it was looking like another mass. So we excised the rudimentary horn as well as that side tube. Patient saved, uterus saved, opposite ovarian tube saved. So so the take-home message is that, again I'm saying that not to panic, not to increase the apprehension of patient, because most of the cysts are benign. However, detailed history taking, meticulous examination, accurate diagnosis is very important. Ultrasound is the first investigation. CT and MRI only if we are suspecting malignancy and masses of non-gynecological origin. And surgeries, nowadays fertility sparing surgery even for a malignant case in appropriately selected cases can be done. And in a younger age group, we preferably go for conservational surgeries, and for older age group, we perform radical surgeries. Thank you so much.
Very excellent talk.
Thank you, sir.
So I'm a physician, I have no idea about what is the ovarian cyst stage. So the discussion is open for any questions, any comments from the audience, please.
But I think your talk will be beneficial to the patients, because when we get ultrasound for some other disease, patient is going to ask you about 2-3 things. Intramural fibroadenomas or fibromas in the uterus, fibroids, and the cyst, both in kidneys as well as in ovaries. So a brief overview has told us that you can risk stratify at least from the appearance, when otherwise all the patients are going to go to a gynecologist and they can do it. But briefly we can also tell that this is a smooth cyst, as you have classified. This is maybe benign or it is malignant. So it is going to benefit the physicians also.
Yes.
Great lot. Thank you very much.
Thank you, sir. Thank you.
One thing I see, as you said, most of them are benign.
Yes.
I think you proved from your surgery also that you suspected malignancy and it turned out to be benign.
Yes, Yes,
So
sir.
that proves the fact that
Yes, but sir, one thing which is important in ovarian surgeries is the facility of frozen section. If on the table we are taking out a cyst and sending it for frozen section, that means pathologists, they can tell within 20 minutes the likely possibility of the nature of the cyst, which is correct up to 80%. So if frozen section, where I have done my gynec-oncology, so we used to send every patient for frozen section, and on the table we could decide whether to perform a radical surgery or whether to complete the surgery there itself.
Thank you very
sir.
much.
Thank you.
Next speaker is again one of our friend from Muksar, Dr. Madan Mohan Bansal. Sorry. Dr. Shafali Gupta, she has done her MD Pediatrics and DM in Medical Genetics. So she is going to talk about genetic testing. Dr. Shafali, please.
Good afternoon, everyone. Thank you for the introduction, sir. So before I start, I would like to thank Dr. Vitul K. Gupta, sir, for this opportunity to talk on this forum. So I'll be talking about the relevance of genetic testing in day-to-day practice, and I would like to cover all the specialities where the genetic testing would be helpful. So the overview of my talk would be, firstly, I would talk about why do we need a genetic testing. This would be followed by relevance across various medical specialities, and it will be a case-based scenario. Third would be overview of type of genetic disorder, and fourth would be overview of type of tests available for various genetic disorders. So now, why do we need genetic testing in routine practice? Definitely, we need it for an early and accurate diagnosis in many unexplained clinical conditions. Next is personalized management of various different clinical scenarios and the treatment decisions based on them. Identifying the at-risk family members as by cascade testing. Reducing other unnecessary investigations and healthcare costs, because sometimes chasing a diagnosis costs a lot to the patient. Then empowering the patients through informed choices, especially the reproductive decisions in the future. So first case was a family who came to me with an ongoing pregnancy and an abnormal HPLC, which was done by the obstetrician as a part of routine screening during her first checkup. So this lady had her third pregnancy at 8 weeks period of gestation. First baby was a term delivery, and the baby expired within 30 minutes of birth due to some respiratory problem, and probably it was HIE or birth asphyxia related. Second was a girl child around 5 years of age. She was well as per the parents, but there was visible jaundice, pallor and short stature in that girl. And third was this ongoing pregnancy. So one HPLC they already had. It showed an HbA2 levels of 29.5, and in general, if HbA2 level of falls between 25 to 35, we usually consider it as an HbE trait. So this lady was probably having HbE thalassemia trait. So her husband's HPLC was ordered, and it showed again an elevated HbA2 level of 6.4, which was suggestive of beta thalassemia carrier status. So as both the partners were carrier of some type of thalassemia trait, so there was chance of the baby having E beta thalassemia. So the mutation testing was advised to this couple, and the HBB sequencing revealed that the female, she was a carrier for a variant in HBB gene leading to HBE trait, and the husband was having beta thalassemia carrier status, so their mutation testing was confirmatory. Plus, the girl who accompanied the couple was examined. She had mild splenomegaly, short stature, jaundice, and pallor. So her HPLC was also done, which was suggestive of an elevated HbF, elevated HbA, and HbA2, and was suggestive of E beta thalassemia in this child. So this family was offered prenatal testing in the ongoing pregnancy, and they were informed about option of MTP if the fetus comes affected. Plus, the previous child who was diagnosed with E beta thalassemia, she was started on hydroxyurea and supportive care with long-term surveillance. Now, this was a really tricky case because they already had a child who was just newly diagnosed with E beta thalassemia. So we could not negatively counsel them about the E beta thalassemia status. Plus, they had to decide about the MTP if the fetus comes affected. So family took a lot of time, and finally they decided for a prenatal testing. So learning points from this case were that hemoglobinopathies are very common, especially in North India. Around 1 in 15 people, they are carrier for beta thalassemia in North India. So it is actually advised to all the couples to get tested for HPLC either prior to pregnancy or at least during pregnancy, so that if both the partners are carrier, and prenatal testing followed by continuation or discontinuation of pregnancy can be decided by them. Then as I told, preconceptional testing should be emphasized, and also at times it is difficult to inform the family to take the decisions about various pregnancy outcomes. Multidisciplinary efforts are required to manage such cases. Second was a family with repeated infant losses due to some intestinal malformation. So this family had a history of 3 baby losses. 2 were males and 1 was female. So as per the history they gave, first baby was a term male child born at a birth weight of 3.2 kg, which means a normal perinatal outcome, apparently well child, but had some intestinal malformation diagnosed at 3 months of age. Parents were repeatedly saying कि कोई बांध था, कोई जन्म से बांध था बच्चे की आंत में. The child was operated, but he could not survive. Next 2 kids, they had the same phenotype. That is, they died around 3 months of age with some intestinal problem. Now the thing was that they did not have any records. All the papers were thrown. They did not have any sample, any cord sample of the previous kids. So upfront, it was like we were thinking it could be a recurrent gastrointestinal congenital anomaly leading to this problem, or some Hirschsprung disease leading to repeated infant losses. Limitations was there were no records, no samples, no photographs, no clinical information. So a couple carrier screening was planned prior to planning next pregnancy. So to our surprise, both the partners, they were carrier for 1 variant of cystic fibrosis each. So the final diagnosis was cystic fibrosis for the previous 3 kids also, and prenatal testing via CVS was offered in the next pregnancy. So here the limitation was that there were no records, there was no documentation of meconium ileus, there was no documentation of the type of pathology which previous kids have. So hence it is very important that if second time the same problem happens in any baby, that couple should be offered a genetic testing so that this can be stopped here. And again, there was another family with the previous 2 baby losses, 2 suspected inborn errors of metabolism, and they came to us in pregnancy. So old records, they suggested TMS, which was having elevated metabolites, which are usually elevated in inborn errors of metabolism. Now this lady, she had a positive quad screen during antenatal period, which came out to be high risk for trisomy 21, 1:10. For this positive quad screen, she was offered an amniocentesis, and amniocentesis came out to be normal. But the important thing is that aneuploidy testing will only rule out trisomy 21, 18, 13 or chromosomal problem. It will not check about the previous babies that died of unknown cause. So the parents were counseled and a couple carrier screening was sent, which showed us a variant in the surfactant metabolism defect. So this variant was tested for in the fetus, and hence fetus came out to be negative. The fetus was heterozygous, 2 variants were not there, hence the fetus was normal and the family continued the pregnancy. This is another interesting case. This was a 40-year-old male who was referred to us from a psychiatry department. He had severe depressive illness, was on electroconvulsive therapy. He was referred in view of dysmorphism. There was a history of attempt to suicide and history of generalized tonic-clonic seizures in this male. On examination, this male had a relatively short stature. There was anti-mongoloid slant, which means that eyes were little down tilted. The ears, if we can appreciate, were low set. So this is the upper portion of the helix. He had a bulbous nose. There was a pectus excavatum. There were multiple cafe au lait macules, if they are appreciable in the picture. There were multiple freckles and there were some hypopigmented marks as well. So upfront from this phenotype, it was a case of rasopathy spectrum, Noonan syndrome. Other differentials were Coulon-Gievray syndrome. So the genetic testing confirmed the presence of a pathogenic variant in PTPN11 leading to Noonan syndrome. So why is this important in this case? Why do we need a genetic testing? Because there are many papers on genotype-phenotype correlation, which means that okay, this variant if present, the patient will have these features in excess. So papers suggest that personality and psychopathology in adults with Noonan syndrome is seen more often than normal population. So how does the management differs in this case? So general principles of depression are same, but due to multiple comorbidities like cardiac involvement in Noonan syndrome, developmental delays, patients need a personalized approach. For example, there can be pulmonary stenosis, hypertrophic cardiomyopathy, arrhythmias. So one has to carefully select the psychotropic drugs. One should avoid the drugs which lead to QT prolongation and avoid the agents which increase cardiac workload. Plus baseline ECG should be done before starting any new medication. Second is there are enhanced chances of bleeding diathesis or platelet dysfunction in Noonan syndrome, and SSRIs which are frequently used in a depressive illness, they can also increase the bleeding risk. So these things can be kept in mind. Then third is neurodevelopmental and cognitively. These patients can have intellectual disabilities, learning difficulties, ADHD. So psychotherapy needs to be adapted as per the patient's diagnosis, and involvement of family is critical. Another thing is that they have behavioral and emotional disorders like anxiety, social withdrawal, depression, ADHD, autism as compared to general population. And metabolism of some drugs, it is reduced in rasopathy spectrum disorders. Plus these patients, they have cognitive and communication deficits which may make it harder for the patient to express suicidal ideations. So these should be kept in mind. Next is a family with reoccurrent late onset cardiac disease. Around all the members in the family, they were having a cardiac disease at around 60 years of age. So this was a 60-year-old female. She was diagnosed as atrial fibrillation and dilated cardiomyopathy in 2022. She was managed medically for that. MI was ruled out. Her cardiac MRI was suggestive of features of DCMP, and there were no evidence of myocardial scar or fibrosis. But she had a significant family history of cardiac disease. So as MI was ruled out, she was presumed to be having post-COVID viral-induced DCMP. So here in this pedigree, this is the female I am talking about. her father had some heart failure at around 60 years of age. Father's brother, father's mother, and father's father all had history of heart failure. This lady's younger brother had coronary artery disease at around 40 years of age. So interestingly, in this family, her daughter, this is her daughter, she got tested for genetic exome sequencing, as her husband had some family history of disorder. This girl was pregnant, so they got a genetic testing done. And to our surprise, this girl carried a variant in the TTN gene, which leads to dilated cardiomyopathy. Although she was asymptomatic at that time, she was around 25 years old. So now this girl had the variant. Upon cascade screening, upon testing other members of the family, her mother had the variant leading to dilated cardiomyopathy. Younger brother of this lady also had the variant leading to dilated cardiomyopathy, but this brother was asymptomatic as yet. He was like 5 years younger to her. And this brother who had coronary artery disease did not have the variant, which means that these two who are asymptomatic, they are at risk of dilated cardiomyopathy at around 60 years of age. Both of them were screened, and the brother of this lady, he was started on prophylactic medications, beta blockers and ARBs, so that he does not develop the DCMP in future. Plus, this girl was kept on surveillance, especially during pregnancy, which is a high output state. So here, the proband could be offered better and confident care. Prognosis could be ascertained. For family members, screening, echo, beta blockers, and cardiac remodeling agents were advised after the age of 40 years. This was case 6. This was a 7-year-old girl who was referred to us from ophthalmology for high myopia and ectopia lentis, a displaced lens. So in general, we know that ectopia lentis means a Marfan syndrome. In general, we think that. But on examination, she had Marfanoid habitus, pectus excavatum, short stature, dark skin, sparse hair, blue sclera, deep set eyes, high arched palate, etc. But she had a short stature. So in the genetic causes of this ectopia lentis, there can be Marfan syndrome, homocystinuria, and sulfite oxidase deficiency. So this girl on further metabolic testing had elevated homocysteine, methionine, normal B12, echo was normal, Marfan syndrome phenotypic score was also less. Hence, probably this was not a case of Marfan syndrome, this was a case of homocystinuria. And it was confirmed via genetic testing. She had a homozygous pathogenic variant in CBS gene. So this girl was started on treatment of homocystinuria in the form of pyridoxine betaine therapy, and her homocysteine was regularly monitored. And she was also under surveillance for as per the guidelines, and prenatal testing for future pregnancies was advised to this couple. Then again, another case with a familial cancer. This was a girl who was having a renal cell carcinoma, and there was a family history of brain cancer in the paternal grandmother. So thinking about two malignancies running in a family, genetic testing was offered to her, plus she was a young female. So again, she was having this pathogenic variant in FLCN gene, and which means a Birt-Hogg-Dubé syndrome. This syndrome makes the person harboring the variant more susceptible to other malignancies also. Hence, she was put on additional surveillance for any lung cyst, more contralateral renal tumor, and parotid, thyroid, or breast cancers in the future. So in the interest of time, I'll skip this case. I'll just tell about the type of genetic disorders and tests the clinician should know. Genetic disorders can be due to problem of a full chromosome, that is full chromosome is absent or extra, or a big deletion or duplication, they are known as chromosomal disorder, or it can be due to a ATGC change, that is a point mutation, which is single gene disorder. Full chromosome like Turner syndrome, Down syndrome, and single gene disorders like thalassemia. So what are the tests which are available for chromosomal disorders? We all know we can do a karyotype, chromosomal microarray, FISH, MLPA or QFPCR. And for the single gene disorder, we can go for Sanger and NGS depending upon our suspicions. So how is the role in the treatment and prognosis? So targeted therapies can be given if diagnosis has been made. Prognostic insights like in SMA, we can prognosticate the patient. We can avoid harmful treatments. For example, some drugs are contraindicated in some genetic variants. And then nutritional interventions can be offered. So when to suspect a genetic basis? In case we have many affected family members, some atypicality is there, patient is not responding, then we can think, okay, this can be some syndrome. How to choose the genetic test is purely based on phenotype. What are our differentials? Based on that, we can choose the test and can be referred for opinion. And genetic testing is just a tool and it is not a last resort. So to conclude, genetic testing is no longer the domain of a research. Every clinician should suspect and do appropriate workup to enhance diagnostic accuracy, improve the outcomes, and empower the patients through the thoughtful use of genetics. And with increasing accessibility, it is becoming indispensable part of everyday medicine. Thank you.
Thank you, madam, for a very extensive sort of a talk on genetics. I think most of the diseases or syndromes you have mentioned, probably they are not very common, you see, in general practice. So as a physician, probably I think the only role is wherever you have a recurrent abortion, you have somebody died early or in the family history, unnatural, you see.
Yes,
one should be very careful, and then there is the need for a physician to work it out further, you see, to rule out the underlying reason, whether it is related to genetics or not.
Yes.
The other thing is, again, genetic labs and the genetic sort of disease testing, they are not easily available at each and every place. I think probably PGIMR, probably the one institute in northern India where probably you are doing all these tests, you see. They are not in the reach of a common man.
Yes.
So.
Actually, sir, this is the biggest myth. I mean, they are available everywhere. They can be sent from everywhere because there are many private labs. They are even offering it at a cost lower than PGI or AIMS. So they are available everywhere. And second thing is about relevance. As they were not very commonly used earlier, they are very new into, clinical use. Like in the case of cardiomyopathy, I told sir, that female was getting managed as post-COVID DCMP. So their genetic testing could help the other relatives of hers who were relatively unaffected at that time. So. Plus her invasive testing like CT angio to rule out a coronary artery disease, etc., that could be deferred as cause was.
I definitely agree with you. This is lack of awareness, and you can say that people don't know where the genetic testing should be done and the patient can benefit. So I think large number of patients who need genetic testing, they are just going here and there taking treatments, not knowing what is happening.
Yes, sir.
As you know, I consider myself, genetic chapter was most difficult chapter, and I never touched it. And I really compliment any genetist that your brain is larger than life.
Oh, no.
Because all these, chromosomes and the names you are telling, so they can be forgotten in just 2 seconds. So I must compliment your degree as well as your education in genetic testing. And we will, whenever I find any, I will keep 2-3 lectures of yours on different aspects of generating awareness among the doctors about genetic testing, where it can be done and whether it is expensive or not, it is cost effective. So I must compliment you for your overview of the lecture, which made at least me aware of genetic part. Thank you very much.
Thank you, sir. Thanks so much.
So So friends, after genetics, the last lecture of today is Dr. Madan Mohan Bansal. He is MD Consultant Physician, Shri Guru Nanak Hospital, Muksar, and his talk is Approach to Unknown Poisoning, which is very common in this part of the country in Punjab. Dr. Madan Mohan Bansal, please.
Thank you, Dr. Vitul and the organizing committee. After listening to such a beautiful talk on genetics by Dr. Shefali, it's a very common topic among physicians, and unfortunately in post-lunch session, I hardly see any physicians available here, the few. But anyhow, the topic lot to me is this, so I go into this topic for my talk. The father of toxicology, Paracelsus, defined that all substances are poisons. The right dose differentiates poison from a remedy. If we go to the toxic epidemiology of poisoning in Indian population, a 10-year meta-analysis showed that out of the all cause of poisoning, pesticides constitute 63% of the all poisoning cases. And if we go back in studies from Punjab, I could not find any new data from any chemical lab. They said it's not being given to common people. And in year of 2016-17, out of 2,000 samples studied in a lab, out of this almost 50% were of aluminum phosphide and 40% were of organophosphorus poisoning. There has been earlier seen a very increasing trend of deaths due to pesticide poisoning in Punjab till 18. After that, I don't know the figures, maybe the incidence gone down because a lot of migration of youth from Punjab to overseas countries, because suicides were quite common among youths earlier. General management of acute poisoning. I will be covering under resuscitation and initial stabilization, diagnosis of type of poison, prevention of absorption, enhancement of elimination, specific therapy by antidote if it's there, and supportive care. The first and foremost part is resuscitation and initial stabilization, which comprises basically the ABC, airways, control of breathing, taking care of oxygenation, maintaining of circulation with fluids or vasopressor wherever they are required. Earlier investigation of metabolic abnormalities and ABG is very essential in such patients. Sometime in comatose patients, and the coma cocktail comprising of dextrose 25 or 50%, oxygen at high flow rate, naloxone, which is very useful in opioid-induced coma, is common. Then in alcoholics, thiamine has also been found very useful. Flumazenil is another drug which has been useful, found in earlier time at immediate admission to the emergency in patients of benzodiazepines toxicity. For the diagnosis of type of poison, if we go by the toxidromes, various toxidromes, we can be early detect the type of poison, like cholinergic toxidrome in opiates and carbamates, anticholinergics in datura-like compounds, adrenergic in amphetamine-like compounds, opiates and narcotics toxidrome. The earlier cholinergic toxidrome, as the undergraduates remembered, like all muscarinic effects, they remember by Dumble, diarrhea, urinary incontinence, meiosis, bradycardia, bronchoconstriction, lacrimation, and the nicotinic effects. The important one are weakness of the muscles and tremors, weakness of the muscle leading to respiratory paralysis. Anticholinergic toxidrome are important in datura-like poisonings, atropine-like poisonings, flushing, dry skin, mydriasis, confusional states, urinary retention, and tachycardia. Adrenergic toxidrome, patient is very agitated, having tachycardia, hypertension, hyperthermia, sometimes can have seizures also, and psychotic behavior. Narcotic toxidrome, so common, opiates and other opioid-like synthetic drugs. Patient having meiosis, altered mental status, shallow breath, bradycardia, and hypotension, hypothermia. Withdrawal toxidrome with alcoholics and benzodiazepines and opiates, again very common presentation. having mydriasis, diarrhea, tachycardia, lacrimation, hypertension. Seizures are very common in ethanol or benzodiazepines withdrawals. And initially you can identify some of the toxins from their characteristic order also, and like garlic kind of a smell in organophosphates compounds, rotten egg with sulfur dioxide, and systemic examination, the neurological examination in patients for poisoning is very patchy involvement. So instead of the other, like we do neurology examination in other comatose patient in suspected poisoning, just keeping 4 simple words: alert, verbal response, painful response, or unresponsiveness. You can just go on to measure these simple things for such patients. Meiosis pupils are very helpful. Meiosis used in cholinergics, opiates, sedative hypnotics, and mydriasis in anticholinergics and withdrawals. Seizures are very common in the earlier stage in organophosphates, oral hypoglycemic agents, amphetamines, and ethanol withdrawal, and lithium poisoning patients, and also in lead poisoning patients. We commonly see lead poisoning because of, again, indigenous drugs used by the youngsters. 3 lab investigations or gaps are very helpful in toxicology: anion gap, osmolar gap, and oxygen saturation gap. So anion gap, increased anion gap is seen in patients who especially having a lot of metabolic acidosis with methanol and ethanol and salicylates poisoning. It's again very helpful in identifying underlying poison. Osmolar gap is very helpful, and it's especially useful in emergency in patients of with unaltered sensorium, because there are some it measures the measured osmolality and minus calculated osmolality. You can measure the calculated osmolar gap. It's increased because of the osmotically active substances in the blood. It's very useful early diagnosis of methanol or ethanol poisoning. Methanol poisoning recently has been very common in some parts of the Punjab. Oxygen saturation gap, especially helpful in carbon monoxide poisoning, where there is a difference of more than 5% in the saturation of ABG and the co-oximeter. Urine tox screen test is helpful these days. The DOP test, which commonly is done in several hospitals for examination, it's helpful sometimes, especially in opioids and some other drugs which the individual may be using and having its toxicity. So in the treatment, the prevention of absorption in the initial stages is very important. Apart from a decontamination and the prevention of absorption from the gastrointestinal tract, gastric lavage, which was very commonly done in earlier stages. So no clear-cut evidence of clinical benefits have been shown in retained drug patients, and only in patients who have a very toxic substance and has ingested very recently in 1 hour, it's most helpful in those patients. Some of the contraindications to gastric lavage means corrosives, hydrocarbons, toxicity, coagulopathies, or loss of airway reflexes, because again gastric lavage is associated with many complications. Sometimes it increases the admission to the ICUs. Techniques of gastric lavage, everybody knows. Only small aliquots of liquid, normal saline or water can be used for this. Activated charcoal has been recommended. Again, the beneficial is again in the first hour. It's not recommended in metals, alcohols, or hydrocarbons. Whole ball irrigation has been useful only in substances who are enteric-coated drugs, slowly dissolving drugs, ingested packets of illicit drugs. Then we come on to enhanced elimination. Methods are urinary alkalinization and multi-doses of activated charcoal or extracorporeal remover with hemodialysis or hemoperfusion. Urinary alkalization, it's more helpful in salicylates, phenobarbital, or lithium compounds of poisonings. The usual method with IV fluids, glucose with soda bicarb, but be careful of hypokalemia in such patients, and it is again contraindicated in patients who are in shock, hypotension, renal failure, or in congestive heart failure. Extracorporeal remover, hemodialysis is very useful in many of toxic substances, especially where there is a low volume distribution, the toxin having low protein bounding, high water solubility, and is useful in alcohol, salicylates poisoning, barbiturates poisoning. Hemoperfusion, the toxin which are having lipid solubility, it's more useful, it's a extracorporeal removal method. There are specific antidotes, like we have atropine and PAM for OPC poisoning. We have certain other, like flumazenil for benzodiazepines, naloxone for opiates, fomepizole or ethanol for methanol poisoning. Supportive therapy is always the key. Antidotes are only for few toxins. Treatment is largely supportive. Aim is to preserve the vital organ function until the poison is eliminated. Therefore, support of function of systems and prevent complications the mainstay. Monitor the fluid, electrolytes and acid base very closely. Few of the common specific poisoning in our area, the OPC and carbamates and organochlorous compounds are very common. Typically, we see muscarinic, nicotinic and CNS effects and OPC and carbamate poisonings. And organochlorous compound poisonings only we see CNS effects, muscarinic and nicotinic effects are not there with organochlorous compounds. Mainstay of treatment in OPC poisoning remains decontamination and atropine bolus dose followed by the dose till atropinization is achieved. The only thing is it should be very withdrawn, gradually withdrawn, maybe up to 72 or 96 hours. Early withdrawal of atropine leads to recurrence of symptoms which can be fatal. Pralidoxime, initial as early as possible should also be used. 1 gram initial dose followed by 0.5 to 1 gram 6 hourly for next 24 hours. These are not required in carbamate, so be careful for this also. Aluminum phosphide poisoning is very common poisoning and having a mortality, high mortality which can occur within 12 hours of ingestion. Patient presenting with the common symptoms of nausea, vomiting, having garlic odor, rotten fish odor. Early hypotension and shock is very common. It's due to because of extensive capillary damage leading on to hypovolemia and decreased cardiac output. It's a directly myocardial toxic drug. Because of the pulmonary hemorrhage leads to early ARDS, leading to metabolic acidosis, hypokalemia, hypomagnesemia, and even calcium levels are also very low in aluminum phosphate poisoning. So very early treatment has to be started. Gastric lavage with mild oxidizing agent can be done with KMNO4, followed by copious lavage with soda bicarb. This will help that we are not loading the patient with soda bicarb. We have to take care of this. Early fluid therapy guided by CVP should be done. Inotrop should be used as per requirement. This drug leads to a lot of cardiac arrhythmias because of direct myocardial toxicity. So arrhythmia specific therapy, magnesium sulfate is very helpful in these patients, should be used early. Initially we can give 1 gram, then followed by every 6 hourly. Calcium gluconate and KCl as per the serum concentration should be given. Then comes the ARDS, which is with the oxygenation and ventilation. Methyl alcohol, the huge tragedy which is commonly occurring in areas of Punjab, it's very common poisoning these days now. Initially the patient is having mild drowsiness, then abdominal pain, vomiting, leading to again when acidosis comes, cosmal respiration, papilloedema, and seizures, eye involvement, direct retrobulbar neuritis can occur, coma and death. So treatment again, fomepizole is not available in India. Cost is very high for a 15 milligram dose per kg body weight. A 15 milligram ampule of 1500 microgram ampoule almost costs $1,000 US. So it's a very costly drug. It's not available in India. In India, apart from the large amount of IV glucose, vitamin B1 and B12, with metabolic acidosis correction with soda bicarb, the mainstay lies here is ethanol. So patient of alcohol poisoning is being treated with alcohol here. So ethanol, because of very high affinity for the enzyme ADH, alcohol dehydrogenase. ADH has got 15 times more affinity for ethanol as compared to methanol, because methanol lead on to converted to formaldehyde, formic acid, which leads to acidosis and the complication. Again, IV ethanol is very not commonly available, and you have to monitor the ethanol levels also therapeutically around 100 milligram per deciliter. So oral ethanol is given in such patients. You can give oral ethanol with Ryle tube around 50%, almost all ethanol alcohols are available with 40 to 50% of the ethanol. So we can give around 2 ml per kg is the dose. You can mix it with the fruit juice and can be given. Here hemodialysis is as early as possible, especially when patients in coma, having seizure or visual loss or leading to visual disturbances, so that you can prevent the death in such patients. So take home points: treat the patient, not the poison. Identifying the poison with the toxidrome is the key to diagnosis. Resuscitation and initial stabilization is most important step. Coma sometimes can be life-saving. Thank you.
Thank you very much, Dr. Bansal, for an enlightening talk. I think the poisoning is most important in Punjab region.
Yeah.
Other part, especially that you have mentioned the methanol poisoning. So it occurs every 1 or 2 months and a lot of people die.
Yeah.
And thank you very much for an enlightening talk.
Thank you.
And I think this will be the last session, because I have not heard from Manish Gupta and Dr. Bharat Bhushan.
Thank you.
If they are in the audience, please let me know. So then we are closing this second days of scientific session. And I must thank all the audience, all the speakers, as well as our online audience who is listening to us online on YouTube, as well as our registered delegates, that is almost about 150 delegates. So yesterday we had about 600 online visuals. So I expect the same as today also. So thank you very much, especially our most dedicated delegate, Dr. Pramod Goyal. I think he will achieve the feat of getting the prize the last day of most hours attended. Thank you very much, everyone. Thank you. See you tomorrow with exciting new scientific session for day 3 and day 4.